Court is now sitting.
Good morning.
Morning, Your
Morning, Dr. Dwyer.
Morning, Your Honour. Your Honour will see that we have our panel of expert psychiatrists assembled this morning, and we'll swear them in, starting with Professor Nordentoft. I just note that Professor Nordentoft is coming to us online. I'll just check that the Professor can hear us.
I can hear you.
Good morning, Professor Nordentoft.
And might I also note how grateful we are for Professor Nordentoft coming to us at what is 1 a.m. her time. So she is essentially pulling an all-nighter to be with us today on screen for the remainder of the time today. I think she's available until 2:30 p.m. today, which is all night her time, all morning.
Professor Nordentoft, we're most grateful that you've made yourself available at this very inconvenient hour of feeding. And I must say I'm grateful to all of our experts. I know it's been a very short turnaround time for all of the reports that you've prepared, and thank you in anticipation and already for your assistance in this inquest.
So I just note for the record, Your Honour, the panel are Professor Merritt Nordentoft, Professor Edward Heffernan, Professor Anthony Harris, Professor Olive Nelson and Professor Matthew Large, and I call the psychiatric panel and ask that they be sworn in.
Thank you.
Good evening, Professor Nordentoft. Can you hear us clearly?
Yes, I can.
Thank you. I understand that you're looking to take an affirmation. Is that correct?
Yes.
Thank you. I'll swear you in. Silence, please.
Thank you.
Do you solemnly and sincerely declare and affirm that the evidence that you shall give will be the truth, the whole truth, and nothing but the truth? If so, please say I do.
I do.
Please stand up for me. Just face one up. Silence, please. Do you solemnly and sincerely declare and affirm that the evidence that you shall give will be the truth, the whole truth, and nothing but the truth? If so, please say I do.
I do.
Thank you.
Do you swear by Almighty God that the evidence that you shall give will be the truth, the whole truth, and nothing but the truth? If so, please say I do.
I do.
Do you swear by Almighty God that the evidence that you shall give will be the truth, the whole truth, and nothing but the truth? If so, please say I do.
I do.
Do you solemnly and sincerely declare and affirm that the evidence that you shall give will be the truth, the whole truth, and nothing but the truth? If so, please say I do.
I do.
If I might raise briefly one matter.
Yes.
I would seek leave this morning to appear on behalf of Dr John Riley, who is the Chief Psychiatrist of Queensland. Dr Riley has a statutory mandate to assist and promote an understanding of the Mental Health Act in Queensland, and he has made himself available to watch today's evidence and will intend to furnish a statement as soon as possible, just assisting in relation to the legislation in Queensland, and will make himself available if anyone wishes to examine him in the first half of next week.
Certainly, thank you. Ms Rob, leave is granted and I'm grateful to Dr Riley.
Thank you, Your Honour.
Dr Dwyer.
Your Honour, might I just spend some time, firstly, to go through some of the qualifications, particularly because this panel is being recorded and there is significant interest in the community in the qualifications and opinions of each of the psychiatrists. Starting with you, Professor Nordentoft, you have kindly provided an expert report which appears at tab 14 of our bundle. You prepared that expert report at the request of the Crown Solicitor's Office to assist Her Honour. You note in that some of your background and experience. I won't be able to do it justice, as is the case for each of our 5 panel members, but you're a Professor of Psychiatry at the Department of Clinical Medicine, University of Copenhagen. Is that correct?
Yes, please.
You are the Director of Research at the Copenhagen Research Centre for Mental Health, otherwise known as CORE. What is that service?
It's a research centre based at the Mental Health Services in Copenhagen, in the Center for Mental Health Services, Copenhagen. It's a large research unit consisting of 50 people, many of them who have worked with patients with schizophrenia, both with regard to trying out different primarily psychosocial intervention, but also register-based studies and long-term follow-up studies of cohorts. So I have had, through that work, insight in long-term prognosis for schizophrenia, and also the proportion who are able to discontinue medication without relapses, and also different adverse events in patients with schizophrenia.
On that topic, we note in your background that you have had extensive clinical experience with disorders within the schizophrenia spectrum, and you've conducted 250 interviews using the schedule for clinical assessment in neuropsychiatry. You are one of 2 certified World Health Organization experts in SCAN, SCAN, that is the schedule for clinical assessment in neuropsychiatry. One of 2 WHO experts in Denmark. What is SCAN?
SCAN is an extensive diagnostic interview which is developed in the WHO, and it's used in countries all over the world. And in each of the countries, there are people responsible for being experts in those diagnostic interviews and providing training courses, treatment and assessment of interviews.
Within your background, it notes that you have significant experience in assessing homeless individuals. You've interviewed 160 homeless people living in shelters or on the streets in relation to their mental illness. Could you tell Her Honour about that study?
Yeah, it is a long time ago. It was in the 1990s, but I did interview, I led a study where we interviewed 200 homeless people in shelters. I did 100 of these interviews, and then I also did a study with 59 people on the street, where I did also interviews. And it was interviews with regard to their life history, the background for homelessness, and also diagnostic interviews.
We'll return to the issue of homelessness in relation to Joel Cauchi and the possible impact of homelessness, and what has been written about that previously by Professor Large and Professor Nielsen. But could you tell us what the conclusions of that study were?
Well, what I found out was that a large proportion of the homeless people, both in the street and in the shelter, suffered from mental illnesses. In the street, it was rather severe mental illness. Many had schizophrenia, not being treated for many years. They had it was very severe form of schizophrenia. In the shelters, there were also many cases with severe schizophrenia and substance abuse. And those who had contact with the mental health services, they had it mainly because they were forensic patients. Very few had contact with mental health services on their own initiative.
Was there a conclusion reached that there was a link between schizophrenia and homelessness and vice versa? So did schizophrenia often cause homelessness, and did homelessness exacerbate the symptoms of schizophrenia?
Yeah, I think I can say yes to both. Definitely schizophrenia could cause homelessness or could contribute to the development of homelessness. For some of the people, it was their delusional experiences that led them to leave their houses or to believe that they have paid the rent by a non-existing satellite or things like that. So they had definitely schizophrenia, and the symptoms associated with schizophrenia had led to homelessness for for a large proportion of these people. And on the other hand, I think that homelessness also contributed to exacerbating schizophrenia. It was not homelessness that caused schizophrenia. I don't think I could state that.
Did it flow from those findings that it was important to provide appropriate supported accommodation for people with schizophrenia?
Could you repeat that?
Certainly. Did it flow from those findings that it was important to the people of Denmark to provide supported accommodation for people with schizophrenia to prevent the worsening of symptoms or to manage the disease?
Yeah, I think that of course it was a small drop. The contribution from these studies were not at that time very influential. I was also a very young doctor, but I think it played a role, and it has since other people have done similar. Also, people in my group who have done register-based studies where we could see that all the disadvantages of being homeless and all the risk of the becoming homeless associated with mental illnesses. We have had the opportunity to conduct register-based studies of homelessness in Denmark, which is very rarely possible, but we have a register of people attending the shelter, and therefore we can follow them and see how many of them will have mental health contacts before they become homeless and also afterwards.
And Professor, I will return to that issue of what Denmark has done when we come to look at some recommendations in Australia. But before I leave you for the moment, you were president of the Danish Psychiatric Society from 2021 to 2025. As president of the Danish Psychiatric Society, you were an advisor for the National Health Agency, is that right?
Yes, we were a large group of people invited for the Danish Health Agency to give advice regarding a 10-year plan for psychiatry. So I played a role in that, and it has just been launched and decided.
That is the 10-year plan for psychiatry for Denmark has just been launched and decided.
Yes, it was just earlier this week. It was the Parliament decided how to fund the 10-year plan for psychiatry, and there is in it a psychiatric team for homeless people.
Then, Professor Nordentoft, included within that role was you being appointed to a Ministry of Health task force investigating the conditions that led to a mass casualty in Copenhagen, Denmark in July 2022, when a young man in a severe psychotic state killed 4 people and wounded many others in a mass shooting incident in a shopping mall. Could you please tell Her Honour, firstly, what was the nature of that investigation and what were the key conclusions?
It was an investigation initiated by the Minister of Health, who wanted the society to learn as much as possible from this very sad event where 4 people died and many people were wounded. And they wanted to learn as much as possible, and therefore this task force was formed.
And was there a report that flowed from that task force?
Yes, there was a report and some recommendations.
Did the report note that there were, or find that there were any missed opportunities to help the young man who had committed those terrible acts?
Yes, there were several missed opportunities. One was about diagnosis. It has, between the psychiatrists, been discussed whether this man had schizophrenia or autism. It ended up with a recommendation on more thorough training of psychiatrists in psychopathology. So to be aware of subtle symptoms or hidden symptoms, I would indeed say, because they were not that subtle, but they were not revealed. So that was one recommendation. Another recommendation was more continuity of care, because for this man, he had actually had contact with mental health services, but he had seen many different people. And even though it was evident that he has had thoughts about attacking and killing someone, he didn't reveal it. At some moment he tried to reveal it, but he spoke to 14 different people for the last 6 months before he finally did this attack. And one conclusion was that if we should hope that somebody should confide and tell about very scaring impulses, it would be needed to build trust so that the person would feel safe in trying to reveal violent impulses.
So am I right, Professor, that ultimately it was determined that that young man had experienced schizophrenia rather than autism?
Yes.
And that... Sorry, please go on. Sorry.
Yeah, and I think that has been confirmed. During the trial, and when he was also observed for whether he was suited to have an ordinary punishment in prison or whether he should be treated as a forensic patient. And he is now treated as a forensic patient, being given treatment for severe schizophrenia.
I will return to that study potentially when we look at the issues of masking some symptoms and the ability of patients to do that on occasion, and the issue of continuity of care. Dr. Heffernan, I should ask you to please state your full name for the court.
Yes, my full name's Edward Bonaventure Heffernan.
You have, where are you currently working?
I'm currently working in Brisbane, Queensland as the Director of the Forensic Mental Health Service.
You've prepared an expert report, again at the request of the Crown Solicitor's Office, for the assistance of Her Honour, and your report sets out your background, as do your colleagues, but what is involved in being the Director of the Queensland Forensic Mental Health Service?
So I have clinical responsibilities, so usually clinical leadership, direct clinical care of people who have usually severe mental illness and have been involved in contact with the criminal justice system in one way or another. I also provide supervision and mentoring to other psychiatrists, and also have a clinical governance responsibility, so cases get escalated to me for advice about the treatment, management and ongoing care of individuals with mental illness who have contact with the criminal justice system.
And Dr. Heffernan, to summarise some of your experience, you've had 2 decades working with people with a mental illness or over that time, and people who encounter the criminal justice system as a result of committing violent offences while they're suffering from serious mental illnesses.
Yes, so I've worked consistently in prisons, sometimes in courts, sometimes in high secure units, sometimes in the community with people who are at risk, look like they're at risk of offending or have offended and are on an order for that offending.
You have been involved in incident analysis, reviews, coronial matters, and investigations of tragic, often very violent matters involving people with mental illness in a number of different Australian jurisdictions over the years as part of your work.
Yes, that's correct.
You have co-led the establishment of the police and mental health services in Queensland over the past decade, and we'll come to that when we look at the interaction that Queensland Police have with Mr Couchy. You're currently the clinical lead of the Queensland Police Communications Centre Mental Health Liaison Service that we've already heard much about. How did you come to be the co-lead for the establishment of the police and mental health services in Queensland?
Well, in around 2014, there was a number of significant tragic events that highlighted the need for enhanced communication between mental health services and police. And one of the ideas that had been proposed was to actually place clinicians inside the police and ambulance 000 call centres to assist in real-time exchange of information, governed and protected by memorandums of understanding to protect the confidentiality of individuals, to help assist the outcomes for those individuals, and to also help enhance the police knowledge when they were attending, or the ambulance knowledge when they were attending to that first response, and also to help communicate what was happening in the community with the health system.
Is there a continual review of whether or not Queensland Police are getting the best possible assistance in their dealings with mental health patients or people in the community?
Well, I can talk about the reviews of the Police Communications Mental Health Liaison Service. So there was an evaluation done of that service, and it was positively evaluated, and out of that it has been recurrently funded. And then there's been several studies looking at the prevalence of mental health calls, the challenges that people face before the call, what happens in the incident, what happens after the incident, and all that data and information has led to the Queensland Government, through the Better Care Together funding, to expand the service, which is currently in process now.
Do you still have a role in reviewing those processes, Doctor?
Yes, most days.
Before I move on, I just want to note this, that you're a member of the Queensland Mental Health Review Tribunal, Deputy Chair of the Psychiatric Medical Assessment Tribunal, and a Professor in the Faculty of Medicine at the University of Queensland. Dr Heffernan.
Yes, that's correct.
And other qualifications set out in your report. Professor Anthony Harris, seated to your right. You've also prepared an expert report at the request of the Crown Solicitor's Office. Professor Harris, you're a Professor of Psychiatry and the Head of Specialty of Psychiatry at the University of Sydney, is that right?
That's correct.
You've been practising for over 3 decades.
Yes.
And your area of practice includes community youth mental health, and a particular area of research interest is schizophrenia and the associated psychosis, is that right?
Correct.
Professor, you're a Senior Staff Specialist in the Prevention, Early Intervention and Recovery Service. What is that service?
That is a youth mental health service that is part of the Western Sydney Local Health District. It provides youth mental health services to people with a moderate to severe illness, aged between 12 and 25. Eye care for people who are in the more adult part of that age spectrum. The service covers the Hills, Parramatta, Marylands and Auburn areas, with a population base of about 550,000 people.
So you have both a clinical and a research interest, as do your colleagues, is that right?
Yes, and a teaching role as well, of course.
And with respect to the area of schizophrenia and associated psychoses, can you tell Her Honour about some of your work there?
Yes, so I have been involved in a series of pieces of research that cover areas of neuroimaging, of treatment with medication in pharmacological trials, of treatments, particularly with psychosocial treatment called cognitive remediation therapy, aimed at improving the cognitive symptoms of people with schizophrenia, and that's the primary part of that research with people with schizophrenia.
So I won't be able to do justice to any of the qualifications of our panel, but you're also a director of Mind Australia. That's a leading non-government organisation specialising in the care of seriously mentally ill people in the community, including their housing. Have I got that right?
Yes, I am.
And how long have you been a director of that not-for-profit organisation?
I've been a director of Mind since January of last year, January 2024. However, I am there as I was a member of the Schizophrenia Fellowship of New South Wales for approximately 25 years, and that organisation merged with Mind to form a larger national organisation in January of 2024.
What are the objectives of the organisation?
Quite simply, the objectives are to make the lives of people with severe mental illness better, as they're stigmatised, and the services that are provided within this country nationally are not up to the task.
Are there different standards of services available throughout Australia for people who suffer from a severe form of schizophrenia?
Yes, and that's one of the difficulties. The services are very varied. They're inequitably distributed. The system is well, there is very little in the way of a true system for care, and the services available are sometimes only available according to your financial means.
And does that organisation, Mind Australia, aim ultimately to try and standardise those services and provide a higher standard of care?
Yes, that's the aim of the services. The aim of the organisation is to improve the level of services and to provide them in as many places as we can.
I might come back to you when we look at the services available to Joel Couchy in Toowoomba versus Brisbane, and then what might have been available to him in New South Wales when we look across that spectrum. But before I do, one of the series of questions I'll ask the panel about is about guidelines in relation to the treatment of severe forms of schizophrenia, and particularly those persons on Clozapine. Are there different guidelines applicable in the different states and territories of Australia?
Each state has some guidelines in regard to certain specific areas, such as the initiation of Clozapine or maintenance. Those guidelines tend to be quite similar. However, overall, the guideline that I think we should be referring to is that written, published and held by the Royal Australian and New Zealand College of Psychiatrists in 2016.
And we will come to that guideline, but before I come off it, is it the case that that guideline is in a state of review currently?
That's correct.
Perhaps an apt time for this panel of 5 experts to offer their opinions on it. Professor Olav Nielsen, you have also prepared an expert report at the request of the Crown Solicitor's Office on behalf of Her Honour, so the 4th report prepared at Her Honour's request. You're a psychiatrist at St Vincent's Hospital and the Professor of Psychiatry at Macquarie University. Can you tell Her Honour how long you've been practising for?
Since 1993, so 32 years. Anthony and I studied together.
I see. And you have, as your other panel members, a research interest and also a clinical interest. I want to come to both of those before I come to your public advocacy on housing for people with a mental illness. In terms of your clinical work, could you outline it, both currently and prior?
Yes, I mean, I've got an old guy's private practice with, a cohort of long-suffering patients. I've been doing a clinic at the Matthew Talbot Hostel, which is a sort of walk-up service for people who have experienced homelessness or risk of homelessness or are sleeping in the open, as is often the case, for the last 18 years. And about half of the people who come to that clinic, not half the people who are homeless, but half the people who come to that clinic have persistent psychotic illness. Before that, I worked for about 15 years in prisons, which are kind of like our new asylums, and coming to the Matthew Talbot, it was just an extension of the criminal justice system. A large proportion of the people I've seen there rotate in and out of prison. I did 10 years on the Mental Health Review Tribunal, reviewing, on the forensic side of it, reviewing release orders for forensic patients, and they're typically tragedies that might have been prevented. I'm a consultant at Mindspot Clinic, which is at Macquarie University, which treats anxiety and depression online, and have a teaching role there as well, and have students come to the homeless sector.
Dr. Nielsen, or Professor Nielsen, you have the private clinic you refer to is the level 8 practice, is that right?
Yes.
That you see private patients at that clinic?
Yes.
And then you see public patients through your work at the Matthew Talbot Hostel?
Yes.
And the Matthew Talbot Hostel, am I right, provides both an accommodation service. Is it a short-term accommodation service?
Well, it's ostensibly 3 months, but they're pretty liberal with it. But it has shrunk terribly, and all the hostels have shrunk. So the availability of hostel accommodation has been greatly reduced, including since COVID.
We'll come to this when we talk about the availability, but just since you raised it, I think you say in your report some statistics about there used to be 1,300 beds. There's now, in the course of in the number of about 300. But can you remind us of the exact statistics and the way that's changed over the decades?
Yes, yeah. Well, when I was training at St Vincent's, one of our service provided outreach services to the 4 big hostels. Matthew Talbot was the biggest, which had 450 residents. Now it's got 66. So, and the decline from 1,100, I estimated, to less than 300,
Yes.
exactly coincides with the number of people who sleep in the open in Sydney every night, in the inner city Sydney every night. So that's, I don't know if it's probably more than a coincidence.
Just to be clear, that's the number of beds available has reduced, not the number of people.
That's right, yeah. There's
Going to
now
those. 300
hostel beds, whereas there was once at least 1,100, and our census shows us about 750 people sleep in the open in the CBD.
What's the reason for that reduction in beds?
Occupational health and safety, a preference of the staff, the funders. The funding is partly philanthropic, but it's also partly from Communities and Justice, and they considered the dormitory beds to be of too low a standard, even though it's shelter.
So where the Matthew Talbot beds have been reduced, no equivalent service has picked up those persons?
Not that I know of, not to those numbers, that's for sure.
We'll return to that issue, but is that, Dr Nelson, partly the driver for you founding Haberless Housing?
Well, yes. I mean, the driver really, I suppose I've seen the model operating because I did sort of provide a clinic at a boarding house early in my career, which was very successful. No one was readmitted to hospital if they were treated. But have conducted some research with it's now about 3,500 individual people I have on a database through our homeless service. And what was alarming about that research was the number of people who'd lost public housing accommodation, which should be like owning a house really, to have that kind of a lease. And it's because they just lack the skills without the supports, and they were very predatory, some of these public housing estates. So the model is small clusters of supported housing. It's actually very like the housing provided by the organisation that Professor Harris is part of, which is the Haven Foundation in Victoria, which is merged with Mind. And I'm hoping to replicate a similar model in New South Wales. And in fact, it's exactly the model that was envisaged by the Richmond Report of 1982, but we had other priorities.
So just to flag before I move on to Professor Large as our final panellist, I will come back to this issue of the deinstitutionalisation in Australia and the Richmond Report, what the aim was at the time in terms of community housing, what has become a shortage in the aims not being fulfilled, and your work, Professor Nielsen, at Haberless, and your work, Professor Harris, at Haven. I note, before we leave you, Professor Nielsen, that you're a member of the College of Psychiatrists committee that was engaged to develop the guidelines for the treatment of schizophrenia. Are they the guidelines that Professor Harris referred to earlier that are now dated 2016? Yes,
they're... Yes, that's one. They're a bit out of date, I suppose, but they're not that there's been that much new, in fact. But my contribution to that, or the reason that I was drawn onto that committee, was in forensic topics, but also homelessness and treatment of chronic psychosis.
We will return to that. Professor Large, you've prepared 2 reports. They were prepared at the request of the legal team that appears for Dr. Borislavak, is that right?
Correct.
And Professor Large, I'll come to your qualifications very shortly, but there was just one correction that I think you wanted to make with respect to your second report, is that right?
On Tuesday night when I was reviewing my materials, I noticed that my point 92 in my second report has a typographic error, and it relates to Mr. Couchy's first application for a firearm licence. And at point 92, I say that it was November 2012, but it's actually 12th of November 2001. It's actually also, that's the correct, that's at point on page 1951. It's simply a typographic error on my part. And in my formulating my opinion, I did know that first application was in 2001 and not in 2012.
I see. Would you mind, do you have your report in front of you, Professor?
I do, yeah.
Could you just read to us the whole of the sentence as it should read now with that correction?
Sure. If you just give me 2 seconds.
Please.
I apologise for this.
Not at all.
latent dyslexia has got the better of me. So point 92 should read, the medical record includes a letter from the Weapons and Licensing Branch of the Queensland Police stating that Mr Couchy's application was awaiting determination and that more information was needed about the injury or illness after an application by Mr Couchy to the Queensland Police in November 2012, but it should be November 2001.
So just to make clear, we know that Mr Couchy made an application for that licence in 2001 and made a further application in 2021. And unsurprisingly, we will return to that issue.
And the final sentence was, there is no evidence in the file that the health service provided information to the police. I couldn't find any.
Thank you very much, Professor Ladge. Just returning to your qualifications, you're a senior staff specialist psychiatrist and the medical superintendent of mental health services at the Prince of Wales Hospital in Sydney.
That's correct.
You, like your colleagues, have both a clinical and research interest and also an advocacy interest, which I'll return to. But could you please tell Her Honour how long you've been practising and your areas of interest?
I've been a psychiatrist since 1995. I've got a very broad range of interests. So clinically, I have worked in private practice a little bit at the beginning of my career, but I'm very much a public psychiatrist. I've alternated between working in inpatient wards.
Sorry, Professor, could you keep your voice?
Sorry.
Thank you very much.
I've alternated between working in inpatient wards and emergency departments. You can't work in emergency departments for more than a couple of years without needing a bit of a break. And I've done community and acute care community work as well. My clinical interest really is in schizophrenia and psychosis, because that is the core of public psychiatry, and the reason I left private practice partly was because I found it so difficult to look after the disorders I was most interested in. My research has been quite broad and interests have been quite broad and have been shared with a couple of people on the panel here.
Yes.
My primary interest has been suicide. There was a period when I published a large number of papers about homicide with Dr. Nielsen.
I'm so sorry, Professor. Can I just stop you? With the rain that's coming down on the roof, it's more difficult to hear you. So
Try to be loud. Sorry, I feel like I'm speaking loudly, but everyone else tells me I'm quiet. I've got an ongoing interest in cannabis and psychosis, and was the chief investigator in a very influential study that showed that cannabis use brings forward the age of onset of psychosis in 2011. And I've got an ongoing but continuing to do cannabis research. And I've also got an interest in Clozapine, and was a co-author and did the statistics for 2 articles that have proven to be quite influential in the dropping of the requirement for blood monitoring for Clozapine in the United States, a reform that hasn't actually happened here.
are you able to provide those articles, and are they attached to your...
They're not attached, but I could easily provide them.
Thank you very much. And we'll return to that issue when we come back to the guidelines. You are a conjoint professor in the discipline of psychiatry and mental health at the University of New South Wales, is that right?
I am, but I'm employed by the hospital.
And Professor Ladge, I referred to your advocacy work, and in fact, you and Professor Nelson have researched and written together about risk assessment and suicide, is that right?
Extensively.
And one article that was published by both of you appeared in the Sydney Morning Herald shortly after the tragedy that unfolded at Bondi Junction on the 13th of April last year. It was an opinion piece, Schizophrenia and Homelessness Can Be a Deadly Combination. You share Professor Nelson's concern about the exacerbation of mental health issues, particularly schizophrenia and psychosis, by homelessness?
Yes.
Your Honour, may I tender that article?
Yes, that'll be Exhibit 6.
I've got copies if anybody would like to read it over the break. I should say that the sub-headline or the byline is... Sorry, the byline is that it's written by both of you, and the title is Schizophrenia and Homelessness Can Be a Deadly Combination. homicide of strangers by people with schizophrenia is extremely rare, but we can reduce the risk by fixing our homelessness crises. That's something that you feel passionate about. Is that fair to say, Dr. Ludge?
There are lots of things I'm extremely interested in. It's a very fascinating area to be working in, and homelessness is a terrible problem for people with schizophrenia. I think it's not inconceivable that homelessness can cause schizophrenia, actually, or can be a contributory factor. I can't see why that wouldn't be the case for some people. It's, I think, extremely stressful being homeless, and we know that psychosocial stresses of all sorts help bring on symptoms. It wouldn't be the sole cause ever. There'd have to be a whole lot of other things. But more importantly, it's really almost impossible to have treatment for schizophrenia if you're homeless.
Unless, of course, well, I withdraw that. Does that underscore the need for services like Haven and Habilis that can provide a treatment model within the accommodation service?
Yes.
Before we move on to the particular circumstances of Joel Cauchi, I'm going to ask some general questions about schizophrenia and the way it can present, the need not to stigmatise all people with schizophrenia, but the risk that the severe forms of the illness present. I don't imagine that there's a lot of controversy, so I may not go to all of the panel in relation to this, but can I start with Dr. Heffernan, set out in your report at paragraph 2.4, page 4. You note, of course, that schizophrenia is defined in the DSM-5, the ultimate textbook for psychiatrists, as characterised by 5 key features: delusions, hallucinations, disorganised thinking, grossly disorganised or abnormal motor behaviour. I withdraw that. I'll just ask you, what's meant by motor behaviour?
So physical behaviour, physical movements.
Which might include, for example, is it tics or agitation or odd presentation of your body?
That can be, yes.
And then the 5th one is negative symptoms that are predominantly a feature of schizophrenia. We have heard a discussion about positive symptoms, negative symptoms and cognitive symptoms of schizophrenia. Doctor, I think those are well understood, but might you give just a broad outline of what you can expect from positive, negative and cognitive symptoms?
Yes, so positive symptoms are probably the symptom spectrum that most people are familiar with when it comes to schizophrenia, and they're things like hallucinations, delusions, disorganised thoughts, and the disorganised behaviour that's manifest from those 3 entities. So that's the positive symptoms. The negative symptoms are really, and the neurocognitive deficits are really the things that contribute to the psychosocial adversity that's associated with schizophrenia. So the negative symptoms include a lack of motivation, a reduced ability to express emotion, reduced thought production, and a poverty of speech, and also reduced ability to experience pleasure in activity. So that's the negative symptoms. And the neurocognitive deficits are really a spectrum of deficits, and they relate to things like verbal processing speed, again, thought processing, and they also relate to things that we do with our frontal lobes, like sequencing, organisation, abstraction, and planning. And these, of course, are really important things in our day-to-day life. And so when we think about schizophrenia, often people focus on the positive symptoms of schizophrenia, but often the things that cause a really significant psychosocial disability are the negative symptoms and the neurocognitive deficits.
And so we know that there are different severity levels of schizophrenia, but in treating somebody who comes to you with a diagnosis, are you aiming to address each of those 3 areas, to eliminate positive, negative and cognitive symptoms if possible?
Yes, that's right. It is I mean, elimination is perhaps a strong word. I think really what we're focusing to do is target all those areas. So positive symptoms are often treated well with psychological treatments, but also medication treatments. And the neurocognitive deficits are often treated well with certain therapies, and there might even be medication that can assist there. And, you know, the negative symptoms are treated with largely psychosocial interventions, but there is a limited amount of evidence that some medications, such as aripiprazole, might enhance the negative symptoms. So the idea is really to have a multidisciplinary team involved in the treatment of schizophrenia, so you can target the biological, psychological and social components that those three deficits combined cause.
Professor Nordentoft, you're listening to all this. I take it you can hear your colleagues?
Yes, I can.
You've just heard Dr. Heffernan outline the treatment aims and the modalities that are available. Is that the same in Denmark?
Yes, it is. I think there's agreement all over the world that medication can play a role, especially for psychotic symptoms, hallucinations and delusions, and that that might be some limited effect also on negative and cognitive symptoms, but psychosocial intervention would be the key issues for those issues. For cognitive remediation could play a role for the cognitive symptoms, and for negative symptoms it would be something like social skills training and comprehensive care.
Professor Nordentoft, I'm going to come back to you in one question. So if you could just hold for one moment. What you also go on to say, Dr. Heffernan, just to be clear, at paragraph 2.5, I'm just going to summarise this so we can move on from the general. Certain criteria must be met for a diagnosis of schizophrenia to be made. First, 2 or more of the 5 features that I read out of a psychotic disorder must be present for a significant proportion of time during a 1-month period. Second, there must be a decline in function, such that from the onset of those features, the person experiences a disturbance in their social, occupational or self-care functioning that is demonstrably poorer after the onset of symptoms. Third is the duration of the condition. There must be evidence of the first 2 criteria being present for at least 6 months. Fourth relates to the exclusion of other relevant mental disorders. And the 5th criteria relates to the exclusion of substances or a general medical condition being relevant causes. I'll pause there. So you would have to ensure, for example, that somebody who is exhibiting very strange behaviour and appears to have motor disturbances does not in fact have another diagnosis like an autism spectrum disorder or something else. Is that right?
Yeah, yes, that's correct. So psychosis, for example, is a final common pathway of a number of things that can affect the brain, one of which is schizophrenia.
The onset of schizophrenia can include a prodromal period whereby some of the symptoms become evident but manifest in a less pervasive or attenuated nature. By some of the symptoms, could that include agitation, anger, confusion?
Yes, and commonly also includes things like a change in motivation, a change in apparent interpersonal interaction, and a change in the level of function.
Your last sentence of this paragraph is that schizophrenia is a severe psychiatric disorder that is usually chronic, has a relapsing, remitting course, and may lead to persistent symptoms throughout adult life. Are there varying degrees of schizophrenia? That is, can people have a mild form of that disease?
There are. Schizophrenia is a spectrum, and that spectrum is characterised by people who have a first episode of schizophrenia and can recover and actually have full recovery. Then there are people who have recurrent episodes of exacerbation of schizophrenia but inter-episode recovery. Then there are people who have recurrent episodes of schizophrenia and poor inter-episode recovery, and then there are people who have just persistent stigmata of schizophrenia.
Professor Nordentoft, does this tie into what you say at paragraph 38, which is this: at least 1/3 of people with schizophrenia experience complete remission of symptoms. Some people with schizophrenia experience worsening and remission of symptoms periodically throughout their lives. Others, a gradual worsening of symptoms over time. It's a spectrum. Are there any, you say at least a third experience complete remission of symptoms. In those circumstances, would there be a need for follow-up?
Yes, but I think there will be many cases where it's not happening. There's 1/3 who achieve remission of psychotic symptoms. Actually, in some cases, it's even more. Some of them are still being treated with antipsychotic medication, and that's the reason for the remission. But we also see cases where it's possible to taper out antipsychotic medication and who do not receive and who do not have a relapse of psychotic symptoms. But that's a group. It has been described also in recent papers. It is around 20%.
Dr. Heffernan, before I move on to the others, I just want to talk about, to address this issue of statistics and then give the panel an opportunity to comment. At paragraph 2.2, when you're explaining to us what schizophrenia is, that it's a brain disorder associated with those symptoms, you say this: the most comprehensive study in Australia estimated the 12-month treated prevalence in the public mental health services of people with psychoses was 4.5 people per 1,000 population. Over 90% of individuals with a psychotic disorder will have multiple episodes, relapses, or a chronic condition, and the impact of their inter-episode function varies significantly from mild to severe. Does it follow that once there is a psychotic element of schizophrenia, there's a much greater risk of relapse?
Firstly, I'm just to explain that study. So that's the survey of high impact psychosis. So that's the biggest study that has been done in Australia. What it doesn't reflect, of course, is people that are homeless or out of treatment. So just to make that point, because these are people that are in treatment, a survey of people in treatment. And then could I just go back to your question? Would you mind?
Please. So you offer this statistic. Over 90% of individuals with a psychotic disorder will have multiple episodes, relapses, or a chronic condition, and the impact on their inter-episode function varies significantly from mild to severe.
Yes, that's restating what I said earlier, and that was the findings in the SHIP study, meaning that it's a smaller percentage of people that will have a full recovery and not have symptoms of.
I see. So your last sentence there is that schizophrenia usually requires lifelong care and treatment, including the use of antipsychotic medication. Are you referring there to all forms of schizophrenia?
I'm using the word usually very deliberately, because there can be times when people have a full recovery and don't need ongoing treatment. But in the majority of circumstances, as was evident through the SHIP study, people will have a spectrum of ongoing symptoms for the rest of their life, from mild to severe. And I would argue that all of those forms on that spectrum require a varying amount of input from mental health services and a varying amount of mental health care.
Professor Large, is there anything that you wanted to add or change on that?
A couple of things, actually. So schizophrenia can't be diagnosed without the presence of psychosis. So you have to have had psychotic symptoms to be diagnosed with schizophrenia.
I see.
And schizophrenia does exist on a spectrum, but it is itself a serious disorder. So people with mild schizophrenia may still be quite disabled. So there's something that might be mild within the spectrum of schizophrenia might be a very significant problem. And in fact, the threshold for diagnosis of schizophrenia is quite high. You have to be disabled by it. So with respect to the SHIP study, about 50% of people with schizophrenia were treated primarily by their general practitioners, not by specialist mental health services. The point prevalence of schizophrenia internationally is thought to be about, it varies a bit, but it's thought to be about 6 per 1,000 or 0.6%. There are 28 million Australians, so that would imply that there were about 165,000 people with schizophrenia. Now, I can't find a study that looks at adherence to schizophrenia that shows that more than 70 or 75% of people are adherent. So, people don't take their antihypertensives, they don't take their anti-diabetic medication, they don't even always adhere to cancer medication, and schizophrenia is not that different. And by that measure, there are probably today around 50,000 people in Australia with schizophrenia who are not currently receiving antipsychotic treatment. They may be having other treatments, but they're not currently receiving antipsychotic treatments.
I'll come to the severe form shortly, but Dr. Nielsen, is there anything that you wanted to add to that?
No, I agree pretty much with the numbers from Dr. Large, Professor Large, and I see plenty of untreated people with schizophrenia in the homeless sector, coming to the clinic and refusing to have treatment, but not really being good candidates for involuntary care. And also agree with the comment earlier that it's very hard to provide ongoing care for someone who doesn't have a place to live.
I'm just, again, staying with the general rather than Joel's diagnosis, about which there might be some conjecture, but all of the panel refer to a condition known as treatment-resistant schizophrenia. Dr. Heffernan, again, you described that as a commonly defined as a failure to respond to 2 or more antipsychotic medications given in an adequate dose for at least 6 to 8 weeks. Clozapine is the medication indicated for treatment-resistant schizophrenia. It's generally considered, along with other aspects of treatment, care and monitoring, that this should be lifelong medication, and that if it is ceased, the risk of relapse and readmission are significantly increased. Both the Royal Australian New Zealand College guidelines and the American Psychiatric Guidelines for the Management of Schizophrenia recommend that patients with treatment-resistant schizophrenia be treated with clozapine. Dr. Nielsen, do you agree with those opinions?
Definitely, yes. Yeah, no, it's well. Firstly, I'd say schizophrenia. All schizophrenia is treatment-resistant, really. If you fully recover in all respects, including functional recovery, after having had an episode of psychosis defined by having had a delusional belief, then it's not schizophrenia.
Yes.
Schizophrenia has residual impairment. But however, it's the more severe impairment and the presence of continuing active symptoms that leads you to say it's a treatment-resistant form of schizophrenia. But yeah, clozapine is the best we have.
And do you agree with what is set out by Dr. Heffernan, that it's generally considered that clozapine should be a lifelong medication, and if it's ceased, the risk of relapse and readmission are significantly increased when you're dealing with treatment-resistant schizophrenia?
Almost definitely, because especially in Australia, where there's a little bit of a bureaucratic threshold to initiating clozapine, so we have really reserved it for people with more severe forms. Those patients are the ones with the greatest chance of relapse, and also have, in the course of forensic practice, come across quite a few very severe and catastrophic relapses of people who'd previously been on clozapine, putting aside this case.
I will come to that. I'll come straight back to that, actually, Dr. Nielsen, but I'll just go to your colleagues. Dr. Harris, do you agree with that outline in Dr. Heffernan?
Yes, I do.
And Professor Nordentoft, do you agree? Is that the situation in Denmark that is both I'll start with the definition of treatment-resistant schizophrenia, the failure to respond to 2 or more antipsychotic medications given in adequate dose for 6 to 8 weeks?
Yeah, I would agree in that definition. And within the panel, we have had some discussions whether we could consider Joel Couch's case as treatment-resistant or chronic, because he actually, after 8 or 10 years, responded. So in that way, you could say it was not completely treatment-resistant because he was able to respond on medication. So in that way, it is a chronic condition, but he was actually responding to Clozapine.
I might just pause that. I'm going to outline for the panel different symptoms that Joel experienced, positive, negative and cognitive, throughout his time in the public sector up until 2020 and thereafter. So if I might just put a pin drop in that and come back to you, Professor Nordentoft, about it. Can I just ask you about the general statements in relation to the treatment for TRS, or treatment-resistant schizophrenia? Dr. Heffernan said it's generally considered, along with other aspects of treatment, care and monitoring, that Clozapine should be a lifelong medication for treatment-resistant schizophrenia, and if it's ceased, the risk of relapse and readmission is significantly increased. Is that the situation or the opinion widely shared in Denmark?
Yes, generally it is shared, but it does not exclude to try to reduce the dose, and it does not exclude that you, in some cases, because of side effect, could try to replace Clozapine with something else, with some other kind of antipsychotic medication. But generally, Clozapine is the drug of choice in severe cases where other forms of treatment does not work, and it is generally recommended to have it for a very long period.
Professor Large, did you want to say anything about that? I accept that there is different view in relation to Joel, and I'll come back to that. But generally?
So a lot of patients do come off Clozapine. Mostly they take themselves off. It is often associated with relapse. But Clozapine causes myocarditis, hepatic problems, gastrointestinal problems, and hematological problems. So it's actually not all that rare for patients to have to come off Clozapine. There's also another group of patients who are, in a sense, although they're treatment resistant, are too sick to be on Clozapine, because you have to be able to adhere to regular blood testing, and who won't take oral medication. So our most severely unwell treatment-resistant patients are often on high-dose intramuscular, second weekly, monthly, up to now 3-monthly injections. So our most severe and most treatment-resistant patients are actually not on Clozapine.
In circumstances where your most severe and most treatment-resistant patients are not on Clozapine, are they on another form of antipsychotic medication?
They're on long-acting intramuscular antipsychotics that are not as effective as Clozapine, but do provide some sort of muting of the extremities of their illness, and provide, I think, quite modest protection. I mean, there's a very high rate of comorbid substance abuse among patients with schizophrenia, estimated to be 60% in some studies. Mostly cannabis, but unfortunately also stimulants in Australia, and tobacco, of course. And medication provides some modest protection against the use of illicit substances. While talking with my patients about this, I say that medication is like a mini moke, and methamphetamine is like a Mack truck. It's really, you have to be quite concrete in your explanations, so our most severe patients are in and out of hospital on involuntary monthly injections of antipsychotic medication. They're too unwell to have Clozapine and use substances, and they're not a small cohort.
But Professor Large, do I take from including in what you said that the relevance of other antipsychotic medication is not just managing symptoms of schizophrenia, but it might be that it prevents some of those patients going back onto illicit drugs?
I don't think that there's some evidence actually that Clozapine does reduce the use of illicit drugs. I don't think there's evidence that other antipsychotics reduce the use of illicit drugs, but they may blunten their effects somewhat.
Just want to come to the risk of relapse, because Dr. Harris, Professor Harris, you deal with this in your report. Taking Joel as an example, and I'll return to the specifics, you say this: at paragraph 4.2, the decision to reduce Joel's Clozapine dose from very high levels was appropriate. At paragraph 4.3, although I would have preferred for Mr. Couchy to remain on Clozapine in the range of 300 to 400 milligrams a day, augmented by a low dose of aripiprazole, Abilify, such as what he was on, the decision to try or cease of his medication was not unreasonable. You go on to say schizophrenia is highly likely to relapse in the absence of a maintenance dose of antipsychotic medication. And the best medication to select for the maintenance treatment is usually the one that has stabilised the person at the dose they are able to tolerate well. And then you say discontinuation of antipsychotic medication is accompanied by a very high relapse rate, estimated to be up to 77% in 1 year and 90% at 2 years, compared to a relapse rate of those people who were maintained on medication of less than 10%. Can I suggest to you, are we right to read that statement, Dr. Harris, as a strong piece of advocacy for maintaining a patient on an antipsychotic medication that they have been demonstrated to tolerate well, where they've experienced a severe form of the disease?
Yes, it is, and it's something that I think most psychiatrists would strive to do. However, in the situation where a patient is competent and wishes to discontinue medication because of the burden of adverse effects, then at times it is best, in my view, to cooperate with the patient and manage a slow and staged withdrawal.
In those circumstances, is it important to explain to the patient what the benefit and risk is of the disease? So, for example, some patients will experience severe side effects on Clozapine or other antipsychotics. Other persons will experience very mild side effects. If the risk of relapse is 90% within 2 years, in those circumstances, you'd be explaining that very carefully to the patient, wouldn't you?
Yes, very carefully.
And to their family.
And to their family, and to try and bring to them as an individual person what the balance of risk as against benefit of coming off medication. The risk of relapse and perhaps rehospitalisation or loss of the progress that they've made thus far in their recovery, as against coming off the medication, not having to have continued blood tests, continued close monitoring, and the release from the side effects, which are considerable from Clozapine.
Dr. Heffernan, do you want to add or address any of that evidence? Would you agree?
I'd agree with you.
Dr. Nielsen, are you in agreement with Dr. Heffernan?
Yeah, and Dr. Harris, yes.
Sorry. And Professor Nordentoft, you've listened to 3 of our Australian psychiatrists so far. Are you in agreement with that position?
Yes, generally. But I would like to mention that in Denmark, in the Copenhagen area, we have a deep prescribing clinic where people who'd like to try whether they can taper out of antipsychotic medication are offered closely supervised tapering of the medication. And some people are actually, even after many years, able to taper their medication off, but then they are followed for at least 18 months to see if there's any sign of relapse. The majority cannot taper off, but what happens when you do that very carefully and in collaboration with the patient is that the patients actually get a higher level of acceptance that this treatment is needed. So that can be a positive effect of this collaborative effort to try to see how low dose can you actually still still have control over the symptoms.
What's meant by close monitoring in that context? Or does it differ for each patient?
Yeah, it means weekly contacts. And I think we will maybe come back to that. I think it's important with continuity of care because I think most people can actually, in an interview, state that I'm okay. And that's not enough. You need to have a close collaboration and where you are able to assess symptoms and the patient has confidence in you so that symptoms can be revealed. And it will need to be a thorough assessment.
Professor Large, I'll ask you to comment on Professor Nordentoft shortly, but Professor Harris was the original report I started with at paragraph 4.4, discontinuation of antipsychotic medication he offers is accompanied by a very high risk of relapse rate, estimated to be up to 77% at 1 year and 90% at 2 years, compared to a risk rate of those persons who were maintained on medication of less than 10%. Do you have any comment on that in a general sense?
Look, I agree with that, but what it does indicate is that 77 on 90 is just a little bit beyond my powers of computation on the witness stand. I could probably do it off the stand, but a very high proportion of the relapses occur in the first year. More than 80% of more like 90% of the relapses occur in the first year.
Just before we have a morning tea break, I just want to finish with the general lessons about schizophrenia. Professor Nordentoft, you remind us about the importance of not stigmatising persons who suffer from schizophrenia, and no doubt your Australian colleagues feel the same way. You say in your report under the subheading Key Facts that stigma, discrimination and violation of human rights of people with schizophrenia are common, and you impress on us the importance of not stigmatising the vast majority of people living with the illness of schizophrenia who will never go on to harm anybody else. Is that right?
Yes, that's definitely right. I've been also interviewed on television when we have these rare occasions where people with schizophrenia kill somebody. It does happen in Denmark. It happens approximately once a year. And all the time I stress that it's a very small proportion who actually go on to do something as bad as killing somebody. And for the vast majority of patients with schizophrenia, they are not dangerous to others.
And no doubt when there is one of those horrific acts, it makes it very difficult for those living with schizophrenia and their families sometimes to feel the pain of that.
Yeah, so in those cases, we're trying to protect the majority who are not dangerous, but also stress that the mechanisms behind those who are dangerous to others is usually psychotic symptoms. So it is often delusions that you are being followed and somebody is trying to harm you, and therefore you need to protect yourself. So that's the most common mechanisms behind dangerous behaviours of the people with schizophrenia.
Accepting that and the very significant importance of not stigmatising the vast majority living with schizophrenia, can I deal before the break with the very small percentage of people who do go on to harm others, often catastrophically? You say this, Professor Nelson, at paragraph 32, most people with schizophrenia will never commit an act of serious violence, but a disproportionate number of homicides are committed by people with psychotic illness, usually because of the effect of acute symptoms of mental illness. Most victims are family members and people known to the patient. The homicide of strangers by people with schizophrenia is a rare event, occurring about one in New South Wales every 2 years or so. Professor Nordentoft just said one a year in Denmark. You referred earlier, Professor Nielsen, to your knowledge of a number of patients who experienced psychoses, who had come off the drug Clozapine and had gone on to commit a homicide. Is that right?
Yes.
Are you aware of the numbers just that you know of over the last decade or so?
Well, just off the top of my head, 3 cases came to mind, which are, notorious cases. One was in a hospital, a psychiatric hospital, of a person just readmitted. I'm not sure if any of those were amongst the homicides of strangers. Oh, actually, one was. Now I think about it, the one at Manly. The study of the homicide of strangers that Professor Large and I did with colleagues in Finland, the Netherlands and Canada, and the reason we did a multinational study was there were just too few cases really to get a signal. But we were then able to approximately or to estimate how frequent it was, and it was rare. But the feature of the of that small group were that they were more likely to be homeless. And the being homeless probably was a signal. It was indicated a loss of continuity of care and perhaps more severe or more prolonged illness.
And again, we'll return to that in the recommendations. But in relation to the group, the very small number of people who have a mental illness with an element of psychosis who go on to kill others, were those three persons, the perpetrators, persons who had been taken off Clozapine?
No, I think all three cases they had decided themselves to stop and stopped abruptly. And a feature of Clozapine is it wears off very quickly because it has a low affinity for the dopamine receptors. It's an unusual drug in that regard. It makes it in some ways more tolerable from a neurological point of view, but it does also means that it wears off. And the fact that we rely on people to be adherent to oral medication does create a limitation of its use.
Is Clozapine capable of being delivered by depot medication?
Yes, it is. There has been a preparation, but of course our blood monitoring would forbid it because once you get a low neutrophil count, which is one of the worries, you can't remove it from your body for the next month or so. And I think that's one reason we hadn't considered it. It might be an innovation that might come to the United States now that they've taken a different view of the risks, but the answer is no.
You're looking to Professor Large there because he's been involved in the FDA guidelines in America. So that is an issue we will return to. Dr. Nielsen, you attach an article to your report which is entitled Rates of Homicide and Homicide Associated with Severe Mental Illness in New South Wales between 1993 and 2016. It was written with a number of colleagues, including Professor Large, and the findings in that were that between 1993 and 2016, the number of homicides not associated with mental illness in New South Wales had declined, but the number of homicides associated with somebody suffering from mental illness had remained the same. Is that right?
That's correct, and it's. I mean, they're too small a numbers really to say. Well, it's due to our to failures of our or the poor performance of our mental health system. But that's definitely the implication. When you look at a homicide rate that's gone from 2 per 100,000 to 0.7, one of the lowest in the world, and yet our the proportion and number of homicides by people with schizophrenia has remained exactly the same. That does look like a problem.
The finding of yourself and Professor Large in that report was that nearly all of those homicides, 88.7% of those found not guilty by reason of mental illness, had schizophrenia-related psychoses.
Yeah, it's probably even higher, I think. And then, of course, you're looking at some people with epilepsy or dementia, and that's the other small group. But it's the way our law is framed, it's people with schizophrenia.
The conclusion that you both reached was that the fall in conviction for homicide rates in the last 24 years has not been matched by a reduction in not guilty mental illness homicide verdicts. More assertive treatment of emerging psychoses and comorbid substance use disorders and improved continuity of care of chronic psychoses might prevent some homicides.
Definitely, yes.
Your Honour, is that a convenient time to break?
Yes, we'll take the morning adjournment and come back at 11.
Silence, please, we'll stand.
Your Honour, I'm about to move to the topic of Mr Cauchi. Before I do, just by way of timetabling, would you want to take the lunch break at 12:30 and consider a 45-minute lunch break so that we could return at 1:15 and hear from Professor Nordentoft? If I haven't finished all of my questions by then, I might focus on Professor Nordentoft so we can get her expertise before she's got to leave us.
Certainly. Excuse me, just one moment. We're just having some recording issues.
I see.
Do we need to reboot? Shouldn't take long. I think we're ready to go now.
Yes, Your Honour, we are. The recording's working again. Panel members, I'm going to ask you some questions about the presentation of Joel Couchy's disease over 3 distinct phases. The first is when he was experiencing when he was experiencing obvious psychotic symptoms in 2001 and his readmission in 2002. A second phase of his treatment in the public system during that period and up until 2012 when he was transferred to Dr Boros-Levac, and then finally from 2012 until June 2019, I should say a fourth phase then from June 2019 when Joel was removed from all antipsychotic medication. Dr Nielsen, much of this is uncontroversial in terms of the history, but you set it out in your report. You note at paragraph 57 that there was a service intake call with respect to Joel on the 20th of July in which his father Andrew reported problems. Andrew Couchy reported that Joel had moved churches because of Joel's belief that he's a prophet. Andrew described his own issues in his background and delusions that he had had. And a letter from July 2000 from a general practitioner noted problems with Mr Couchy, that is Joel's aggression, withdrawal, verbal abuse and threats to kill his father. There was also some threats against his sister. These are all prior to the admission in January 2001. Are they appropriately described as prodromal symptoms, some of them?
Well, firstly, the transfer of churches was Andrew Couchy,
I beg your
the
pardon.
father, who I understand also has a form of psychotic illness. So, but the other symptoms they sound like early psychosis rather than prodromal. But the prodrome is the interval between an observed morbid change and the emergence of distinct symptoms of psychosis. So there's often a decline in social functions, some mood symptoms, irritability, perhaps attenuated paranoid ideas, but that's the prodrome, and those features you just described sounded like by the time he'd become psychotic.
I see. So Joel started experiencing those prodromal symptoms from around the age of 14. Is there anything you can say about the typical onset of serious illness, of this serious form of schizophrenia?
Yes, well, in many respects it sounded quite typical, with a decline in social function and a decline in performance from being a scholarship student to not doing as well at school, and then the emergence of frank psychosis in the last year of school is not at all uncommon.
Professor Nordentoft, I could see you nodding there. Is that common in terms of your experiences in treating patients with this serious form of illness?
Yes, I think I agree that usually the first episode, before that there can be a phase with prodromal symptoms, but the symptoms described by his father and also noted in the records would be clear signs of the first episode psychosis. So I think there were many symptoms presented when he had his first hospital contacts, actually a clear evidence that he was by that time suffering from schizophrenia.
Does the panel generally agree with that? Is there anything anybody wants to add? I can see you nodding, Professor Harris, Professor Heffernan, Professor Large.
Yes, I agree with that, but globally, the average duration of time between the onset of psychotic symptoms that could result in a diagnosis and the actual diagnosis and treatment, that period is known as the duration of untreated psychosis, and it's remarkably long, of the order of a year in developed countries, actually in some developed countries even longer than that, and also in poor countries, but globally it's around a year.
What do you mean by that, Professor, that you have to experience those symptoms for that period of time before you're diagnosed?
No, that there are all sorts of barriers to getting to the point of taking antipsychotic medication. People recognising that you are mentally ill, compelling you to have treatment, persuading you to have treatment, making a diagnosis. There's a whole body of research about the delayed initial treatment of schizophrenia, and it's important because the duration of untreated psychosis is one of the factors that determine prognosis, along with an earlier age of onset, and actually, frankly, cannabis use is an important factor. And the psychosis emerging in the teens, not long after exposure to cannabis, is not at all uncommon. And I agree fully that, by the time he presented, he had schizophrenia.
Dr Nielsen, at paragraph 58, you say a note from a referral call to a mental health intake dated the 19th of December 2000 included that Mr Couchy had threatened a person by saying he had a gun in his bag. Is that Mr Couchy Jr.? That's Joel?
Yes, I beg your pardon. Yeah, that is, and again, that's just taken from the Toowoomba Hospital medical records.
So by the time that Joel was making those threats and engaging in verbal abuse and aggression, they were symptoms of psychoses, Dr Nielsen?
Yes, it seemed he'd had those symptoms. His duration of untreated psychosis was probably a little shorter than a year, and it seems that he got treatment fairly promptly after that, so he was admitted within a month of making that threat.
So I'll come to that first admission. He was admitted to the psychiatric unit of Toowoomba Hospital for 4 weeks, from the 27th of January 2001 to the 23rd of February 2001. I appreciate this is all set out in your reports, but I'm saying this so that everybody could follow it. I'm going to focus on Dr Nielsen for these uncontentious questions. If any of the panel members would like to add to them, would you please let us know? Dr Nelson, you write, the discharge summary reported that he was brought to hospital after damaging doors at home, and he believed he'd been possessed by demons for 2 weeks. A morbid change was reported from the age of 14. At the time of admission, Joel described hallucinations of frogs and of seeing and feeling demons entering his body, feeling as though his movements were controlled and that people were inserting thoughts into his mind, and believing he was followed by 2 men. It was noted that Andrew Couchy, Joel's father, had a psychotic illness. Joel confirmed the past use of cannabis, but reported that he had not had cannabis or alcohol for 18 months prior to admission. He expressed anxiety, etc. It was, in fact, Joel's father who called the police leading to his admission, and he was supported by other family members. There's evidence at that early stage of auditory, visual and tactile hallucinations. Is that right?
Yes, I mean the syndrome, the combination of symptoms is very typical of an acute schizophreniform psychosis.
The inpatient records include information from Andrew Couchy in which he told staff that he took his son's threats to kill seriously. Is it common for members of the family, even though they love someone dearly, to feel genuinely frightened when this psychosis emerges?
Yes, of course, and often because of the anger and hostility that accompanies these symptoms. And as Professor Nordentoff said, the person themselves in fear because of their symptoms and reacts angrily. And again, that's there was other reasons. Perhaps Mr. Couchy's father took it more seriously, but often family members are frightened of acutely psychotic relatives.
Can that make it difficult for family members to report symptoms or to get their loved ones help?
Most definitely. And again, jumping way ahead to 2023, it seemed that his mother was a little bit circumspect about reporting her concerns perhaps because she was a little afraid.
I'll come back to that issue. Staying with these early years of treatment, we know that Joel was an inpatient for 4 weeks at that period of time. He was managed in the community with the support of a mobile intensive rehabilitation team, or a MERT. His symptoms continued. And Dr Nelson, you note at paragraph 63, an entry in the community mental health records from 19th of June 2002 noted the presence of intrusive thoughts and indistinct hallucinations of voices and somatic sensations. There were symptoms of OCD in the form of repetitive cleaning behaviour. This is OCD prior to Joel being trialled on Clozapine. Was it evident to you that OCD, obsessive compulsive disorder, was a symptom of his schizophrenia as opposed to just a side effect of medication?
Look, it's very hard to separate the two. They have overlapping inheritance, for example. Tic disorder, obsessive compulsive disorder and psychotic illness appear in family histories so separately or together. The classic textbooks on schizophrenia phenomenology describe obsessive compulsive symptoms as being common in the onset of schizophrenia. I mean, it's really hard to separate the two. I mean, we know OCD is a kind of neurological disorder, some sort of neurological origin, and I think it's just part of the one syndrome.
I see. All right. Does anybody want to add to that? I'll return to these symptoms of OCD at some stage as we track Joel through his diagnosis. Dr. Nielsen, you note that Dr. Nikki Stevens, who was his treating psychiatrist, or one of them in the public sector, recorded on the 21st of August 2002 that Joel's auditory hallucinations continued but were not as intrusive as frequent. A subsequent letter noted the presence of auditory hallucinations, distorted perceptions of his body, poor concentration and thought disorder. In September, Joel was invited to participate in an early psychosis group facilitated by a psychologist, and there was a further admission to the psychiatric unit of Toowoomba Hospital from the 1st of October 2002 through to the 15th of October 2002 to initiate treatment with Clozapine. Dr. Nielsen, what were the first-line antipsychotics that had been trialled with Joel from January 2001 through to October 2002?
Yes, he was initially treated with olanzapine, better known by the brand name Zyprexa. And again, the doses weren't impressively high, and he was later switched to risperidone or Risperidal. And again, not very high doses, but it seems that he continued to have symptoms despite treatment with those two medications. And I'm sure that's what... And the other disability, the negative symptoms, probably contributed to the decision to initiate Clozapine.
So in October 2002, a decision was made to admit Joel to hospital to commence the Clozapine. The admission was for a couple of weeks at that time, and it was supported by community mental health follow-up. I'm going to just take you to some of the ongoing symptoms that appear to be reported after that time. Dr. Nielsen, you note that in May 2003, Joel listed possible triggers to relapse as study stress, the use of marijuana and physical illness. Is it important to, in the therapeutic alliance with a patient, to have them understand what their possible triggers are for psychotic relapse?
Yes, of course, yeah, especially if those triggers can be minimised or avoided.
Joel listed his own early warning signs of relapse as being preoccupied, feeling as my thoughts might not be my own, or thinking that I could be someone else. And he set out his goals at that stage to join and successfully compete in competition-level shooting. Joel wrote that both hallucinations and suspicions he thought had gone by May 2003. That was Joel's assessment of what might be warning signs. We know that first episode of psychosis, as you all set out, was characterised by aggression, threats, and the auditory hallucinations, and also a disengagement or a lack of engagement with those close to him. When looking out for signs of relapse, is it important to look at the early signs of psychosis to see if they return? That is, do the early signs give you an indication of what might be a relapse in the future?
Yes. In particular, a change in the emotional responses of a person, that they might seem more preoccupied or more irritable, rather than what they might disclose in terms of the return of symptoms.
Does anybody want to add to that or disagree with that? So far, everybody aligned.
I'd say that although they're an indication, they're not always 100% there. So the return of symptoms can be heralded by a broader range or a different profile of symptoms but they are indicative of a return of the illness.
Dr. Harris, is it possible for patients, like those in Joel's condition, to not recall what the earlier auditory hallucinations or visual hallucinations were? That is, once they recover, it's difficult for them to identify it?
It can be difficult to for some patients, because the period of time when somebody is acutely psychotic is very disorganised and is sometimes filled with sleeplessness or substance use or a whole range of other things that can interfere with the effective remembering of symptoms, as well as the fact that there is an effect upon memory itself with the disorder. So it can be difficult for people to clearly remember all of their symptoms.
For that reason, is it generally accepted in practice that it's important to engage family members or those close to the person with an illness so that they can assist to recognise symptoms of relapse?
It's very important to engage family members in the treatment and to use their experience and their knowledge of their loved one in the treatment, as the family is going to be the chief ally of the person with presenting at this sort of age, and the chief resource in the recovery journey.
Professor Nordentoft, you spoke before the break about a particular clinic in Denmark where if you're going to wean somebody off antipsychotic medication, that clinic does the close follow-up for 18 months, and you spoke about weekly follow-up. Is it part of the protocol at that clinic to engage the patient's family members or loved ones?
No, it's actually not. I think they often do, but it's not a protocol for doing it. It is a part of the protocol for the early intervention teams. We have specialized assertive early intervention teams where it's more or less mandatory to involve the relatives. And I think they often can convey very important information. They know the patients much better than we are able to do as professionals. And they can often observe signs of early relapse long before the psychiatrist would be able to detect it.
So it's good clinical practice to pay regard to those signs that are reported by family members. Is that fair?
Yes.
So just carrying on with some of Joel's symptoms, and then I'll come to his diagnosis at the end of 2012. Dr. Nielsen, as with your colleagues, you set these out. For example, paragraph 72, skipping to 2006, reviews at the Clozapine clinic noted Joel's denial of symptoms of psychoses, but the persistence of OCD and his continued involvement with an occupational therapist. On the 22nd of February that year, 2006, an occupational therapist elicited an account of voices that Joel heard, attributed to God punishing him. A family conference on the 6th of September 2006 noted that Joel had good insight into the nature of his auditory hallucinations if they occur, but poor insight into his obsessive thoughts of contamination. Dr. Nielsen, did those auditory hallucinations and the contamination issues appear to be signs of ongoing psychosis at that time?
Well, psychosis is defined as having a delusional belief, and I guess attributing voices to the voice of God is a delusional belief. And that, again, Dr. McQueen, his case manager, who was a psychologist, a PhD psychologist, and something of an expert in OCD, I understand, had speculated that his account of obsessional thoughts may well have been hallucinations, and he did he was his case manager for nearly 6 years. So again, they could have been symptoms of psychosis.
An entry on the 8th of January 2007 by Dr. McQueen noted hallucinated voices to be present in varying frequency and intensity.
Yes.
Dr. Heffernan, you deal with an entry in 2008, the following year, at paragraph 2.17 of your report. You note that throughout the remainder of 2007, Joel continued to experience positive psychotic symptoms and OCD symptoms. By mid-2008, His clozapine dose was 600 milligrams at night and aripiprazole 15 milligrams. It was reported that while his negative symptoms were improving, it was noted in his clinical record he had experienced occasional auditory hallucinations and he developed the side effect of bedwetting. Dr. Harris, is it common for, I withdraw that, firstly, is 600 milligrams at night clozapine a high dose of that drug?
Yes, it is.
Is it common for somebody who is experiencing psychotic form of, well, I withdraw that, is it common for somebody who has experienced schizophrenia in their teenage years to still have ongoing symptoms, some by this stage 4 years or so after commencing clozapine?
No, it's not common. Most patients, in my experience, have responded to treatment relatively quickly after the initiation of treatment.
So does that tell us anything about the severity of the disease at that stage?
It suggests that Mr. Cauchi had a severe form of schizophrenia.
Professor Lodge, do you agree with that?
Look, I have a slightly nuanced view. So just going back to the question of how stable people's initial symptoms are, we use the term first episode psychosis because the diagnosis of schizophrenia isn't necessarily particularly reliable at the beginning of the illness. And some people who present with psychosis will subsequently have a mood disorder. And additionally, some people who present looking as if they have a psychotic version of a mood disorder will end up having schizophrenia. So we use the term first episode psychosis in that undifferentiated period. In Mr. Cauchi's case, it was quite clear that he had schizophrenia. He had an unusual pattern of, persistent first episode of schizophrenia, and I'm not saying first episode psychosis, but he had this long episode that went on for years. That is a somewhat unusual but well-described pattern. I think there's a framing issue to do with the severity that is probably influenced by my role in the public sector. Anyone who has a diagnosis of schizophrenia has a severe disorder. The most severe forms of schizophrenia are quite extraordinary. And in the public sector, Mr. Cauchi wasn't placed in that category and was referred to the private sector as a result of that. So I think his illness was enduring, obviously very problematic for everybody. But in terms of his actual symptoms, was of moderate severity.
Joel was described as stable by 2009, but Professor Lodge, you will have seen in his reports, he continued to experience positive hallucinations right up until 2012 at his time of discharge from the public sector. Is that right?
Yeah, lots of people are stable, but 1/3 of patients don't. I mean, about 1/3 of patients with schizophrenia do pretty well. About 1/3 do have some response to treatment and have some ongoing disabilities. And there's another 1/3 who are chronically, severely disabled, perhaps in and out of hospital, having contact with the criminal justice system, using drugs, are persistently dangerous to their families, end up in public housing because they can't live with anybody else. I would put Joel in that sort of intermediate group, really, rather than in the very severe group.
One of the things that Joel had that some patients don't have is very supportive parents who were offering him accommodation. Do you agree with that?
Actually, I would say that almost every child who develops schizophrenia has extremely supportive parents. I think that his parents were very supportive and his mother was very, very active. But any child who develops schizophrenia will be of enormous concern to families. Families have bottomless needs that are often not met very well by the health system. As a result of that, there's a group of people who don't end up living in their family home. But I think it would be wrong to think that the parents of other children with schizophrenia are not similarly concerned. It becomes the dominant thought process for the parents of anyone with schizophrenia. I tell my registrars that the families of people with psychosis have bottomless needs for assistance.
Is there more need in Australia for support systems for family members?
Oh, no doubt. But things are worse in other places, much worse in the US.
I might come back to that in terms of recommendations. Professor Large, just to remind you, I know, or remind everybody listening, Joel was discharged in 2012 on a high dose of Clozapine, 550 milligrams. In spite of that, and in spite of that treatment with very large doses of Clozapine, from 2009 to 2012, he continued to experience positive symptoms of psychoses. That suggests a serious form of that illness, doesn't it?
It suggests a persistent form of the illness, but all schizophrenia is severe.
It suggests by 2012, at the time of discharge, Joel had been in the public health system from 2001, when he experienced those acute forms of psychoses, through to 2012, where he'd been stabilised on large doses of Clozapine, but still experienced some positive signs of psychoses and negative symptoms of schizophrenia. Is that right?
Yes.
And does that suggest that at least by 2012, it's accurate to describe that disease as chronic form of schizophrenia?
He definitely had chronic schizophrenia, absolutely definitely, and schizophrenia is a severe disease or severe illness. But the public system saw fit to discharge him to the private system. And that indicates their view, and my view is that at that time, a patient similar to Joel, and I'm not necessarily talking about Joel, in the public sector, in almost anywhere in Australia, would be regarded as not being of the most severe, on the most severe spectrum.
Sure, but Joel was discharged. We've got a note from one of the psychiatrists who was working with him around that time. The decision to discharge him in the public sector was influenced by a number of things. First, his stability. Secondly, the fact that he and his parents were supportive of him being discharged to the private sector so he could have the psychiatrist of his choice ongoing. And third, because he was someone who was very compliant with his medication regime. Do you agree with that?
Extreme patients don't meet any of those criteria. They burn their relationships with their
Sure.
parents. They won't take medication and they won't come to appointments.
But that was the one factor leading to his discharge to the private sector was because he was compliant and cooperative.
Yes,
Do you
of
agree?
course.
And is it fair to say, Professor Large, there is evidence throughout that Joel wanted to be well?
Yes.
And he wanted to have a productive life with positive relationships?
Yes.
Do you see ongoing signs of negative symptoms of schizophrenia throughout the period of his treatment in the public and private sector?
Oh, no doubt. He had a very unusual psychometric test with... So schizophrenia, the old name for schizophrenia is dementia praecox. My belief is that schizophrenia is fundamentally a cognitive disorder. This young man, as a young man, Joel obtained a scholarship to go to a private school. And later, when he had psychometric testing, his verbal IQ was 129, which is not all that atypical of an IQ of doctors. There are many doctors with an IQ of less than 129. Yet, his performance IQ, which is, doing your shoelaces up kind of IQ, was in the bottom 7th percentile. So he'd had a deterioration in some of his cognitive functions, which was very significant, almost certainly due to schizophrenia, probably quite possibly something to do with cannabis. And so he had an underlying cognitive deficit that could not have been remediated by medication. It just doesn't respond to medication really. And that would manifest as, his inability to, he couldn't cook, the poor fellow. Mm. He had profound negative symptoms that I think were mostly due to his cognitive problems. And
he's continued to experience those negative symptoms when he was not using marijuana, correct?
Marijuana, marijuana causes cognitive impairment. It's entirely well understood and measurable. If you smoke marijuana, for about 6 weeks afterwards, you'll have impairments of memory, attention, concentration. There's some evidence of permanent disability of mathematical ability due to quite minor exposure to cannabis. More prolonged exposure to cannabis it's less certain what cognitive impairment occurs as a result of it, but it's quite likely that chronic cannabis exposure causes permanent defects in cognition. This has been measured in rats. So if you expose adolescent rats to cannabis, they have permanent impairment in visuospatial learning throughout the rest of their 2 years of life.
We haven't dealt with, you in your reports have each dealt with, I think for the most part, the causes of schizophrenia. But there's a complexity, isn't there, in the relationship between cannabis and schizophrenia? Professor Nelson, I might ask you, because you have, and Professor Large both have an interest in this. Is it the case that sometimes people with an underlying schizophrenia can turn to cannabis to self-medicate in effect? So that one comes, it's not that cannabis causes schizophrenia, but in fact, somebody with schizophrenia might be more likely to use illicit substances to self-medicate?
Yes, well, I mean, it's a very common comorbid condition. I mean, something up to half of people in first episode psychosis have been smoking cannabis, and as Professor Large said, it brings on psychosis earlier. However, Mr. Cauchi's cannabis use wasn't impressive, and he reported that he'd been abstinent for about 18 months prior to the initial treatment. However, again, we're jumping right to the end, but if he had, and when he did resume cannabis, it almost certainly made his symptoms worse.
Yes.
Yeah, in between, I mean, it's definitely leads to a less favourable course of illness, and also less adherence to medication with cannabis and substance use in general. So, I mean, it's a terrible comorbid condition.
And it's a risk factor that patients have to be warned about, and that treaters and family members would be conscious of.
Yes.
In terms of triggering. In Joel's case, rather than dealing with the general causes of schizophrenia, Professor Nielsen, if I can stay with you for the moment, Joel was diagnosed or had those prodromal issues from an early age in his teenage years. He was diagnosed with psychotic episodes at 17. His father, Andrew, had his own issues with psychoses. Is it possible, on your review of the history of Joel, to say what the cause of his schizophrenia was?
Well, it's almost certainly an inherited, neurological abnormality. Because it's not just his father. I think he's got an uncle, a paternal uncle, who's a hoarder, and so it looks like it's an abnormality handed down. However, despite our genome-wide understanding of genes, the specific genetic mechanism and the specific neurological mechanism for schizophrenia is not known. And obviously Professor Nordentoft's the international expert on this topic, but all I can tell you is it's probably an inherited neurological defect.
Professor Nordentoft, can you expand on that, or do you agree with that?
Yes, I agree that there's definitely both twin studies and genetic studies indicating that there is a large amount of heritability in schizophrenia, but also it's also evident that it's not the whole explanation. There are also environmental factors that can affect whether schizophrenia will occur or not. And we've done a large register-based study indicating that cannabis use can contribute to the incidence of schizophrenia.
Professor Large, before I come back to Professor Nordentoft, do you feel passionate about these issues in relation to the correlation between cannabis use and exacerbation of schizophrenia? Is that right?
Well, I've looked at the science, so it's impossible not to be passionate about it.
Do you feel that there's enough public understanding about that, or do you think when I return to recommendations it should be something that's more broadly understood?
I'm going to go a bit out on a limb here. The chief survival strategy of the cannabis plant is to make humans love it. Humans love cannabis, and it's the only drug that's managed to completely evade therapeutic regulation. And it's now got a therapeutic halo around it. But it is the most proven potent environmental cause of schizophrenia. And that occurs irrespective of your degree of heritability. There's a thing called a polygenetic risk score, and there's an increase in the risk in the likelihood of psychosis among people with a low polygenetic risk score, and it's similar among people with a high polygenetic risk score.
Professor Nordentoft, is that similar to or is that consistent with your research?
Yes, I would agree that cannabis is an independent risk factor for schizophrenia. independent of the genetic risk. It adds to the genetic risk, but it can add both in cases where there's a low genetic risk and a high genetic risk.
Can I come to Joel's discharge from the public health system? If we could just have on the screen, please, page 327 of tab 793. These are the My Mind records, so hopefully you'll be able to see them too, Professor Nordentoft. You were provided with them previously. Just to remind everybody, this was provided to My Mind. The admission episode date notes 7th of July 2003, which of course was not the first admission. Discharge the 19th of April 2012. There's a notation about Joel beginning to experience symptoms of schizophrenia in 2000 while in year 12, and that he became distressed by perceptual disturbances, including auditory hallucinations in the form of sounds and voices. He's been continually managed since then. Down the page, there's a reference to the fact that Joel had been stable since commencing on Clozapine and had now been treated with Clozapine for 10 years. The next paragraph reads, "It appears that Joel may continue to experience some positive symptoms with fluctuating severity. However, Joel denies any positive symptoms. If symptoms are present, they're not interfering with his functioning. There was a brief period of exacerbation of symptoms around 2008, coinciding with a transition from Clozaril to Clozapine at equal doses. That was managed by an increase in his dose of Clozapine and the addition of aripiprazole. Negative symptoms remain a feature of his illness," etc. Can I come now, and a question will follow, to page 333. This was the initial letter of Dr. Boroslavak to Dr. Grundy, a general practitioner, of the 6th of March 2022. That letter lists Joel's diagnosis as chronic paranoid and disorganised schizophrenia in control on Clozapine, OCD, and he was noted to be anxious, shy, with avoidant dependent features. Was that, Professor Nielsen, was that the appropriate diagnosis for Joel at that time?
Yes, I'm not sure about the paranoid or disorganised categories, but certainly schizophrenia, OCD, anxiety, and disability are all quite. I agree with those.
And I think there's broad agreement that it's a chronic form of schizophrenia. Is that right?
Yes.
Okay. And one of the vulnerabilities listed is that Joel's father is noted to be over-religious with revelations. Can I pause to ask this question, Professor Nordentoft? In looking at the vulnerabilities, in spite of Joel's support from his mum and dad, would you expect a clinician to be aware that the fact that his father had experienced psychoses and was unmedicated would be an ongoing risk factor for Joel? Or might be?
Definitely one should be aware that he has this predisposition. But I think whether it had been there or not, the clinical management of his case would be based on an evaluation of his clinical presentation, and of course also the knowledge that his father has this that he has these revelations. But I think the main issue would be evaluating his clinical state.
Would you be conscious of a risk that if his father was experiencing delusions, that could impact on Joel's mental health functioning?
Yes, I think that's necessary to consider. There's a condition called folie à deux, where you're actually sharing delusions with people close to you. But I don't think that was the case in Joel's situation. But of course, it is important to know that somebody close to a patient has a psychotic condition as well.
I'll return to that potential influence in 2019. But before I do, in relation to how we characterise Joel's illness, Professor Nordentoft, you say this at paragraph 47. Together, the mentioning of his symptoms in the medical reports, it is very well documented that Joel suffered from schizophrenia, based on the fact that his psychotic symptoms were present for approximately a decade, it must be evaluated that he was a typical case of severe treatment-resistant schizophrenia. And you've referred to the particular symptoms in the paragraph above. You go on to note at paragraph 82, Mr. Cauchi had a severe treatment-resistant schizophrenia and was treated with antipsychotic medication for 19 years. In the first 12 or 13 years, he was still psychotic. So you are firm in your belief, Professor Nordentoft, that he can be characterised as having treatment-resistant schizophrenia?
Actually, we discussed that in the panel before this court meeting, and I think that for many years he fulfilled criteria for treatment-resistant schizophrenia, but actually he ended up with having some response to Clozapine, and in that case, I would rather say that it is a chronic form for schizophrenia, but it was. He was receptive. He did have some response to antipsychotic medication, and in that case, I think that it's more precise to call it chronic schizophrenia than treatment-resistant schizophrenia. So I'm deferring a little bit from what I wrote in the report. I'd rather call it chronic.
Do you mean that at some point in time when the positive symptoms of schizophrenia have abated, you would shift in a diagnosis from treatment-resistant schizophrenia to chronic schizophrenia?
Yes, I think I would do that, but it doesn't really influence a lot on what kind of recommendations I would make regarding treatment. But of course, if it was treatment-resistant after many years, one should consider whether the dose should be increased or whether there should be some change in medication, but actually he responded well on Clozapine. I think the combination of Clozapine and aripiprazole.
Professor Nielsen, can you comment on that in terms of the ongoing symptoms of Joel? He might be described as being stable, when in 2012, when he was given into the care of Dr. Boroslovac, is that right?
Yes, well, in the sense that he hadn't, adherent to treatment, was there'd been no change in his level of symptoms for quite some time. I would agree he was stable.
He continued to. Sorry, did I interrupt you?
Oh no, I was going to say nevertheless symptomatic to some lower level.
That was my question. So, what were his symptoms beyond while he was with Dr. Boroslovac, and I'm really going up until the time of June 2019 when all antipsychotics were discontinued?
Well, the symptoms seem to be the chronic cognitive symptoms and negative symptoms referred to by Professor Large, and very likely a lower level of hallucinations. Although they're not documented, but they're very likely to have persisted. There's no reason they would have gone away, even though his response improved. And then he had continuing symptoms of obsessive-compulsive disorder as well.
Dr. Heffernan, do you agree with that?
Yeah, I might add something,
Please.
if I may, so I don't disagree. But I just thought it was important to add the context of the term treatment-resistant. It's not a term that's defined in the Diagnostic and Statistical Manual. So it's a term that's used really largely in relation to, for example, Clozapine. So it's just a definitional term, really. It's almost semantics in this case, but the term is defined by a failure to respond to 2 or more antipsychotic medications given in an adequate dose for at least 6 to 8 weeks. And so by that definition, then you would use the term treatment-resistant schizophrenia. That doesn't necessarily mean that someone doesn't go on to have a complete remission, a partial remission, or never remit. It's just that initial period defines that term. Sorry.
I think so. That clarifies it. I think there's broad agreement then in terms of that definition now. Is that right?
I was going to say exactly the same thing.
Okay.
as Professor Heffernan.
At the time of discharging Joel from the public health system, if you can take it from me, we've got a statement from Dr. Manaj Narayan, for the benefit of my friends, tab 781A, volume 15, and he says this is in 2012, that Joel was reducing the current daily dose of Clozapine, 550 milligrams, due to the reported side effects. There was a slow reduction or tapering was suggested to a target dose range of 300 to 400 milligrams, and then to check Clozapine levels once he had reached a daily dose of 400 milligrams to ensure the dose was in the therapeutic range. Joel was to continue to take the aripiprazole while reducing his dose of Clozapine. It's either Dr. Heffernan or Dr. Harris talks about how your preference would have been for Joel to maintain some sort of stable dose of Clozapine. Are there, and I'll return to that shortly, but are there patients who are managed for the rest of their lives on a dose of something like what was envisaged by Dr. Narayan, which is 300 to 400 milligrams?
Yes, there are. And I'd also draw attention to the introduction of aripiprazole to Mr. Gauchi's treatment, as that may well have helped significantly as an augmenting medication, even though it is a very low dose of aripiprazole. But that combination of aripiprazole and Clozapine is known to be an effective one.
Why is that, in terms of the way the medications work?
I don't think anyone really knows why it is. That there are different classes of medications. Aripiprazole, along with the two other medications that are licensed for use from that class, are partial dopamine D2 receptor agonists, and that would appear to have some additional benefit, and additional benefit also from the point of view of negative symptoms.
Can I come then fairly quickly to the first 3 years of Joel's treatment in the private sector, 2012 through to 2015. Does the panel agree that the My Mind setup was a good one, in that you had clinical nurses with training in mental health, a psychiatrist who was seeing Joel on a monthly basis, and if necessary or Joel was willing, a psychologist who could have assisted? I think there's broad agreement, do I take it, that that was a reasonable setup for management in the private sector. Professor Large?
Clozapine is very rarely prescribed in the private sector, I think it's impossible to be a sole prescriber of Clozapine. You need to have that sort of setup, and the frameworks don't really exist. I don't know how many private Clozapine prescribers there are in New South Wales, but not many at all.
Dr. Nielsen, I think you're a could you tell us about your setup?
No, I was the only private Clozapine prescriber in Australia, I think, while in the homeless sector. But it was through using a number I got from St Vincent's Private Hospital. I think I was able to do it. But everybody who started on it in the homeless sector, it made a good response. So it really encouraged me to want to use it more. The use of Clozapine, like 40% of the forensic patients are on it, about 10 to 15% of patients in the community are on it, and about 3% of the homeless patients were getting Clozapine, and ironically they were the most severely unwell who should have been getting it. So I guess that was the reason for wanting to do it. But I thought the setup at My Mind was exemplary in some ways, and the key benefit was to have the same doctor all the time, and also for that doctor to have appropriate supports and coverage. It just guaranteed that you'd have a relationship where you'd assume the person would sort of follow the doctor's advice, from building up a trusted relationship. And one of the reasons that Clozapine might work so well is that the amount of clinical care you get, because you have weekly blood tests, which usually involve some kind of interpersonal conversation for people who are often very lonely. So it's sometimes hard to separate that from the medical effect of it, the medication.
Dr. Harris?
I'd certainly agree that the way that Scacchi was treated from the point of view of his medication at My Minds was very good. However, there's a broader issue of psychosocial treatments that are a systemic problem for the treatment of people with schizophrenia, not just from the point of view of the treatment at My Minds. And that is better and that type of care of more assertive social skills training, of use of cognitive remediation therapy or specialist cognitive behavioural therapy is hard to obtain generally in this country, and that's not a specific, but it is possibly more available in the public sector in some parts of Australia.
So what's the ideal management for someone with Joel's condition, with the severity of his illness, as at 2012, in terms of an allied health professional response?
It would have been best if he had access to a multidisciplinary team in which not only was his medication dealt with, and it was dealt with very well at my minds, but that he had access to allied health, particularly psychologists and occupational therapists, and a team also to help him get back into function. Mr. Cauchi was attending university and had some real academic skills and was able to complete a degree, but it's conspicuous that he was unable to follow that up with employment or with being able to stabilise his own life. And that's the type of help to bridge him into some form of employment, to help provide a structure for his day, and to help him find a social network which would have been very protective, and particularly from dropping into homelessness, that was not available for him in Toowoomba and is often not available at all in this country.
Where is it available?
It's available in some specialist centres, particularly in early psychosis programs, or youth programs. But there's a gap for many people after they leave those more intensive treatment programs. There are some scattered programs which are linked to non-government organisations or to institutions like clubhouses that provide some social a social framework for people to have continued connection with other people and to bridge into disability employment services of one sort or another. But that is patchy.
Dr. Heffernan, do you agree with your colleagues, with your colleague Dr. Harris?
Yes, I do. I think there's the what should be and the what is.
Yes.
And I think that, just reflecting on your initial question, which was about the My Mind Centre, it was necessary at the time. I think that the public system is so overwhelmed, and to have an alternative where Clozapine can be prescribed and a clinical nurse can be involved in the care and psychiatrists providing regular treatment is a very good option. But is it sufficient? I would agree with Professor Harris that no, not ideally sufficient, but necessary.
And Professor Large, is your evidence to be understood that your preference is for patients like this to be treated in the public system rather than the private system?
I think that is my evidence.
And Doctor, before I came to Professor Nordentoft, Dr. Nelson, have you provided Clozapine primarily through the Matthew Talbot Clinic or also in your private practice at level 8?
No, I've got one very long-term patient for 30 years actually who takes Clozapine, but he has it managed at Prince of Wales. He lives down there. But I've got 6 people on Clozapine at my my housing project, which we'll assume I'll be managing long-term. So it can be done.
Through Matthew Talbot or through the private clinic?
Well, they're all on the Matthew Talbot,
I see.
Which again is sort of they believe is part of St Vincent's mental health. So that's how I do the blood reconciliations.
Those persons are being managed on Clozapine long term to good effect in minimising their symptoms?
Yeah, certainly to better effect than other medications. Yes, yeah, they've got treatment resistance.
But you gave an example of one patient without giving any clues as to their identity, but 30 years managed on Clozapine. Was that person previously, by nature of the fact he's on Clozapine, he or she experiencing a severe chronic form of psychosis and illness?
No, he had a very, very severe illness. He was living in the boarding house I alluded to earlier, and was on a massive medication, was very angry and disturbed, and arranged admission to St Vincent's, and it was just remarkable. It was just a transformation, and as we so often see. And his actual regime has come down to 100 milligrams plus aripiprazole. He is fully employed. He still has, I think, chronic schizophrenia, but we've certainly he did try to go down to 25 milligrams and had troubling symptoms, and we settled back on 100. And but I've always encouraged him not to stop.
When you managed him down to 25 milligrams, was that in the private system still that he was managed down, or was that with the assistance of a hospital?
No, I was corresponding with Prince of Wales, who were managing his medication.
And how long did it take for those? Were they psychotic symptoms that returned, or early?
Pretty quickly, yeah. So anger, distress, hallucinations, prominent hallucinations, and quickly responded to restoring. He was on 300 long term, then it was reduced down, and then down to 25, and then that wasn't correct.
100 milligrams might be thought to be a small dose, but you're saying that still on that small dose has proved to be an essential way to manage those symptoms.
Yeah, with aripiprazole.
I see.
And he's a very not thoughtful man, but he recognises his illness. He can identify his own symptoms.
Yes, and so fully engaged in employment. Did you say?
Yes, open employment. Yeah. He's not he went off the pension, stopped smoking. I mean, that's Clozapine.
Professor Nordentoft, in Denmark, is it common for patients on Clozapine to be managed in the private system or the public system, or both?
I think most people would be managed in the public system. We have a very small private system, and they are mainly dealing with people with other disorders. Most people with schizophrenia are managed in the public system, especially if they are on Clozapine. I think few private practitioners or private hospitals would be able, at this point at least, to manage Clozapine treatment.
What is it about the public? I'm sorry, Professor. What is it about the public system in Denmark that means that this sort of care you need when you're on Clozapine is appropriately provided in public rather than private?
I think it is the way we have organised ourselves. When I saw my mind clinic, what they did would actually be quite parallel to what would happen in a public system in Denmark, except that we might have access to more of the services mentioned by my colleagues, for instance, to be able to be more assertive. I think that would often be a difficulty in the private system. To do that, at least the way we have organised ourselves in Denmark.
What do you mean by assertive? Are you talking there about where there's early warning signs?
Yes, I think you would be able to do home visits. You would be able to involve the relatives and encourage them to report if there's warning signs, and be persistent if the patient is not attending planned visits. That's part of what I mean with assertiveness.
I see.
But actually, in the case of Joel Couchy, he was attending almost every visit in my mind centre, and he complied with all blood tests and things like that. In that way, I can understand that it was seen as an appropriate way of handling his situation, at least when he was stable. I think when he started to become unstable, the system, the vulnerabilities of the private system shows the weaknesses became clear.
Panel members, I'm going to take you to a letter in 2015 written by Dr. Boros-Levac to Dr. Richard Grundy. It's dated the 6th of May 2015. It's page 240 of tab 793. While that's coming up on the screen, generally, is it fair to say that a decision was made, a reasonable decision was made by Dr. Boros-Levac to reduce the dosage of Clozapine? I think the panel are in agreement about that. The panel are also in agreement that, I take it, that there was regular correspondence from Dr. Boros-Levac back to the general practitioner reporting on Joel's progress. Yes. And you will have noted that in that correspondence, the general Dr. Boros-Levac was telling the general practitioner that Joel was doing well and Joel's family regarded him as doing well. Is that fair?
Yes.
So in 2015, this letter is written, and it includes that, as you know, Joel's been very well for a long time despite gradual reduction in his Clozapine, which has decreased from 60 milligrams at night to his current dose of 275 milligrams at night by me, with the continuation of Abilify 5 milligrams in the morning. I'll just pause there for a moment. Dr. Nielsen, given that you've told us about that patient who is stable on 100 milligrams of Clozapine, 275 milligrams at night with the assistance of Abilify is a dose which is therapeutic and was likely to be having a positive effect on Joel?
Yes, very, very much so. That'll be a typical long-term maintenance dose.
The letter goes on to read, he was started on Clozapine at 17, and then she writes, with the advent of Nikki, that's Nikki Stevens, coming to private practice, I've approached I've approached her to give a second opinion regarding Clozapine. What would be his optimum dose? Could we switch him to another medication, e.g. optimum dose of Abilify? I do believe Joel needs an antipsychotic for long-term relapse prevention. And Joel's mother was noted to be supportive of the second opinion from Dr. Stevens. So that letter of the 6th of May 2015, it's clear from the letter that Dr. Boros-Levac recognises that there is a need for... her belief at that time was that Joel needed an antipsychotic for long-term relapse prevention. She's recognising the risk, she's getting a second opinion, and she's in accordance with the general standard care that for somebody with his illness, you're likely to need an alternative antipsychotic if Clozapine is reduced. I'm trying to summarise to be quick, but is that... the panel are nodding in agreement?
Yes, agree.
Professor Large, is that fair?
Yes, I just wanted to say earlier you suggested that I might have had some contact with the FDA. That's not quite true. I just wanted to correct that.
Can I come to that? Yeah. I know that you don't want to present as having influenced the FDA in their decision-making about Clozapine. I'm grateful for that. We've printed something off about what the FDA are doing on Clozapine in 2025, and I'm going to ask you, Dr. Large, about your opinion of that and what role you have played in. Is it advising a group with an interest?
It is.
I'll come back to that. So in relation to Dr. Stevens, might I then have the letter, which is at page 86 to 87 of that same tab. Panel members will no doubt have had regard to this previously. Dr. Stevens writes a letter back, and in it she says she thanks Dr. Grundy, who's done the referral on behalf of Dr. Boros-Levac. There's a couple of things I wanted to draw out from that letter. Dr. Stevens has had a long-term relationship with Joel through the public sector. Is it fair to say, Professor Large, it was a very good idea for Dr. Boros-Levac to get a second opinion from Dr. Stevens?
Excellent idea.
And you would... I would draw that. Dr. Stevens writes in that a couple of things. Second paragraph, Joel's memory of his symptoms at the time of that relapse when he was aged 17 appeared quite patchy, but he could recall mostly tactile hallucinations of being touched on his back and believing this was a spiritual experience. Goes on to note that he did quite well on quite high doses of Clozapine, and his positive symptoms resolved completely. He said he's had no further relapse in the intervening 14 years. I'll just pause. That might have been recorded in this letter, but we know, of course, that there were symptoms of relapse while he was in the public sector. So he had not been symptom-free for 14 years. Is that correct?
No, he hadn't been.
He goes on to note that towards the end of paragraph 2, although there were no signs of positive symptom relapse, the family felt Joel became more withdrawn at this time. He has functioned well in terms of completing a university degree part-time in language, though he remains reliant on his very supportive mother to organise him, provide social interactions, and he continues to live at home. On the second page, the fourth paragraph up, or the third paragraph up, says, his mother is agreeable to support him throughout this time, and in view of Joel's limited recollection of his positive psychotic symptoms, the family are most likely to be the people to recognise any early signs of relapse. That letter underscores, doesn't it? I might ask you, Dr. Heffernan, that letter underscores what is just good practice, that if you've got family members who are engaged and reliable, as Michelle Couchy was, you would pay careful regard to any signs that they raise in the future of concern?
Yes, I think that's really important, because often, in a first episode psychosis, the experiences that someone have are really poorly formed. The hallucinations are poorly formed, or they may be poorly formed. And so to actually add meaning to them, it can be quite difficult, and to understand them can be quite difficult, and that may change over the course of illness. Also, as people become unwell, sometimes they don't recognise they're becoming unwell, and in fact the process can be a recruitment of adversity, in that the more unwell a person becomes, the less they realise they're becoming unwell. And so that's why it's so crucial to have other people, particularly if they're as close as Joel was with his parents, able to recognise those early warning signs.
And Dr. Heffernan, is it possible for patients who are clever, as Joel was, to mask their symptoms of relapse once they've been off medication?
It's possible. People, when they're determined, it's just a human quality. When we're determined to achieve something, we really want to diminish, maybe even dismiss things that might suggest the alternative. And, it's speculation, but I suspect that Joel was determined to remain well, wanted to push away, symptoms. And so it is possible that he may not have voiced symptoms that were actually there. And I also think, perhaps if I could just
Please.
talk about something else, I also think that the terms stable, well, and remission just need a little context leading on from that, in that the terms are often defined relative to the individual. So compared to being, floridly psychotic, a person might be considered well with episodic attenuated symptoms, for example, but they're often not defined against the general population.
Right.
And so it's really important to sort of take that into context when we see these terms in letters and see stable, well, or remission. Sometimes they might mean relatively stable, relatively well, relatively remitted
Yes.
to that individual's previous state, and may not reflect what that individual is like relative to the general population.
I could see your colleagues nodding, and somebody will let me know if anybody wants to say anything different. The other issue I wanted to ask you related to masking is, if somebody has experienced side effects of medication, for example, low libido or OCD or any of the other side effects that might come, would you expect to have a high index of suspicion that they might try to cover up symptoms?
Well, firstly, let me say that most antipsychotics have unpleasant side effects, and it's perfectly reasonable to not want to have those side effects. And I suspect that being on treatment with Clozapine comes with a lot of side effects that are really unpleasant. And when a person is well, sometimes, or remitted, sometimes it's really difficult to understand that they could become unwell again. So the notion that I'm on a medication that's causing me problems and I'm well, that's a very compelling argument to say, well, I don't really need this medication. And it happens all the time with other treatments for asthma, treatments for hypertension. For example, people in general are often non-adherent to medication because they feel like they may not need it. So it's also the same in this circumstance, except the side effects are often worse with antipsychotic.
What's the education then that has to go on for a doctor to a patient to make sure they understand the risk versus the benefits?
Well, I think, you know, exactly that the key is education. We spend a lot of time with illness education, balancing those risks and side effects and benefits. And I think that's, you know, that's an ongoing process. It never stops because the side effects are ongoing. Sorry.
So does that mean that it never stops in terms of you need ongoing education for the patient, but also for the patient's family members, in this case, Michelle and Andrew Couchy?
Well, it seemed to me that Michelle had a lot of understanding.
Yes.
What I could tell about mental health, and was actively involved in mental health groups. And I'm not as sure about Mr. Couchy, but there will be moments in any family's history where they might change their mind or might think that you know, this particular treatment is not necessary, and so that process of continued discussion is necessary.
Well, let me get to the point then about Joel before I skip forward in 2019. In 2019, I'll come to the point shortly where I point out the symptoms that were being reported by Michelle Couchy. A decision was made by Dr. Boros-Levac that she would like him to go on an antipsychotic, and he was advised about that. And then his father, Andrew, when, in my mind, clinic nurse rang up, said that he did not want his son to go back on an antipsychotic, and then Joel did not go back on the antipsychotic. Does that suggest that there was a need to engage Michelle and Andrew in understanding what the risks were for Joel of having been taken off his antipsychotic medication? Dr. Heffernan?
It's a difficult question because, you know, whether people might hold that view for different reasons. So if they hold it because of a lack of education, then education is going to be helpful. If they hold it because of an ideological belief or in fact an illness belief, then education may not be as helpful. And that's why really considering the family unit as a whole is important. And of course, if his father did hold those views, that's going to be a very powerful message for Joel.
And I'll come to the exact notation shortly. But Professor Nordentoft, did you want to add anything to the discussion thus far?
Yes, I think that the mother's concerns are being voiced very, they're very clear, both in letters and in telephone contacts. And I think it is, I think it's not taken seriously enough in the autumn of 2019, where she's several times reports being worried, and she reports that she's seen him, that his place is in a very messy state, and there are notes indicating that he might hear voices. And I think she's the best observer. And I think Joel might at that point be able, in a short or maybe also a little bit longer conversation, be able to mask the real state of his mind, so that that Michelle's report might actually be the most accurate reflection of how he was at that time.
I'm going to return to that, Professor Nelson, shortly. Sorry, I'll come back to October 2019 shortly. Chronologically, we know that there was a second opinion in 2015 from Dr. Stevens in relation to reducing Clozapine or continuing to wean down from Clozapine. I'll come to the decision to wean entirely off Clozapine. Between 2016 to 2018, in general, Mr. Couchy was presenting well. There were regular letters from Dr. Boros-Levac to his GP indicating that he was presenting well, and some of those letters referred specifically to the fact that Michelle Couchy was supportive of him reducing his medication and reporting that he was doing well. Is that a fair summary? Sorry, Professor Large, did you?
So in the letter of 2015 from Nikki Stevens, and this is the first entry that I can find about stopping Clozapine, She says, I've discussed with Joel and his mother today the potential risk and benefits of stopping clozapine medication. It's the first time this emerges.
Yes.
Risk of relapse of positive symptoms, also exacerbation of negative symptoms, and the attendant impairment of functioning and disruption of his ongoing study and lifestyle. The benefits of the trial off clozapine, OFF clozapine, and she talks about the benefits there. So that's where this is introduced into the file, at least in the letter from Nikki Stevens. So that's the first thing I want to say. The second thing, that, you know, psychiatry always occurs in the context of uncertainty. That's really what we're dealing with. And to just take this to some more neutral territory, it's very frequent that a patient will say they don't have suicidal ideas. When a patient does tell us they have suicidal ideas, that tells us something, but it doesn't tell you all that much. If psychiatry starts getting into the territory of like second guessing or thinking we can read the patient's minds, then we've become insane.
Dr.
We
Large.
have to listen to what our patients say.
Sure.
That's the primary starting point. There may be distractions from that, but that is the starting point.
In that letter of Dr. Stevens, there's a discussion referred to about the risks and benefits of stopping clozapine. The decision at that stage was very much that if clozapine was stopped, another antipsychotic regime would still continue. Am I right?
Yes.
So there's no suggestion of weaning Joel off all medication at that point in time.
It talks about stopping clozapine.
And certainly the letter that I took you to earlier from Dr. Borislovac, in terms of the second opinion, was that her aim was to determine what the optimal dose of clozapine was, or if there was another antipsychotic regime. But her belief, as expressed in 2015, was that Joel would need to be treated on long-term antipsychotics.
Yes, that was her belief.
A decision is made in 2018 to remove Joel from the clozapine and entirely, and I just come to that. Might I have page 170 on tab 793? This is the termination of treatment form filled out by Dr. Borislovac. And if you scroll down, please, in that letter, earlier, if you can take it from me, it says no event except discontinuation of clopine due to successful treatment, and then ceased due to medical reasons, which are determined to be recovered from first episode psychosis and remained well with no relapse over the past 16 years, exclamation mark. This is in 2018. 16 years takes us back to 2002. Dr. Nielsen, that's not a correct characterisation, is it, at that stage, that Joel had remained well with no relapse over the last 16 years?
He's been pretty unchanged, and in fact she's observed an improvement according to her. There's been no acute relapse, there's been no acute admissions to hospital. There was the minor relapse in about 2007, 2008 with the changed formulation when there were more symptoms, but the only disagreement would be characterising his illness as a first episode psychosis. It's a chronic psychosis, but no, I generally agree that he hadn't had an acute relapse.
Professor Harris, do you agree with Professor Nelson that it's not correct to describe it as first episode psychosis, but he hadn't had a chronic relapse, an acute relapse?
Yes, I do. This is not a first episode psychosis. He has schizophrenia and it's a chronic illness. And he'd had continued symptoms for the majority of the 16 years that of which he'd been treated with clozapine.
Professor Nordentoft, I think you...
Yeah, I would just like to add to that. I think it would be wrong to characterise him as a patient with first episode psychosis. It's far beyond that. It is a chronic condition. And I also think it's slightly misleading to say no relapses. And of course, there were no relapses, but it was because he was psychotic. So there could have been exacerbations, but it's not correct to state that there's been 16 years without relapses. There's been 16 years, and in many of those years, he's been actually psychotic. And for the last maybe 4 or 5 years, he was not, or at least it was not detected. But he was not seen as psychotic for the last years. And in that period, you could say he did not have relapses. But before that, I think it would be wrong to call it no relapses, because you cannot have a relapse if you are already psychotic.
Dr. Heffernan?
Just really to reiterate that the context of the word well, and I think it, if it's defined by a readmission to hospital, then that's why that word might be used. But if it's defined against the general population, you couldn't use that word, because you would have to say, a period of negative symptoms, cognitive deficits, social deficits, and episodic psychotic symptoms.
And do you agree with the view expressed by Dr. Nelson, Dr. Harris and Professor Nordentoff that this is not described as first episode psychoses by this point?
No, it's not a first episode psychosis.
Professor Large?
Look, I agree, it's not a first episode psychosis, but he hasn't had a second episode of schizophrenia. So it's definitely not first episode psychosis, but he's had this prolonged, fluctuating, I hesitate to call it first episode schizophrenia, but he hasn't had a second episode, and 2 comes after 1.
But I think you agreed that he suffered from chronic schizophrenia.
Yeah, of course.
Yeah. Can I ask you a question about the Abilify? Staying with the decision to remove him from all Clozapine, Dr. Nelson, you express a view at paragraph 136 of your report. Given the long therapeutic relationship and the risks associated with ceasing antipsychotic, I withdraw that, that's in ceasing antipsychotics entirely. In relation to the decision to cease Clozapine, in hindsight, it appears obvious as a mistake. Is that your view?
Yeah, in hindsight, of course.
What do you say about the decision to trial, at least, removing him from all Clozapine?
Well, again, it seems to have been made very much with Mr. Couchy's wishes, and there seems there was a good and ongoing therapeutic relationship where maybe Dr. Borislavac was confident that if it was needed again, it could be resumed. No, I don't disagree with going along with his wishes the way he was reported to be.
Is it your view that Joel needed close monitoring from that period of time, given the risk of relapse that we've talked about this morning?
Yes, yeah, ideally, and including after the cessation of Abilify as well.
And that's the view of the panel generally, as summed up by Dr. Nielsen. Is that fair? Dr. Heffernan, you're nodding. Dr. Harris? Dr. Large?
Look, I think after such an incredible event, we're all subject to outcome bias and hindsight bias, and beforehand we were subject to the biases associated with prospect theory. But it was within the guidelines, the college guidelines for the cessation of antipsychotics. If you go down, it goes all the way down to Clozapine, and then it goes back up to stopping. If you've been stable for 2 to 5 years, around 90% of the relapses will occur in the first year, so you definitely should monitor for the first year. It's a very tricky decision to think about it after the tragic events.
Dr. Harris, 90% of your statistics are that 77% of relapse will occur in the first year, 90% in the first 2 years. How long do you think that somebody should be closely followed up in Joel's position, where you had acute psychoses as a teenager and ongoing symptoms as described?
One of the issues that's slightly complicating this is that Dr. Borislavac reduced his medication to very low levels for some time before it was finally stopped. So he was on 50 milligrams in July of 2000 of Clozapine in 2017, and on 25 milligrams from January of 2018. So no one knows exactly what his bottom therapeutic level was, but he was on a very low dose of the Clozapine, which is likely to have been ineffective for a prolonged period of time. And so in the middle of 2018 and when the date for the 12-month follow-up should start is a little ambiguous, because he's likely to have been on a very low dose and possibly an ineffective dose at that stage.
He was on a low dose, but it was supplemented with Abilify.
That's true, but it was also a very low dose of the aripiprazole or Abilify, yes.
Dr. Nielsen's given an example of somebody who is being managed very effectively on 100 milligrams of Clozapine. In that case, does that suggest that in fact very low doses can still be effective in managing?
Yes, and that's also my experience.
Professor Nordentoft.
Yeah, and I think we cannot know what would have happened if he would have stayed on a very low dose of Clozapine, and we cannot know what would have happened if he would have stayed on 5 milligrams aripiprazole. But the problem starts shortly after him being weaned off aripiprazole. So it could have been that just continuing with aripiprazole, I don't know, it would have been extraordinary if that would actually be enough, but it's not impossible.
Can I come then to the decision to stop Abilify? Sorry, just before I do, on page 85 of our documents, we see a letter from Dr. Boros-Levarch dated the 1st of June 2017 to Dr. Grundy. That letter again expresses a view that Joel suffered first episode schizophrenia 17 years ago and has remained sustained full remission for the past 15 years on Clozapine, which has been gradually discontinued. There's a collaborative decision, she notes, to wait another 1 to 2 months before the next medication regime. Can I suggest to you that what we see in this correspondence is a continual referencing by Dr. Boros-Levarch back to Dr. Grundy that Joel is doing well, that he had first episode psychosis and that he's been in full remission and is doing very well. I'll come to the relevance of that again shortly. So the Abilify was stopped in June 2019, and we see a reference to that on the 12th of June, page 31, seen with mum, re-stop Abilify 5 milligrams in the morning. Mum agrees that since Clozapine was stopped a year ago, his son has become totally well with remission of his psychosocial disability. I pause to note, Dr. Nelson, there's clear reference to the fact that Dr. Boros-Levarch has high regard for what mum is noticing at that time in terms of him doing well. Do you agree?
Yes, yes.
It goes on to say, thank you, he's been caught up with his developmental delays. It records this: only problem has been residential complex tics involved in his sternocleidomastoid muscles, causing his neck to turn involuntary to the right with associated facial and ocular grimacing. His tics were worse on Clozapine. We go on in the records throughout 2018 and 19 to see that Joel's tics come and go, but at some point are such in 2019 that it might be an indication that Dr. Boros-Levarch feels that he might be hearing voices to one side. What relevance are the tics, Dr. Heffernan, to trying to understand whether or not Joel is experiencing a relapse?
Well, the tics are a difficult thing to assess, and I think we have to put a differential diagnosis around those tics. We read about them, obviously none of us have seen them, but the differential diagnosis would include that this is a true motor tic disorder, and in someone who's got schizophrenia, who's got OCD, there is an overlapping Venn diagram of these problems. So that's one. Number two is that the tics are related to antipsychotic treatment. And number three is that the tics are actually a mannerism that's associated with experiences of psychotic symptoms. So we have to broaden, and there's probably 4 and 5, which I haven't thought of, but others may. But so we have to sort of broaden our thinking about what actually are these tics, and the context is going to be relevant. So and the appearance of them will be relevant. So it's possible that they could reflect a psychotic process.
Can I take you to an entry on the 28th of November 2018? I might just continue with this unless Your Honour wants me to stop. So page 35, 28th of November 2018. This is a consultation with Dr. Boros-Levark. It says he presented for a face-to-face appointment. Joel seems out of sorts, apparently upset after appointment with Dr. ABL. Sorry, that's Andrea Brooks, the nurse, noting that. And same discussed with Dr. ABL. Mother has contacted this service today, concerned that Joel is out and about too much, never home. She feels it's too stressful, an event for Joel to consider study for community services, etc. If you could look at page 36, there's a consultation notes of Dr. Boros-Levark. He presented well, energised and confident, but also vulnerable. She later goes on to note, he's keen to meet a girl that he can marry and start a family with. Mental state was apsychotic, euthymic, but exhausted, with a new mannerism of a complex tic of frowning towards the right and then bringing his gaze back into the conversation, like he was responding to an NAS. What does that acronym stand for, Dr. Heffernan? NAS?
Oh, I was hoping you wouldn't ask me that question. I'm thinking that it's a not apparent stimulus, but I could be wrong there.
Do your colleagues agree? That's what makes sense or something like that makes sense in the circumstances. When confronted, he was grateful for it and explained his behaviour of fighting with breaking down emotionally, then cried with his head down from exhaustion, as he's been well aware of doing too much. He's on Abilify 5 milligrams in the morning still at this stage, but he's been off Clozapine for about 18 months. What would you make of, 12 months altogether. What would you make of those symptoms, if anything, Dr. Heffernan?
Well, you know, anyone that has an apparent tic, that's a concerning thing to start with. The second thing is that the way that that's described in Dr. Boros-Levark's entry makes me think that the differential should be reshuffled such that at the top of my differential is, well, maybe this is a psychotic symptom, because in the context, he's no longer on antipsychotic medication, it suddenly reappeared, and the description suggests that rather than the phenotype of a tic, it's more a gaze and a concerned look, which disengages him from the conversation. So that would be more consistent with a psychotic symptom. But I think we just have to put a caveat around that to say that none of us would be certain.
All right, something to closely monitor, but you couldn't be certain what that involved. Do your colleagues agree with that?
Yes.
All right, I'm going to jump forward then. I'm sorry, beg your pardon.
I mean, if a patient with schizophrenia on antipsychotics, even if they're having a reduced dose, presents with a movement disorder, the most common explanation for this is that they are developing tardive dyskinesia or even tardive dystonia. That's the single most probabilistically. I mean, there might be some things that you observe about it that make you think that it's something different, but he's had nearly 20 years of exposure to antipsychotics. He may well have had withdrawal emergent tardive dyskinesia.
Can you explain that in layperson's terms, please, Professor?
Tardive dyskinesia is an involuntary movement disorder that occurs as a dose-response curve to antipsychotic medications. Older antipsychotics are more likely to cause it than newer antipsychotics, but older antipsychotics had an incidence of about 5% per year. Typically, it involves orofacial movements that are, their lip smacking, blinking, involuntary movements, pill rolling of the fingers. It's a real problem with older antipsychotics, but is not unknown in newer antipsychotics. Most patients who have schizophrenia are actually not very aware of it and doesn't trouble them particularly, unlike patients with mood disorders who are often extremely troubled by it. It's socially stigmatising. It tends to get worse. It is dose dependent, so the more antipsychotics you're given, the more likely you will develop tardive dyskinesia, and there are people who have such severe tardive dyskinesia that you make a judgment that they should be off antipsychotics and tolerate their auditory hallucinations.
Would you expect to see that when Joel had been off Clozapine and on your evidence on a very low dose of Clozapine such that it might not work some 2 years later?
You might not expect to see it, but you wouldn't be at all surprised.
All right.
I still maintain that the most probable explanation of a tic disorder in any patient with 20 years of exposure to antipsychotics is tardive dyskinesia and not a psychotic symptom.
Dr. Harris?
Well, certainly I agree that with any patient who's been on antipsychotics for a prolonged period of time, tardive dyskinesia or a movement disorder caused by the antipsychotics is a real possibility. Clozapine is the antipsychotic least likely to cause this particular disorder, and in fact, one of the reasons for starting someone on Clozapine is significant movement disorders such as tardive dyskinesia. Aripiprazole, in my experience, can cause tics such as this, and I think it's actually more likely that it was, if anything, due to the aripiprazole. Clozapine has a very low propensity towards causing tardive dyskinesia.
Professor Nordentoft?
Yeah, my first thought was that it could be tardive dyskinesia, and it's actually Clozapine is sometimes used to treat tics. So I think the fact that it occurs after Clozapine being tapered off, it does not. It does make it likely that it is tardive dyskinesia, and I also think that the description of this with the sternocleidomastoid, the muscle, it is in agreement with this suspicion of tardive dyskinesia.
Professor Nordentoft, what
But
about
whether it could be hallucinations as well, but I think tardive dyskinesia would be the most likely.
what about the level of distress that is reported by Joel and recorded in that note that appears to be an unusual sign? Would you be concerned about that as a psychiatrist in terms of the return of symptoms?
I would be concerned, and I would think that feeling stressed is it increases your vulnerability for a psychotic relapse. So I would definitely be concerned.
Come to one of the main issues. I'm going to present to you a list of the symptoms that are noted around the time of September or beyond September 2019 and ask for your opinions separately after that. Can I bring to your attention that in September 2019, Joel was reported to have difficulty sleeping. So just a reminder that Abilify had been ceased by June 2019. That's from the benefit of my friends, page 29, 20th of September, reported difficulty sleeping. Sorry, I know I'm going to go till 1 o'clock unless anybody stops me. I'm getting some mutterings about a break, Your Honour. I'm about to go to the point where I put to the panel the evidence of Joel's decline from September 2019 through to February 2020. What it might be helpful to do is to take the break now and to ask the panel if they would mind to refresh their memory over the break of the details of that, which appear page 141 and 142 of the clinical notes and page 20 through to page 27 of the clinical notes. Would that be convenient, Your Honour?
We'll take the break. We come back at 1:30 then?
Thank you, Your Honour.
Thank you. We'll have a break.
Please all stand. stand. This kindness court is now resumed.
Thank you, Your Honour. Panel members, before I ask you some questions about symptoms noticed from September, I note that if you take it from me, that at page 115 of the My Mind volume, there's a note to Dr Grundy from Dr Boros-Levark, which says, seen with mum, re-stopping Abilify 5 milligrams in the morning. Mum agrees that since Clozapine was stopped a year ago, son has become totally well with remission of his psychosocial disability, etc. The plan was then collaboratively decided to stop Abilify 5 milligrams in the morning. I started before the break to run by some symptoms some 3 months later. On the 20th of September 2019, a nurse notes, sleep not as good lately, had melatonin, cut it back, mood good. On the 17th of October 2019, Dr Boros-Levark saw Joel. If you take note of this date in particular and some others that I point out to you until March. 17 October 2019, Dr Boros-Levark, seen with Brooksy, re-mum's concern for relapse. Joel's mother rang admin and reported her concern for Joel's mental health and physical health, and she told Joel to keep the appointment after he had cancelled it. Dr Boros-Levark, when she sees Joel, feels that he's good mentally, but mum had raised that concern. On the 31st of October and the 7th of November, Joel was seen by nurses and was not shown to, and they did not see any signs of mood disorder or psychosis. On the 14th of, I'll go back a step, if you could take note of this date, on the 12th of November, Joel sent an email to the practice. It said, "Hi, can we please cover some ideas for a porn-free phone and other devices currently using Hotspot on Thursday? I will consider a porn-free ISP if the cost is reasonable as well. If seeing a specialist is what you recommend, I will consider with that the same. I want a totally porn-free internet on my devices if possible, on all browsers and potential browsers," and he lists them all and includes images. On the 14th of November, 2 days later, when Dr Boros-Levark saw Joel, she records that he was insomniac. He accepted a short dose of Zopiclone for sleep. He said, wants to stop use of pornography, opposed to religious beliefs. Email noted and discussed, given information on how to block sites. Before I come to the other symptoms that he experienced from that time, the email that he sent on the 12th of November was does the panel agree, is the first of its kind to the reception. That is, Joel reporting his own concerns in relation to his use of pornography and later reporting that it conflicts with his religious beliefs and was causing him stress and he wanted help removing it from all devices. Dr. Large, if this was Dr. Nelson, if this was your patient who had been seeing you for some time, given his background of schizophrenia, would you be concerned about his own reports of excessive use of pornography and how he was keen to block it?
And look, it's hard to say generally. I'd really have to, think about the patient, the individual in front of me. I mean, it seems unrelated necessarily to psychosis, but being communicated with for the first time suggests some sort of change.
Right. And so is this fair to say, rather than pulling out individual signs or symptoms, it's important to look holistically about what some of the indicators might be towards a decline in mental health?
Exactly.
The panel are nodding, I take it that is uncontroversial. Is that right? In relation to this issue, though, of pornography, there are many people in the community who use pornography legally and without criticism. But in this case, is it significant that Joel was reporting that he was potentially stressed by it? That is, he wants help removing it from his devices, which suggests some sort of compulsion, and it conflicts with his religious beliefs, which might cause stress. Is that fair, Dr. Nelson?
Yes, yes.
Does the panel agree with that? Professor Large?
One other thing, antipsychotics can raise your prolactin level, which has effects on sexuality.
Sorry, Professor Large, could you speak up?
Sorry. Antipsychotics, including low doses of, all antipsychotics can raise your prolactin
What does that mean in layperson's terms?
Prolactin used to be, dopamine used to be known as prolactin inhibiting factor when I was a medical student. And raised prolactin levels do change your sex drive, and it's possible that there was an emergence of his sex drive once he'd stopped or was stopping antipsychotics.
Professor Nordentoft is nodding behind you, Professor Large. That corresponds with your understanding of the research, Professor Nordentoft?
Yes, I think that decreasing libido is a common side effect from antipsychotic medication. And when it's then weaned off, it's likely that his sexual desires will come back.
Was that, Professor Nordentoft, something that his mental health professionals, particularly psychiatrists, had to be wary of, given the potential conflict that would cause in Joel because of his religious beliefs and the compunction to look at pornography?
I think actually to be attentive of the sexual desires and sexuality all through the treatment should be something that you should be aware of it. Also because for many patients it is a reason why they want to stop antipsychotic medication, because it impedes sexual life. So I think there should be attention to it both while patients are treated, but also when treatment is terminated.
There is, of course, a healthy sexual interest and an unhealthy sexual interest. Professor Nordentoft, would you expect that to be a concern of his psychiatrist, given the extreme symptoms that he'd experienced previously, which included threats of violence back in 2000 and 2001?
Of course, I think it is a warning signal, but it's very unspecific, actually. So I'm not sure how much attention I would pay to it. But there are several. It's also the fact that he suddenly wrote a text message to the other psychiatrist asking about men's sexual performance, and that was inappropriate. I think you would think that something's going on, and we know from his phone that later on a lot is going on,
yes.
But we do not have reports from his phone already in 2019.
No. But in January, we don't know what his phone said at that, might have revealed, but in January of 2020 was the text message to the psychiatrist, Miss Alen Pavijevic, when Dr. Boroslavak was away, but that was an odd text message about sexual performance. And seen on the back of that email that he sent in November about concerns about pornography was a red flag. Is that fair to say, Professor Nordentoft?
Yes.
Let me just come...
A rather unspecific red flag, but it is a red flag.
Right. Let me put it together with some other red flags, can I suggest to you? On the 20th of November, I'll withdraw that, going back a step. So 17th of October, he was seen with a nurse and his psychiatrist in relation to mum's concern for relapse. On the 14th of November, he was seen by Dr. Boroslavak in relation to and reported insomnia and wanting to stop the use of pornography. On the 20th of November, his mother sent an email to Dr. Boroslavak, which is at page 141, which read, "Dear Andrea," that can come up on the screen if you may. Page 141, "Hi, Dr. Andrea. I'm contacting you about my son, Joel Couchy. He isn't doing very well since going off Abilify, and I know you thought it wasn't having any effect, but I have noticed a gradual decline in his condition, and judging from notes on paper he's left around the place in the past week, I have a feeling he's now hearing voices, etc. He's very distracted, forgetful, and the OCD is getting out of hand with him going through half a cake of soap in one shower. He found out last week that the place where he volunteers teaching English put someone new on, and he'd been hoping to get a job there, so that was a real blow. I would hate to see him have to go back into hospital after 20 years of being stable when on medication. But of course, being off it has made him realise how sedating it was, although I think that it was the Clozapine that did that, not the Abilify. Also, he's at a loose end now that he's finished study. He quite possibly won't let on what is going on in his head, but I think you need to know how he is. I would appreciate if you wouldn't tell him I've contacted you, as I don't want him cutting off communication with me, and I'm the one who looks after him when he needs it. I would like to see him be able to successfully live independently and be doing as well as he was a year ago when he first moved out of home. So I'm going to read you a clinical note after that, but in this, Michelle raises he isn't doing very well since going off Abilify. Judging from notes around paper left around the place in the last week, she had a feeling he was now hearing voices. He was distracted, forgetful, and the OCD was getting out of hand, and she reports a gradual decline in his condition. On the 20th of November 2019, there's a record of a consultation with the nurse. It's page 25. Reports from those known to Joel of changes in behaviour. He's having extreme OCD with showering and washing himself, using half a cake of soap during one shower, writing a lot of notes +++ at home and leaving them about. Mother read some notes with content of under satanic control, of religious themes, desire for porn with conflict of his religious beliefs and wanting to access porn. Leaving his phone with his mother at her home overnight so as not to use phone, internet for porn sites. Mother reports he is walking funny, change in his gait. He reports he's afraid of getting sick and wearing layers and layers of clothes to prevent getting sick. He's been observed that he bends his head a lot and has odd movements. Reports he's very busy but unsure what he's doing with his day, wanting connection and relationship. Mother does not want Joel to know she's raised concerns of deteriorating mental health with staff. Possibly hearing voices has been considered, and staff at My Mind noted unusual new behaviour with respect to his wanting coffee. I'll just pause there. Does the panel agree that this sort of behaviour reported from Mother is very different to the reports of Joel when he was well, including as at June 2019, as reported back to the general practitioner? Dr. Harris?
Yes. They suggest that he is having a relapse, that he's having changes in his behaviour that suggest not only positive symptoms but a relapse of his obsessional symptoms, but also the movement disorder that was highlighted earlier about by Professor Heffernan as one of the symptoms of psychosis.
Dr. Heffernan, do you agree with your colleague, Dr. Harris?
Yeah, so I had examined, as I'm sure everyone did, this period quite closely.
Yes.
They're all subtle things. So each one of their own could be dismissed, although some of them are much more concerning than others. But when you collectively put together, and I counted 9 different entries that were entries of concern, either about insomnia or mother suspecting symptoms or change in behaviour, satanic control, preoccupation with religious themes. When you start to put them all together, to me this is flags, well, we're probably having a psychotic relapse here.
And when you say 9 different entries, do you mean in that one medical note or from September through to February?
From the period of August 2019 until February 2020.
Professor Nordentoft, do you have anything to add to that? Or do you agree with your colleagues?
Yes, I agree that there are several red flags, and I think the most important ones are the concerns raised by his mother, who is the one who knows most about his condition, much more than can be revealed through a rather short conversation with the psychiatrist or the registered nurse. I think there's a missed opportunity in this period because actually the nurse had a discussion with him where he agreed to start antipsychotic medication,
Yes.
and it should have been reintroduced at that time.
And I'll come to that shortly. You recall one of the notes there that was raised by Mum in her email and then in the consultation is that she had found a lot of notes +++ at home and leaving them about. Mother read some of those notes with some content of under satanic control of religious themes, and she reported her concerns that he was hearing voices. When Joel had his first episode of psychosis, the panel will recall what I took you to this morning, that he, on January the 26th, 2001, he put a hole through the fly screen door, claiming he was distracted by demons. He was observed scratching and to pull out a demon or devil. So those satanic voices and the agitation were features of his first episode of psychosis. Does that make it particularly concerning, Professor Nordentoft, that mum is reporting satanic notes?
Yes, I think it's not always that the same symptoms reoccur when there is a relapse, but the fact that it is exactly the same symptoms is really concerning.
I'm conscious of moving through the evidence, but Professor Large, do you agree with that?
Look, there were concerning things that required some further investigation.
The next day, when Joel is seen in the clinic by Miss Brooks, she's seen by a nurse initially, not Dr. Broslevac, but when he is seen by a nurse, she notes, under examination, usual dress presentation, well-groomed, poor eye contact, evasive in directly answering questions, long replies, only vaguely answering questions, denies hallucinations, denies thought issues, confirmed memory issues, short-term memory, looks to the left side often quickly with eyes pointing up, nil tics observed. Joel has difficulty explaining himself and repeats his words, speaks slowly and deliberately with no substance to topic, skirts around the issue. Thoughts, preoccupied, not expansive, denies themes, complains of excessive tiredness. Does that suggest, Professor Large, that the nurse herself is also noticing some red flags?
It does, but it does, but she wasn't able to elicit hallucinations or delusions. So it's sort of intermediate, a bit of an intermediate result.
You just heard Professor Nordentoft say that the mother, who was regarded as a reliable historian and helpful, the mother would have been in a better position to notice that than a short-term clinic assessment. Do you agree with that?
I think that at the end of the day, you've got to take the information from the patient and from other sources, and then you've got to be able to explain to the patient why you're doing what you're doing. And that was a bit tricky because there'd been please don't tell Joel this. So I think that did inhibit that conversation. This is a voluntary patient. I think they were in a process of gathering information at that point.
It's the evidence thus far is that Dr. Boroslevac and the nurses took the mum's concerns at face value. That is, that they regarded her as a reliable historian.
Yeah.
And do you see there under plan, Joel is to return again the next day after thinking about his ADLs and self-reflection. Can you help us with the acronym of ADLs?
Activities of daily living.
Thank you. So this is at page 25, Dr. Harris. He wants peer support, has next appointment. He agrees with the reintroduction of psychotropics, but desperately wants to avoid sedation. The panel will have seen that although he didn't see Dr. Boroslevac on that day, Nurse Brooks had a conversation with Dr. Boroslevac, and the plan recorded is Abilify tablets, 10 milligram, 1 in the morning. The evidence from Dr. Boroslevac is that that's a typographical error, and she had intended half of that, 5 milligrams, although she had never written it that way previously. But regardless, there was a plan to return to Abilify. Joel appears initially to have agreed with the reintroduction of psychotropics. And then you'll see page 24, there's something that occurs subsequently, but I'll just pause there. In relation to persuading Joel at that time to take antipsychotics and Abilify at 10 milligrams or 5 milligrams, Dr. Harris, was that an appropriate response to the concerns?
That was a reasonable response to restart medication and to restart aripiprazole as it represented the easiest path back into using an antipsychotic medication. Both Dr. Boroslevac and Mr. Couchy had gone through several years of trying to stop medication, And to restart at this stage was really something which I'm sure Mr. Cauchi didn't want, and it's also a defeat, I suppose, in some ways for the treating team, that this would have been very disappointing for them at that stage. But the choice of aripiprazole at 10 milligrams would have been a standard starting dose for somebody with psychotic illness.
So 10 milligrams was
10
the starting
milligrams
dose.
would have been the standard dose to commence for somebody with schizophrenia who was not on medication.
If the decision is in fact 5 milligrams, because she had intended to have a half tablet, would that have been appropriate or not?
He had been on 5 milligrams and been unwell, so in Dr. Borislavak's experience, it might have been that was a reasonable dose, that he'd stayed well for quite a prolonged period of time. But to restart medication is the important point at this stage.
Would you consider at that time going back on Clozapine as an option, given the severity of the symptoms as reported by mum?
Not necessarily. I think it would have been reasonable to trial an alternative medication at this stage, and recommencing Clozapine is a process. It requires baseline testing. They wouldn't have in fact been able to start Clozapine just with a script. It would have taken probably at least 10 days before the bureaucracy of starting Clozapine would have been completed. So starting with the medication that he'd last been on is a reasonable one.
Dr. Harris, for a patient who has been doing well or appears to be doing well and then has an apparent relapse into psychotic symptoms, does it make more sense to you to put them on a 10 milligram of Abilify if you believe that these are psychotic symptoms?
Yes, it does.
Professor Nordentoft, the plan at that stage was to reintroduce psychotropics, which Joel initially agreed to on that day, and to have him followed up on a weekly basis by the nurses, and to have Abilify either at 5 milligrams or 10 milligrams. Dr. Boroslavak did not actually see him in person until the 8th of January. So she did not see him until about a month and a half after the 20th of November. Just taking, and I should say Joel then changed his mind and said that he did not want to go on medication. Was that sufficient response at that time to what Mum had drawn attention to?
Well, I think that might be the situation where the vulnerabilities of a private system would be obvious. I don't know what kind of options they have had, but I think if I was presented to something like that, I would have put quite an effort to try to persuade him to really start and also monitor if it happened. And I think 5 milligrams is better than nothing. And given that he was very eager not to have something that was sedative, I think Abilify would clearly be better. And I agree with Dr. Harris' concerns regarding starting with the Clozapine. That would be far too difficult. So I think it was an appropriate answer to say start with 5 milligrams. But monitor it closely and make sure that it actually happens.
All right.
28th of November was the consultation before January 2020.
So if you have a look at do you have the notes in front of you, yes. Professor Nordentoft? Sorry, and Dr. Harris does. You can see there, so I misspoke and said January, but it appears there that there's a note 28th of November 2019. It's a clinical consultation with Miss Brooks. Can you see if
Yes.
And the note there is clinical at 2:40. So she's seen initially by Miss Brooks at 3:17 and then seen by Dr. Boroslavak a week after Mum's concerns. So I'll come to that shortly. But on the 21st of November, having initially agreed to go back on the medication, there's a note that says face-to-face on his own today, he sees Miss Brooks. Phone call to the home landline to advise parents Joel has a script for Abilify but has chosen not to have it filled at this time. Information given to his father, who became adamant that he did not want his son to go on medication as it will kill him. Father spoke that he himself had been traumatised by demons when awake and hears voices and is not on medication. Professor Nordentoft, we've already spoken, this is no disrespect intended to Andrew Couchy, Joel's father, who has had his own struggles with mental health. But in circumstances where as a psychiatrist you want your patient, who's voluntary, to go back on to an antipsychotic, where his mother, who reliably reports symptoms, has reported satanic voices and her concerns, where a father then who's got mental health issues and psychosis says he doesn't want to go on his son, want his son to go on medication, what options would be available to you?
Of course, it's a difficult situation, but I think the mother has played an important role all the way through, so I will try to connect with her but of course it's difficult when the father is opposing and the son is more likely to not wanting to take medication. But I think I think still there is a room for persuading, and I think that should be tried out fully. But I understand it's a difficult situation.
Would it suggest, if you want your patient to go back on medication, that there is a need for some sort of family education of the father, of the mother, and of Joel about the risks of not taking that medication?
You want to object to that? That omits the reference in the chronology to the clinic contacting the mother on the 28th of November to seek her input in relation to this.
Yes.
Well, I'll stick with the father. Given the father's reluctance for his son to go on medication, if the psychiatrist believes that that is necessary because of the return of psychotic symptoms, is there a need to educate the parent who's reluctant? Professor Nordentoft.
We actually touched upon that previously. I think it could be tried, but I think the father has very firm views, and that would be difficult to influence.
On the 28th of November, Miss Brooks and Dr. Brostovac see Joel. Mum was contacted by telephone who told Joel to start Abilify for relapse prevention based on his early warning signs of relapse. Joel presented as well, feeling good with good sleep and no fatigue. He was going to Caloundra. He was not keen to start Abilify because of the dysphoric feelings on it in the past, but was happy to start Rexulti if not going well mentally to prevent a relapse of schizophrenia. Professor Heffernan, you can see there that Dr. Boros-Levac has an ongoing concern in relation to the risk of relapse. She hears what Joel says about his not being willing to start Abilify. She gives him, or the plan is to start Rexulti 1 milligrams in the morning and then 2 milligrams in the morning with a 2-week trial plaque, but to leave it to him to report symptoms. What do you think of that plan in response to the symptoms reported?
I think at this stage, there's been quite a few red flags about a relapse of psychosis, and I think this is where a more assertive approach in terms of encouraging restarting medication needs to be considered. And I think, it's very difficult when you have a voluntary patient, as most patients should be, to change a course that has been in play for some time. And unfortunately, it does involve having some hard conversations, and those conversations sometimes involve drawing a line in the sand about what you as a treating psychiatrist think is acceptable and what you think endangers that patient.
Dr. Nielsen, do you have any comment on that?
I mean, I think the thing that we can't know is how much Mr. Couchy pushed back against the advice. And my guess it's not just his father, it's he himself is quite determined. And perhaps the only thing missing really in Dr. Boros-Levac's notes perhaps might be a clearer account of his views and her attempts to persuade him, because clearly she wanted him to go back on medication and he didn't want to.
Given Joel's reluctance to go back on medication, would you as a psychiatrist have to have a high index of suspicion that he might be masking symptoms at that stage?
Oh, most definitely, yeah. And I mean, look, it's clear that he's relapsing, but how urgent it is to treat it isn't quite as clear. And then suddenly we've got COVID and he's moved to Brisbane.
I'll come to that shortly. Dr. Harris and Dr. Heffernan, you agree with Dr. Nelson's perspective so far? Yes. Professor Nordentoft, you wanted to add to that?
Yeah, and I think there might be, on a systemic level, also the question about compulsory treatment, because as I understand, there are differences between Denmark and Australia on that point. In Denmark, we would be able to actually activate compulsory readmission if the flags were, if we had sufficient amount of red flags. I've been in that position myself with a patient I've tapered off, and then the symptoms started to re-emerge, and I had to admit him against his will.
And is that in circumstances, Professor Nordentoft, where there is no direct evidence of a threat to either self-harm physically or harm somebody else physically?
Yeah, in that way, the legislation is different. In Denmark, it's possible to compulsory admit a person who is having psychotic symptoms, and where it's judged that these psychotic symptoms cannot be relieved unless the person is admitted to hospital and treated. So that's a different on the systemic level.
I'm conscious that we don't have you for much longer, Professor Nordentoft. So is it your view that is the circumstance for all mental health disorders, or just for a number that are in a particularly serious category?
It's not determined on diagnosis. It's determined of severity of symptoms, and the doctor who should make this declaration regarding the readmission or the admission should state that it is a severe psychotic condition that cannot be treated without admission. So that's the legislation in Denmark.
I'll come to you shortly, Professor Large, but Dr. Harris, given your description of the risk of relapse for patients that are taken, or for patients that have experienced psychoses, do you think that Australia should be considering legislation like that, so that you don't have to wait till somebody is at serious risk to themselves or others if you determined that their psychotic symptoms are returning?
I think that that's a very difficult balance between the rights of the individual and the need to institute involuntary care. And I think in this particular state, in this particular situation, I would personally be uncomfortable with bringing in a compulsory treatment at this stage, which is certainly looks like a relapse, but it would be a very early use of compulsory treatment, in my view.
In response,
let alone the practical issues of the hospital system just not being able to cope with that number of people.
In response to what are the signs of relapse here, Dr. Boroslavak arranges for him to be seen weekly for a period of time until around the 8th of January, and then it goes back to monthly. Was there anything more assertive that could have been done within the private system?
Within the private system, being seen on a weekly basis over Christmas is actually, I think, quite by the nurses, quite an intense level of review. I think at this stage a referral to the public mental health system for some more assistance or review by that team would have been reasonable. However, I'm not familiar with the availability of those services in Toowoomba. So, but within settings of metropolitan New South Wales, and that would have been a reasonable thing for the private psychiatrist to do.
Professor Large, I'm going to whiz forward to February and do a bullet point of the symptoms that emerged between November and February, but is there anything else you wanted to say in relation to what was evident as at the 28th of November?
Yes, I wouldn't have called for a family meeting. I think that would have very likely had the effect of creating a split within the family and increased emotion. I think it was quite reasonable for the doctors to communicate separately with mum and dad. So that's the first thing. I think that's the main thing I'd have to say. With respect to, this is going to sound tricky, what I'm going to say next is, if he was having a relapse, and it looks like he might have, and you're in this situation, if you referred the patient to from the private sector, if you refer the patient back to the public sector, you'll probably never see them again. That's been my experience as a private doctor. If you write a schedule or refer them, that's the end of your relationship with them.
So you can, what you would do is try to maintain your therapeutic alliance with the patient.
Absolutely.
And your alliance with mum, who you know is really critical to him staying well, correct? Yeah. And you would also see signs in the notes of the My Mind nurses trying to alleviate mum's concerns because of the anxiety she has around her son relapsing.
And one other comment. So words are starting to matter here. And we don't have a private psychiatric system. We have a private psychiatric sector. We don't even really have a national public system. We have a series of state systems, but we don't have a private psychiatric system. There is no system. There's just individual practitioners. And here what was unusual is there was something of a system in that there were nurses involved, but most private practitioners have no system at all.
Professor Large, I want to just ask you about trying to work around the risk factor that Joel's father presented, accepting that he was a loving father and that Joel loved him very much and vice versa. Dr. Boros-Levac had decided that it was appropriate that he go on an antipsychotic medication. Information was given to his dad, who became adamant that he did not want his son to go on medication as it will kill him. Father spoke that he himself had been traumatised by demons when awake and hears voices and is not on medication. Isn't that a significant risk factor for Joel's relapse? That firstly, Dad doesn't want him to go back on medication, and secondly, Dad is himself somebody who is hearing voices?
That's been there all along throughout his whole course of his illness.
But isn't it of significant risk at this stage where Joel is exhibiting symptoms which include hearing spirit voices or satanic voices?
It makes it less likely that he would take his medication. But patients don't always take their medication. They don't take their asthma inhalers. They don't take their antihypertensives. They don't adhere to treatment for cancer. They don't have a mastectomy when they need it. I mean, we don't have acts for the compulsory treatment of other disorders, and there's a threshold in the Mental Health Act.
Yes, but Professor Large, the examples that you just gave of people not taking their medication might mean that it has an adverse impact on their own physical health. But what we know is a small number of people who experience psychosis go on to hurt other people, and it's catastrophic when they do. So it calls for a high index of suspicion, doesn't it?
It's also true of epilepsy. People don't take their anti-epileptics, but there's no act compelling epileptics to take their anticonvulsants.
But there's no connection between epilepsy and psychosis that goes on to result in homicides.
No, but people with epilepsy do harm other people during their seizures.
Can I come then to the ongoing symptoms that are exhibited? On the 4th of December, Dr. Boros-Levac notes that she's got a message to ring Joel's mum. Joel left the family and is in Brisbane, and mother feels he's confused. On the 5th of December, the next day, the nurse told Joel of his concerns that his mother had, and the psychiatrist and the mental health nurse, and encouraged him to take his medication. Joel was advised about compliance with his treatment and management plan, and Joel remained steadfast that he believed his medication was good. Sorry, that his mental health was good. On the 19th of December, so some 2 weeks later, Joel reported that he had plans to relocate, but doesn't see it as an issue because he could attend appointments in November. On the 8th of January, Dr. Boros-Levac writes this is page 21, seen with Brooksy, totally well and doing well, euthymic and apsychotic, enjoyed a month holiday on his own in Brisbane and on Gold Coast, has friends in Brisbane, moving to Brisbane, getting a room in a shared house and planning to find a job as an ESOL teacher in there. Parents are supportive, plan, congratulated for the progress, continue no meds, agree to monthly Skype appointments with me and monthly Skypes or follow-up or phone calls with Brooksy. That's the 8th of January. It's only a month and a half after Mum has reported those extreme concerns, including satanic notes, the funny gait, the confusion, and signs and symptoms have been noted by the nurses. Do you think that note reflects a significant enough follow-up as at the 8th of January, Professor Large?
Well, I think that was her assessment, and I've got no particular reason for thinking that that assessment was necessarily wrong. I mean, he may have been unwell, but lots of medical practitioners were seeing him at that time and in the following year, and not a single one of them really thought that he was psychotic.
Professor Large, is there any evidence there on the 8th of January of any follow-up with Mum, given her significant concerns?
No, I don't think so.
In those circumstances, do you think that that is sufficient, given that Mum, who is a reliable historian, has reported those concerns on the 20th of November that have been taken so seriously?
Well, I think there are two ways of looking at it. Probably it would have been better if there had been some contact, but I mean, Mum was not shy about contacting the practice if she had concerns either.
But Doctor, she'd expressed her concerns. The concerns had related in her being believed and a suggestion that he should take the antipsychotics that he wasn't taking. That appointment, can I tell you, was more than 75 minutes, and they're the notes taken on the 8th of January with no indication that Joel's mother is contacted. Is there any? Do you have any comment about that?
It's a short set of notes for a 75-minute consultation.
Dr. Nielsen?
Yeah, I agree.
What does that mean? It's a short set of notes. Does it give you any proper understanding of what his mental state examination was at that time?
Well, it sounded very glowing, really, her account. But you'd think that if she had spoken to him for that length of time, maybe some further signs of relapse might have become apparent. Given that they didn't go away, I don't think those symptoms went away.
Professor Nordentoft, this is the 8th of January. The 12th of November, I'll remind you, is the time when Mum had written the email and her concerns had been reported. Do you have any comment about the consultation on the 8th of January where Dr. Boroslavak noted that he was totally well and doing well, but there's nothing to suggest a conversation with Mum?
Of course, it would be better if the mum has been involved as well. But I see this as a sign of Joel being able to hide, either not having symptoms at that day or being able to hide it and present well. But it could have been revealed maybe if the mother has been involved.
Is it common for there to be a level of masking for patients who are clever but have suffered from the condition that Joel did?
I think we also the casualty I was involved in, he was actually also able to mask his symptoms. So even though he was seen by a lot of professionals, they didn't understand really, or they were not able to reveal that he had such psychotic symptoms that he kept held back. So I think it is a common thing that can happen.
I've got two further issues, Professor Nordentoft, that I'm going to put to you before you have to leave us. On the 14th of February 2020, so that's just a month and a bit after that January consultation, there's been a couple of consultations with the nurses where he's noted to present as well. But on the 14th of February, Michelle, his mother, called to express her concerns about Joel's functioning at home and his probable move to Brisbane. She said his self-care is poor. His father went round there to put the bins out and the place was a mess. There were dishes in the sink and mess everywhere. He appears more isolated and is irritable and is occasionally swearing. In this circumstance where there's concerns about his self-care, he appears more isolated. He's now irritable and swearing. On the back of her concerns in November about his satanic preoccupation with notes and hearing voices, and in December that he was confused. Do you have any view at that time about what was appropriate follow-up?
I think it is the same as in November. This report from the mother that everything is messy is just underlining that he is deteriorating. and that assertive approach. And but I think it must have been a real dilemma, because she has tried to persuade him to take antipsychotic medication, and he hasn't agreed. But I think it would really have been appropriate to try to persuade him again.
Can I suggest to you that her evidence at this time is that she believed him to be well in spite of Mum's concerns by the 14th of February. So she sees him on Skype on the 17th of February, just 3 days later. There's no evidence of a discussion with his mother, and she says, seen on Skype, well-groomed, good hygiene with no tics, mentally good, no signs of psychiatric disorder. At his parents' house, his flat is under renovation, sexually frustrated, can't hook up with girls at present. So after the 14th of February, when Mum reveals her concerns about him more irritable, swearing, his poor self-care, Dr. Boroslavak does not see him again in person because of the issues with COVID and his move. Given that he's about to move to Brisbane and the stresses that might come with that and the concerns expressed by his mother, was it reasonable to consider that he was well at that point in time by the 17th of February on the back of that Skype call?
I think it is a too superficial evaluation where the mother's concern is not taken into consideration to a sufficient degree. But could I say something?
Please.
Before I leave, I would like to mention also the incident where he calls the police years after.
Yes, I know that you'll have to leave us, so please, Professor Nordentoft, tell us what your opinion is of that occasion. That's the 8th of January 2023.
Yeah, it's the 8th of January, and it's repeated in February. Both times he calls the police because his father has removed the sharp knives that he has bought and eventually used in the mass attack. And I think his explanation to the police and the mother's explanation to the police is very concerning. And, you know, in Denmark, we have something called psychiatric emergency outreach, where psychiatrists can be called by the police or by staff members in supported housing facilities, and also families. And I actually have a duty in that service. And if I was on call and I was called to this situation, I would have organized a compulsory admission, because I think it was a clear message that he was psychotic, and also that he could be of potential dangers to others. Of course, the knives were moved away, but just the fact that he had so many knives and his psychotic logic about them, that if he didn't have the knives, he would go bankrupt and be homeless, become homeless. That's not a rational conclusion, that if you don't have a knife, you become homeless or you go bankrupt. So I think there was a clear presentation that he was suffering from psychosis at that time, much clearer than what was Dr. Boroslavak was able to see. But at this point, it was pretty clear. And I think the police, maybe they didn't have anything else to do, but then I think you should consider on a systemic level, could the police have better access to mental health examinations? And yeah.
And the reason for that is you would accept, Professor Nordentoft, that a trained mental health professional is in a better position than a police officer to do that assessment at that stage.
Yeah, and also to draw conclusions, because I think they were concerned, the police officers, and they wrote notes about it, but they didn't take any further steps.
Professor Nordentoft, can I stay with you for a moment for a final topic, which is in relation to discharge? I'll take the panel shortly after we've let you go to the letter that is written to a general practitioner, Dr. Grundy, in relation to discharging Joel back into his care. That happens in March, when Joel is no longer eligible for Medicare and his Skype call is cancelled. In
2020, because we've just been in January 2023.
Oh, sorry, going
Back 3 years now. Yeah.
Thank you. So just to remind you, there was a note from his mother called on the 14th of February and reported her concerns in relation to his lack of self-care, and she noted him to be aggressive, and she maintained her concerns about Joel's mental health decline. Dr. Boroslavak saw him by Skype on the 17th of February, and she satisfied herself that there was no longer a risk of concern in spite of what had been raised by Mum. When he was handed back to Dr. Grundy, the letter that was written to Dr. Grundy presented that Joel was well, and she did not record in that letter any of the concerns that had been outlined by Joel's mother from October through to February. Do you have a comment on that?
Well, I think it would have been more appropriate to report in that letter to Dr. Grundy that there were some concerns about risk of relapse, and that was voiced by the mother on several occasions. So I think also for Dr. Grundy to be able to take some steps, and as I understand it, he also ceased to see Dr. Grundy because he moved to Brisbane.
That's right.
So maybe his possibilities for doing something was also limited. But I think no matter whether Dr. Grundy was going to continue to have him under his care, I think it would be reasonable to write that there has been voiced concerns about risk of relapse.
So whoever was going to monitor Joel, is it your view that he needed ongoing close monitoring by a psychiatrist after February 2020?
Yes.
And
I think when you...
Please, you go.
Yeah, I think the recommendations to monitor people after cessation of antipsychotic medication is to look after them for at least a year. And I think I don't know if there are if there are rules in different countries, but we have the clinic I just talked about. They say 18 months at least.
In this case, Joel had been removed from his Clozapine in June 2018 and from his Abilify in June 2019. Are you suggesting that at least from June 2019 he needed to be monitored for a year?
At least a year.
That was done, and Dr. Broloslavac said that if Joel had not moved out of area, she would have monitored him for the rest of his life. But given the potential relapse, as reported by his mother, is it your view that he needed ongoing monitoring after March 2020 for the signs of relapse?
Yes, definitely.
And in Denmark, would that happen? Would it be ongoing monitoring by a psychiatrist or a GP?
Oh, I think actually it would vary. I think in some cases it might actually be transferred to the GP, and that might be insufficient. I'm not going to pretend that it is if Denmark is doing everything perfectly, but I think the recommendations are that it should be monitored for at least 1 year, and that would be by a psychiatrist. But it's not always practiced in Denmark either.
And when you say monitoring, given the symptoms reported by Joel's mother, at what frequency would it be appropriate to monitor Joel?
At least monthly, but I think when there are these symptoms, I would like to monitor it more closely. When I think of my own practice, I would be specifically aware also when there are such red flags. It might be weekly. But I don't think there are any firm recommendations regarding that, but I think that would be good practice.
Professor Nordentoft, do we take it that it might be opportune to reflect on the circumstances of Joel's relapse around this time and tighten up regulations or specifically amend guidelines around weaning clients who have had psychoses off medication?
I think that would be a good conclusion, to have a recommendation that the patient should be monitored at least 1 year after cessation of the medication.
What about this, though? That patients should be monitored for a period of at least 12 months at particular interval levels once they exhibit potential signs of relapse into psychoses.
But actually, I think they should be monitored also if they don't. But if they do present signs of possible relapse, it should be with shorter intervals. It should not be monthly, but with shorter intervals.
I'll just pause there. Your Honour, Professor Nordentoft now has to catch a plane to receive the World Health Organization Sasakawa Health Prize for Public Health. So I think she's leaving Denmark to go to Belgium to be awarded that prize, and that's why we're losing her after staying up all night.
Can I just say, Professor, thank you so much for making yourself available. It's been so valuable to have your input, and congratulations on the award you're about to receive. Thank you very much.
Thank you. Yeah, pleasure.
And, Your Honour, I should say that I note that my learned friends didn't have an opportunity to ask Professor Nordentoft questions, but she has offered to engage in the process of recommendations that might come as a result of the inquest, and I'm sure she'd make herself available to answer any specific questions.
Thank you.
In writing. Might I return then, panel members, to the issue of Joel's presentation as at February, March, and the options that were available to Dr. Barros-Levark at that time. I note that it was COVID and that Joel was moving town. Can I just put up on the screen the discharge letter that Dr. Barros-Levark wrote to Dr. Grundy? She notes there, "Dear Richard, I've received advice from Medicare regarding the parameters of their Skype eligibility. Unfortunately, Joel has moved recently and currently resides in an ineligible Skype area, and as such, I'm no longer able to offer Skype appointments. My receptionist has contacted Joel to advise of this change. Joel has indicated that he will be unable to attend face-to-face appointments with me due to the distance to travel from appointments. I'm therefore discharging Joel back into his and your kind ongoing care. Please recall Joel to discuss his options and referral to an alternative psychiatrist if required. In the future, should Joel move into a Skype-eligible area or wishes to see me for face-to-face appointments, I will be happy to. However, I need a new referral for that." So the letter that has gone to Dr. Grundy prior to this is the 12th of June 2019. It doesn't have to come up, but it appears at page 115. It says, "Mum agrees that since Clozapine was stopped a year ago, his son became totally well, with remission of his psychosocial disability." And then on this letter, there's no indication of any relapse for Joel. Dr. Harris, given the mother's concerns and the previous letters, do you have a comment about that?
Yes, I think that's one of the things that the mother and the father, in fact, were concerned about was the level of disorganisation when they saw Joel in his new flat in Brisbane. And that can be interpreted in two ways. It could be interpreted as a relapse, or it could be the flat of a young man who's never looked after himself and has just moved out of home. So in and of itself, it's not. I know there is a logic here from the point of view of his disorganisation and some of the other red flags, but some of the things that the mother and the father are contacting the practice about would be seen in most young men who move out of home for the first time. So I think that's something which needs to be thought there to a certain extent.
Sorry, I don't want to interrupt you.
Going back to the question, if you could...
Sure. I wasn't thinking more of the disorganised state of his flat.
Yes.
On the 20th of November, she reported that he had extreme OCD with showering, changes in behaviour, a lot of notes at home, that he had left notes that she'd read with content of satanic control of religious themes. He had a funny gait.
If we're going back to that, yes, I certainly agree that is there a series of symptoms very suggestive of a relapse of his soul.
And from November through to February, the mother is reporting symptoms of concern. That's the most concerning entry. But in February, she's expressing her concerns that he's more isolated, he's self-poor, his care, he's irritable and occasionally swearing. The last note that the GP's got in June 2019 is that Mum agrees Clozapine is stopped a year ago because her son had become totally well with a remission of psychosocial disability. So given that there have been very unusual concerns expressed by Mum since that time, would you expect them to be passed on to the person who's taking over Joel at discharge?
I think it would have been it would have been better to describe some of those factors and some of the concerns about that he may be having a relapse, yes.
Dr. Nelson?
Well, again, you know, it wasn't a complete letter in terms of the recent events, and I do know that it was written on the 19th of March, which is pretty much the week after complete lockdown. But yeah, it's insufficient.
Dr. Heffernan, you're discharging, at this point, Joel is being discharged from her care after some 8.5 years in circumstances where there's a significant risk of relapse as described by Dr. Harris, and in circumstances where mum, who's a reliable historian, has reported that she's concerned he's hearing voices and there's satanic notes and there's poor self-care and there's confusion. If you're discharging to a GP who you've previously reported for many years that Joel is doing very well and that mum is fully supportive of removing him from antipsychotics, would you expect to see that concern being reflected in the letter?
Yes, so I might just cover two things there. And I should say that I have a bit of experience with having to do this because of the nuances of the Mental Health Act in Queensland. As a treating psychiatrist in prison, I'm often treating people who stop their medication and are going to be released into the community, and I need to refer them to somebody for ongoing follow-up, which is not a dissimilar situation. So the first thing I'd say is I think it is very important to include the information about the mother's concerns about a possible relapse. So I think that's just an important clinical piece of information. It might be that Dr. Boris Lavarch follows that up with, but I have assessed him on a number of occasions and I didn't share these concerns. However, this is important collateral information.
Yes.
So I think that's number one. But I also think, really importantly, number two would be when I was last seeing Joel, my intent was that he continue antipsychotic medication.
Yes.
And I think perhaps an explanation just about how we got to a situation where he wasn't taking medication, but what might be the psychiatrist's recommendations from this situation going forward to help inform the GP about what might be a sensible plan going forward. So, for example, including a sentence that, you know, we discussed the risk and benefits of medication. Joel does not want to continue medication. I have had a discussion with him. My preference was that he should continue medication. I have encouraged him to take aripiprazole or brexpiprazole, at this dose for these reasons. So I think that would be a second element that would be important in a comprehensive discharge letter.
On the 14th of February, his mother also reported to the practice, as recorded at page 19, that she was worried if Joel moved to Brisbane, he may become homeless. Is that something that should be discussed with the person that you're handing over care to?
It is a very difficult situation because I think Dr. Grundy is in Toowoomba and Joel has gone to Brisbane, and so really there is little that Dr. Grundy can do, and it would be much more effective for a psychiatrist to refer to a psychiatrist in Brisbane or another general practitioner to ensure that continuity of care. I mean, I have a view about this, which is that I think this is a situation where the public health system could have been utilised in terms of a referral.
So let me come to that issue then. But before I do, Professor Large, is there anything you wanted to say generally in relation to this period and the handover of information to the GP?
So I've got no reason to think that on the 17th of February, Dr. Boris Lavarch didn't reach the conclusion that at that time, had there been a relapse, that had resolved in some way. I also don't think that the specific information that Mum is concerned about him would be likely to end up in a letter, given Mum's telling the doctor, don't tell him, because I think that would leak. It's a short discharge summary after a long period of care. We don't know whether, we don't really know what, I mean, you would have hoped that he would have come back to see Boros-Levac.
Professor Large, there's the evidence of Dr. Boros-Levac, although it's disputed, is that she then phoned Dr. Grundy. Dr. Grundy says he doesn't recall receiving that, and if he had received that phone call, he would have written a note. But putting that to one side, it's Dr. Boros-Levac's evidence that she phoned Dr. Grundy but did not discuss with him any of the concerns that had been raised by Mum. Can I suggest to you, because this is an issue of significant concern to the families, that in circumstances where Mum is regarded as a reliable historian, where Joel's been your patient for 8.5 years, where these symptoms reported by Mum are totally unusual compared to the 8.5 years that you've seen him, where the psychotic symptoms that he initially displayed in 2001 involve some satanic beliefs. You would be, if you're going to discharge him after 8.5 years without seeing him again face to face, you report to the person you're discharging him to what Mum's concerns were.
So I think communicating Mum's concerns orally, when you could have a conversation about the confidentiality issue, is much easier to do than in a letter. It would be possible to put in a letter that there have been concerns about a relapse, independently of any view of Mum. That would be possible to put that in a letter.
But in any event, it's certainly, if it's her evidence that she didn't discuss it or raise it, then that's an oversight, isn't it? Sorry, you're nodding.
Yes.
Excuse me a moment. It's been pointed out, I might just have that letter back again if you don't mind, which is at page 113. You see there a referral back to the GP, but am I right to say, Professor Large, that that's not a mental state examination? That is, that there's nothing in there that actually gives you an idea of what Joel's mental state is at the time?
In the letter, no.
Yes. And that there should have been?
Well, on the 17th of February, and I've got no reason to doubt this, except that it was by Skype, she thought his mental state was normal. And
But not even that is represented in that letter, is it?
yeah, no, it's not.
And it should have been. Or her views should have at least have been expressed.
You could have written a letter that said, look, there's a disparity between my assessment of the patient and the family's reporting.
Dr. Heffernan, can I come to you then to comment on that? Is that what should have happened, that there should have been an outline of what Dr. Boros-Levac thought the mental state of Joel was at that time and the disparity as reported by members of his family?
The mental state is really the key to understanding a person's psychiatric condition. So it's really important, if you're expecting somebody to take over care or manage the continuity of care, that you actually give them some indication of where that person is on the spectrum between well and severely unwell. So irrespective of what you think about the collateral information, or even whether you feel you should relay that in the letter or by phone conversation or however, a standard piece of information from a psychiatrist to a general practitioner should contain information about that person's mental state and the symptoms that they're experiencing. So it might be something like this individual currently is not experiencing any symptoms of psychosis, however has some ongoing psychosocial disability and negative symptoms, or it might be this individual is currently quite unwell and experiencing, but some indication, because otherwise it's a cold handover to the general practitioner who probably would expect more from a specialist.
Yes, and given that the general practitioner's evidence is that he had not worked in mental health for many years and had no particular expertise and was of the view that Joel had been going well on the back of the letters that he had been sent. If you had any concerns about an ongoing risk of relapse, given what Joel had suffered, the condition he'd suffered from originally, and that you'd taken him off that medication. Should that be set out in a letter if you're referring it back, so that you give the GP guidance about how often to see him and what sort of follow-up is required?
I think it should.
Sorry, Dr. Harris?
I think that if this is a discharge letter, then it would have been reasonable to expect details such as a discharge diagnosis, which may have helped frame the issues that you're putting forward there about whether he had schizophrenia in remission, in which case there wouldn't have been any ongoing concerns from the point of view of intensive follow-up, or whether there are other diagnoses in Dr. Boroslavak's mind at that period, as well as details of any ongoing treatment. So that would be standard in a discharge letter.
I'm going to come to this issue that you are all passionate about, which is learning from this case and about how we might improve the system. Dr. Nielsen's averted to the difficulties that Dr. Boroslavak had at that time in COVID, and that Joel was moving to an area in Brisbane, had not yet identified a GP at the time he moved. Dr. Heffernan has raised his view that it would be a better system to refer somebody back into the public system at this stage where they're moving out of area. Have I encapsulated that properly, Dr. Heffernan?
Yeah, with the context that at that particular time in Brisbane, the likelihood of getting a prompt psychiatric appointment in the private sector was going to be very difficult.
Dr. Harris, do you have any comment on that, about whether or not there should be guidelines that assist a psychiatrist when a patient is moving out of area but has suffered from the type of severity of illness Joel had?
I think it's reasonable, but one of the difficulties is where would I refer that person on if they are in the private sector? So, for instance, I wouldn't know the names of any GPs in Brisbane if I had a patient moving from Sydney to Brisbane, as it's not infrequently that occurs, and it would usually be up to the patient to establish a relationship with a GP in the area that they move to, and that GP would then get back to me or my team and ask for information to be forwarded. Similarly, it's very difficult to identify psychiatrists who would be happy to take on someone with schizophrenia, who wouldn't be able to provide any sort of co-payment or additional payment to Medicare. So it is, in the way that our systems are configured, it is difficult other than to refer somebody to the public mental health team of the area in which the person is moving, and whether Mr. Coucher would have been accepted as a referral at that stage is moot.
Should there be guidelines then, given the risk of relapse for somebody who has experienced psychosis and been on Clozapine that you identify, 90% will relapse within 2 years, and given particularly the symptoms that have been raised by mum, but even without them, should there be guidelines that say that if you've been a treating psychiatrist, you need to refer into a particular system, and then the other system needs to take that person?
Into a system of ongoing care,
yes.
That might be a general practitioner, because that might be the only person who's likely to take the referral on.
But when you're dealing with, let's stick with a patient who's on Clozapine or been on Clozapine because they've suffered treatment-resistant schizophrenia, should there be guidelines that say how that person should be discharged or handed over when they're moving out of area?
For someone who's had a severe mental illness, generally it's reasonable to expect that some ongoing care be passed on. However, that has to be tempered with the reality of what's likely to occur at the other end, because there's nothing more frustrating than being told to contact a local mental health team and then not be accepted into care. And that's unfortunately a very likely outcome. And so it's better to be accepted into care, i.e. into a general practitioner, and then having had a discharge letter which says we would like you to continue to monitor for possible recurrence of psychosis.
And gives the GP some guidance about how to do that. Dr. Nielsen, are there currently good enough mechanisms for maintaining oversight of people with severe schizophrenia who have required involuntary admission at some stage, who move out of area?
Well, there are quite a number of community treatment orders floating around. We're, Australia's the world champion in community treatment orders, and it's a controlling kind of system. But of course, if you want to get off a community treatment order, the best thing to do is to move, and because it's very hard to transfer these, and no guarantee to be taken up, and that the treatment would be continued. But I mean, there's a chaotic movement of people with psychotic illness. McCafferty's up and down the east coast of Australia, people drop into the Matthew Talbot, they drop into the equivalent services in Brisbane and Melbourne. People come in and out of jail, and we get very, and there's no warning often when people come out of jail, so they sort of arrive at you cold. You lose contact with people. You rely very much on patients to seek treatment. I mean, it's kind of touching they do in a way, because as we've heard, the medications are so unpalatable, and yet obviously the symptoms are so distressing, or the lack of treatment is so distressing that people do seek treatment. So it's it really is a counsel of perfection to expect that we can keep track of all the people with schizophrenia floating around our community, and especially with the services that we have, because they are pretty threadbare, I've got to say.
I'll come to the services that might otherwise pull people in, at homelessness services, but in relation to a patient in Joel's position who's been on Clozapine and been weaned off Clozapine, who's previously been treatment compliant, who moves out of area, is there a way of tightening guidelines to require the psychiatrist or advise the psychiatrist to do certain things at the point of discharge?
No, I don't think we can exercise that kind of control over people, actually. I mean, really, it's sort of to have some kind of tracking system to...
No, that's not it. But if you, at the time of discharge, for somebody in Dr. Boros-Levac's position, would it be appropriate to review the guidelines to see if more assistance can be given to a doctor in that position about what she should set out at the time of discharge?
Yes, I'm sorry. It should be clearly stated that there is a risk of relapse, and that we are concerned that risk is already there. She hasn't found that to be the case. The two psychiatrists he saw later didn't see him as being relapsing, but it seems also pretty clear that he kept his symptoms to himself.
Given the risk of relapse, even in the absence of overt symptoms that Dr. Harris has reported, should those guidelines set out that for a period of X number of years, 5 years, for example, there should be a further follow-up of patients?
Yes, I believe we should make it quite clear that once stopping treatment, the risk of relapse is so high that we should keep in touch, of course. Yeah, that is a...
But in reality, how would that happen if it's a voluntary patient?
It has to be through the relationship between the patient and the doctor.
That's
and
right.
So it seems that Mr. Cauchi and Dr. Boros-Levac had that kind of relationship, but it fell apart for a number of reasons.
And we know that Mr. Cauchi saw in fact, 3 psychiatrists in the intervening period after he was discharged from Dr. Boros-Levac. So even if he was referred to a psychiatrist, it would be difficult to make sure that he was still monitored for 5 years if he's a voluntary patient and chooses to not see the psychiatrist or go off medication. And you were talking about, Professor Nielsen, about a community treatment order. That's very limited, isn't it, the people who'd be able to be put on a community treatment order where they become, where there's an element of involuntary demands made of them.
Yes, well, you'd normally have to have become mentally ill within the meaning of the Mental Health Act before an order like that could be applied for.
Do you think that would have applied in any way? to Mr Couchy?
Well, not based on the assessments that were recorded, even though there was lots of warning signs that he probably was relapsing and was going to relapse. I'm putting myself in, for example, her shoes. I don't, and thinking of the New South Wales Act, of course. I don't think one could have made that application. It really relied on being able to persuade him to resume treatment. Otherwise, it's a watch and wait.
Yes. Sorry, Do.
Not at all. And in the report of Professor Nordentoft, she refers to the absence of any signs in the notes that Dr Boroslavak was assertive enough in getting Joel back, in trying to get Joel back on his medication. And by the 17th of February, Dr Boroslavak says she has convinced herself that he's well again. Do you have any comment on that, Dr Nielsen?
Yes, yeah. Well, firstly, it seems that she has taken him on face value and not adequately considered the risk, that this was what was happening. And she hasn't spelt out that she has advised him to resume treatment at subsequent correspondence and entries. The assertiveness one assumes is in the course of her recording that she has attempted again and again to persuade him to resume a low dose of medication, because this is what's happening.
Dr Hevenin?
I might just say that there's sort of three things I was going to say, and I'll be quite brief with them. The first is that when someone moves to an area in Brisbane, Queensland, there is an identified catchment for that area, as I'm sure there is in New South Wales, and there is a particular number that is well sort of published and known that can assist in a referral to the public mental health system. So that's about sort of knowing how to refer. The second thing is that I have confidence that in Queensland at that time, having been a person that refers people like this almost on a daily basis in Queensland, that someone with treatment-resistant schizophrenia who is off all medication, who has had substantial contact with the public mental health service in the past, would be picked up by the public mental health system. That would be seen in some ways bread and butter for the public mental health system. Unfortunately, because of the scarcity of resources, the focus really is often on major mental disorders such as schizophrenia. Someone with treatment-resistant schizophrenia, all the more reason to engage them in treatment. And somebody with treatment-resistant schizophrenia off medication would at least have the opportunity for assessment with some consideration of, well, what are the ongoing needs here? And I feel confident that that would have happened in Queensland. I understand from colleagues that that's not the case everywhere else, and I'm certainly not being parochial. I just, we have all the problems everybody else does, but I'm just, that is the type of situation that the public mental health system takes quite seriously in terms of providing assessment and follow-up. And the final thing I was going to say, the third thing, and so I actually think that there's probably some interest in what Professor Norton has said about deprescribing clinics and guidelines. There might be something to learn there. I'd have to say that's the first time I've heard of it today, but that does sound like an interesting way to enable a person to safely come off medication and have a trial off medication, and having some guidelines around standards of practice for that would seem to be a sensible idea.
Dr Harris, I could see you nodding at that point. Is that something that interests you?
Yes, it is. There has been a number of trials looking at the best way to deprescribe, to take somebody off an antipsychotic medication. And really what those 3 studies have found is that people being taken off medication relapse in somewhat like the figures that I've suggested. However, the advantage of being in a particular clinic or having a particular protocol for that means that risk of relapse is underlined as one of the purposes of the whole process. That it's anticipated that may occur, and so the framing of the clinic is to identify and pick up relapse as early as stage as possible, so it would be of advantage.
Before I come to Professor Large about this, Dr Heffernan, given the Queensland experience, what would Dr Boroslavak have had to do to refer Joel into the public health system in Queensland?
So there's several ways to access systems. So the first is you can be accessed by a phone call. There's a 1300 MH call line that will be relevant to the catchment that you're referring into. You can call an acute care team directly in the relevant area, or you could correspond in writing. So there's a number of different ways that you can navigate that pathway. Now, it's not always easy to navigate the mental health system, even for people who work in it. But a lot of efforts are made to ensure that there is a point of entry into a catchment area.
And it was Dr Boroslavak's evidence that she, I think I said earlier, she would have wanted to monitor Joel for the rest of his life. That was her plan before he moved to Brisbane. In circumstances where it's your belief that a patient should be monitored for the rest of their lives, it seems that it would be preferable, wouldn't it, for a doctor to be able to identify the service that you're discharging somebody to, rather than just leave that to a patient?
Yeah, well, absolutely. I think, it's a collaborative effort, you know. Because you have to have the patient wanting to turn up. I mean, I did notice that Joel did seek some psychiatric appointments, and so that's that indicates that he was at least open to that.
Yes.
And so having the psychiatrist and the individual working together on that entry, I think is really important.
In relation to, Professor Large, is there anything you wanted to add to the lessons about discharge or the ways in which we might improve that process?
I think it's very difficult for one private psychiatrist to refer to another private psychiatrist, actually. Quite apart from the waiting list problem, there's a Medicare item number issue and the duration of the referral. So the usual pattern is to go back through the GP. And the collaboration between if you refer to another psychiatrist with a GP, then that cuts the GP out of future care. And actually, I mean, Joel's main risk was a premature death due to vascular disease. That's his main statistical risk of dying. So post-discharge suicide is exceeded by vascular risk within a year of discharge, and patients with schizophrenia have a premature mortality of about 20 years. So that's the main actual mortal risk that he faced. So a GP needed to be involved. The referral, I think, whatever referral had to happen had to involve a GP. The most monitoring of patients with schizophrenia, according to the SHIP study, is in general practice. The monitoring of psychosis is within the core skills of a general practitioner. Psychosis is not a common disorder, but it's common enough that every GP will have patients with schizophrenia. Now, questions about the referral to the public system are, I think, complicated, but what I will say is functionally the threshold for discharging a patient to case management back to their GP is extraordinarily high in New South Wales. So taking their medication, putting one foot in front of another, having their symptoms sort of stabilised, that's the threshold. And the reason for that is there's the incidence of this sort of disorder is, 20 per 100,000 per annum. So in a catchment area of 100,000 people, you get of 500,000 people, you get 100 new cases like this per year, and we don't have, an incrementally increasing case management service to cater with that. So people have to be discharged out of the other end. And when you think about who's discharged out of the other end, you might think of all sorts of things, but a typical mental health, public mental health patient has got some of the features of Joel, but not many of them actually. So they're not very bright. Often there's active substance use. There's usually direct contact between the patient and the criminal justice system, or they've been in the emergency department with a suicide attempt. They're the sort of typical patients that we look after in the public sector, and compared to them, Joel would have been the sort of person that you would have referred back to a general practitioner and expect a general practitioner to manage. Now, I know he was moving and that made things much more complicated, but that is the reality.
Whoever was expected to manage Joel, whether it was a GP or a psychiatrist, needed to be fully apprised of the risk of relapse and recent symptoms. Do you agree with that?
Well, a GP should have some degree of presumed knowledge about schizophrenia, and I agree that the letter is slight, but we're talking general practitioners have responsibility for mental health care. They are the main providers of mental health care in this country. Psychiatrists are bit players in this, really, in terms of the number of psychiatrists and the number of general practitioners. Mental health problems are primarily problems of general practice.
Dr. Nielsen, is it common for a general practitioner to manage a patient like Joel who had been diagnosed with treatment-resistant schizophrenia and had been on Clozapine for 15 years or so and been weaned off?
Yeah, quite common until they relapse, because that's what happens with this. These episodes of care where people are with lifelong illnesses are referred back to GPs, is that they typically relapse. It's utterly self-defeating. I know it's an inevitable and a resource-related necessity, but it's utterly self-defeating, and it's one of the reasons our system is in the stress it's under, because we don't keep people well, so they're always coming back in crisis. But that's the way it is. But so in answer to your question directly, yes, it is common for GPs to manage people who've been discharged.
Given the high risk of relapse that's been discussed today, it suggests, doesn't it, the need for continuity of care and to design systems that include keeping people in treatment of whatever form so they don't relapse.
Yeah, that was previously the model. When I started training, that was the model. Community health centres would not discharge people with chronic schizophrenia. They'd keep treating them on the whole, until, of course, they ran away or stopped, because quite often patients refuse treatment.
So Professor Large is nodding at that. All of you throughout your long careers will have seen a change in the mental health system then. Professor Nielsen, can you summarise that then? You referred to the Richmond report. What was the change and what impact has it had on maintaining continuity of care for people with schizophrenia, chronic schizophrenia?
Well, my experience goes back to working as a psychiatric nurse in 1977. So, and that was deinstitutionalisation had already occurred, actually. So it wasn't the Richmond report that caused it. It was the response to the emptying of the asylums already at that time. When I started training in the late 80s, the community health centres were pretty functional type of system. So you could ring each centre directly. You didn't go through a 1-800 number. I mean, I have the most dispiriting experiences of trying to refer people, through that number. The case managers were, knew their patients pretty well, I think. There were psychiatrists at each of these community health centres. So in other words, the psychiatrists who knew the patients were there. So really, it really has become much more chaotic. The reasons it's happened are multiple, and Professor Large has alluded to just the growth in population, really, that the sort of services haven't really kept up with that. But they include the change to the Mental Health Act, so that we don't respond to deterioration or anticipate deterioration. We have to wait in a way until people have deteriorated. There's, of course, housing, because we did have a lot more housing options, and the stress of housing, which has turned up in this case, means that people aren't in the stable situation where they can be easily treated. You can't treat someone who's not housed. I mean, the change in patterns of substance use, of course, have made people a lot more acute, particularly methamphetamine, but also potent cannabis. So that, and because it's almost ubiquitous, comorbid substance use, and of course we've had a little bit of that here. I feel that the recent substance use probably led to a much more acute situation.
All of you are in agreement that when these terrible acts happened on the 13th of April 2024, Joel was experiencing a psychotic relapse of his schizophrenia, of his chronic condition. Is that right, Dr. Nelson?
I think we've all agreed that in our consultation.
Mm-hmm. Professor Large?
Look, I have two things to say. I don't think relapses are always utterly self-defeating. They are self-defeating, but actually that is the way that a lot of patients end up being adherent. They come off their medication, they get sick, and they go, oh my God, I've been sick again twice, now I'm going to take medication. Similarly with epilepsy, you know, one seizure doesn't necessarily convince a patient that they need to take anti-epileptics. So relapses are not always utterly self-defeating. Now, the way I would think about the events in April of last year are maybe slightly different. He didn't utter anything that I can make out of any significance during that episode. So we don't actually know, but 1/3 of people who run amok have got a psychotic illness. So our starting point is about 1/3. We know that he had schizophrenia, so we know the likelihood of him being psychotic is higher. We know that he wasn't on treatment. That increases the probability somewhat. Although it is possible for people with schizophrenia to be involved in killings and mass killings even when they are treated. And finally, I mean, we know something about his demeanour on the day, and he had cannabis on board. So that gets me well over the line for thinking, it gets me beyond the balance of probabilities. I think it's a near certainty that he was psychotic, but it's a question of my belief. We believe that on the basis of this. We don't actually know.
Can I add to what you've just said, that we know that in 2001 police attended on his house because he was banging the doors and making bizarre noises. We know that he was pulled over 3 times for erratic driving in 2020 and 2021 without realising that he was driving erratically. We know that there was content on his phone which is bizarre and fanatical and dangerous in 2022 in terms of his obsessions with girls and women or with violence. We know that the violent content of his phone got worse, that is, it had not been present prior to 2020 when he was medicated, and it got worse. And we know that on the day, well, I would draw that, we know that in December, we know that the 8th of January he was presenting in a way in 2023 when the police went around, that Professor Nordentoft said in Denmark he would have been detained, but certainly the police were concerned enough about his mental health to do a referral. We know that in December 2023 he recorded on his phone some bizarre videos that haven't been played in court, which suggest that he is incoherent and muttering at something. We know that throughout the day on the 13th of April, when those terrible events were happening, he said a few strange things like, catch me, to somebody. Sorry, Leah Barco, Leah Barco, one of the persons who was injured by Mr. Couchy, said that he said, catch you, as he was stabbed. And another victim said that she heard him say in a very monotone voice, I have a knife, I have a knife, I have a knife, and his voice was very strange and didn't sound normal.
I read that. I'm not disputing that he was psychotic. I knew all that other information. I think that in 2023, when seen by the police, he was psychotic.
I'll just pause you there then. That's your view, Dr. Harris?
On the day of the event?
Yes, that he was clearly psychotic.
I think he was most likely psychotic, yes.
Dr. Heffernan?
Yes, on the day of those tragic events, I believe he was psychotic.
And Dr. Nelson, you don't have any doubt about that?
No, I think it was an acute relapse that had been brewing, and there was plenty of signs of it.
I just want to come to I've got to sit down and let my colleagues ask you some questions, but just want to, we will have time to conference with you and Professor Nordentoft about improvements to our system to try and avoid this tragedy happening again, bearing in mind that although there are small numbers of persons with schizophrenia who are responsible for homicides, in the study that you and Professor Large did, Dr Nelson, it pointed out that the homicides where persons have been found not guilty by reason of mental illness, about 80% or thereabouts have been committed by persons with a diagnosis of schizophrenia. Is that right?
Probably more, yes.
In those circumstances, with respect to the discharge, we can't conduct an inquiry into the whole mental health system in this inquest, but we are dealing with somebody with treatment-resistant schizophrenia who has committed these terrible acts in circumstances where he had tried very hard for a long time to be well and did not want to get sick and became sick. Is there room to amend the guidelines so that persons suffering from treatment-resistant schizophrenia can at least be retained or monitored more closely?
Well, we could, if you're starting with me, we could say that really if you've got treatment-resistant schizophrenia, you should really advise people to stay on medication indefinitely. The odds of relapse are so high. And then if the person elects to go off it, then that they be monitored indefinitely because if possible,
yes.
if such a relationship exists.
Yes. I'll just pause there. Dr Heffernan, do you agree with Dr Nelson there?
Yes, I agree with what he said, and I've got other thoughts, but we can leave.
No, please share them. Or do you mean in terms of generally, in terms of discharge and follow-up?
Yes, I mean,
Please share.
just a couple of areas. I mean, you asked the question earlier about the deinstitutionalisation, and I think what hasn't been said and is quite important is that the funding for community services never really followed to match that movement and that shift. And so that's really important. That's why you hear my colleagues and myself and other people from other jurisdictions, a lot of the community services are drawn back into hospitals, into acute care teams and in hospitals because they're simply overwhelmed inside the hospital. So, I think that's a real issue on a day-to-day basis is the access to community mental health services. And I think the other thing that I'll just mention quickly in case it doesn't come up, but is that we expect a lot from our police. And I think there is an opportunity to think about how does the mental health system work to support police and by corollary individuals in mental health crisis in the community in real time. How do we do that? And I have some thoughts about that, but I'll leave that for later.
Dr Heffernan, that will be very valuable, and we're going to hear next week too from the Police Commissioner in Queensland and some seniors in New South Wales, but I'll return to you on that issue in terms of the best models. Dr Harris, do you agree in relation to an amendment to the guidelines to provide some guidance with respect to treatment-resistant schizophrenia, given the risk of relapse?
I think it is reasonable to have guidelines about deprescribing and the periods of time for which people should be reviewed. I also think it's important to remember from the point of view of the people we're looking after with schizophrenia that they do want to have a chance of being able to come off medication. And it is reasonable in the case of somebody like Mr Cutchy, who was very well, he had recovered well overall, that he be given a chance to come off medication because a small proportion of those people will be able to go on in life without medication. And as Professor Large has said, sometimes it's only after a relapse that people realise that the medication really is useful and helpful. So it's not in itself always a disastrous thing that what's happening as long as it's being monitored. So people, the expression in the consumer movement is that people have be given some dignity of choice and the ability to fail from the point of view of relapse. So I think that's an important part of this.
So I think Dr Nelson's suggestion was that the advice in a guideline would be that you really shouldn't come off medication, rather than not telling you that you must not, but that there are dangers associated with it such that you should not. But if you are going to, then there have to be ongoing monitoring. Do you agree with that?
Ongoing monitoring for a period of time, and that is one of the moot points, because needing to turn up 5 years hence because without any relapse or any illness would also be firstly something which I suspect wouldn't happen, but also would be an unfair imposition on somebody who'd been well for a prolonged period of time.
Sorry, Your Honour. Currently, the guidelines don't prescribe a period of time for somebody who has had treatment-resistant schizophrenia, and should they?
Yes, I think it is reasonable.
Dr. Larch?
Well, that's not quite true, actually. If you look at the guideline, which is a now extinct guideline, and in figure 1, it goes down from clozapine back up to deprescribing, and it makes a recommendation about how long people are monitored for. I can't remember precisely what the figure is, but it's quite short. But you can see that in the guideline. I just can't remember exactly. It's a guideline.
We weren't able to find somewhere that suggested that was the case with respect to chronic schizophrenia, that is treatment-resistant schizophrenia.
No, there is a line that goes from clozapine up to deprescribing in figure 1 in the guidelines, and you can't get clozapine unless someone thinks you're treatment-resistant, so there is a guideline around that. But I'd like to answer this just very slightly differently, and I don't mind changes in guidelines, but 1 in 500 people who present with schizophrenia present by way of a homicide. Olaf and I worked that out a number of years ago. And there's a 1-year delay on average in getting into treatment. But only 1 in 10,000 people who've even had initial treatment for schizophrenia go on to kill someone. That's a homicide rate that's similar to the whole population of Louisiana, which is the state with the highest homicide rate. So a person in Louisiana is about as dangerous as a person with schizophrenia in Australia. It's a very dramatic thing. But the rate before you're treated is high, and we don't want to do things that dissuade people from having treatment. The second thing I wanted to say is about clozapine. So I just really want to make sure that, you said that I'd had something to do with the FDA. That's actually not true. I wrote 2 papers about the side effects, about the risks associated with clozapine, and I've been in a communication with a group called the Angry Mums, who have in turn represented to the FDA and have had a big win with the FDA in the last year. In the United States, the requirement for close blood monitoring of clozapine has been dropped because it's pointless. And our clozapine is the single antipsychotic that is most known to reduce violence. And at the moment it's very complicated to be on clozapine, and it's excessively complicated. And we've got 2 instances where we've got a disjunction between 1990 and now. One of those has been mentioned, and that is with respect to mental health resources. We've kind of got 1990s tracks and 2024 trains in the mental health system. And with clozapine, we have guidelines for clozapine that emerged when clozapine was reintroduced after being taken off the market because of agranulocytosis. But we now know this enormous amount more about it, and we know there's absolutely no need for blood testing after 6 months. That would allow more people to have clozapine. It's a better drug than other antipsychotics. People on clozapine on average live longer, and they'd be less dangerous.
We'll come back to you about that out of session, but does anybody else in the panel want to comment on those changes that America has introduced to the use of all guidelines around clozapine and whether or not we should follow suit? Please.
Yes, there is good evidence that we no longer need to prolong the monitoring for blood counts from the point of view of agranulocytosis. However, continued close monitoring is needed for clozapine because of the range of other dangerous adverse effects that occur. However, that need for the monthly full blood count isn't there after the period of time.
Are you able to guess what the estimate is, or tell us what the estimate is rather than guess? The appropriate estimate of time, interval of time that would take then for the monitoring. If it's not monthly, what's required?
Clozapine has a wide range of adverse effects. As I think we commented earlier, Constipation is actually more dangerous to people in this country than agranulocytosis. Acute myocarditis at the beginning of treatment is in many ways more dangerous than agranulocytosis. In the same way as the risk for those cardiac adverse effects is relatively time limited and loaded towards the front period of time of treatment, so agranulocytosis is the risk of that is front loaded towards the opening months of treatment with Clozapine, and then it is reduced to the same risk as most other antipsychotics in actual fact. Monitoring for the metabolic adverse effects of Clozapine requires regular care, which can also be provided in many ways by a general practitioner, because it's about weight, it's about exercise, it's about the assertive introduction of lipid-lowering agents or metformin. That's of course best done with the psychiatrist also going in the same direction, but it's a care which should be provided on a regular basis.
Can I come off that now, because we'll come back to you about what that guideline might be written, just a number of other topics before I sit down. One is in 2001, Professor Large, as you noted, Joel expressed an interest in getting a gun licence. In 2000, he'd actually threatened to shoot his father. In 2001, he also said something about wanting to be, this is while he was unwell, wanting to use a gun for some sporting interests. In 2021, he went to 2 psychiatrists to try and obtain a licence to use a weapon, he said, because he wanted to go to the shooting range. Do you have a view as to whether or not somebody who has suffered from chronic schizophrenia with the sort of psychosis that was reported by Joel should have access to a gun licence, even for use at a shooting range?
Look, I'll just sort of concede a bit of bias here. I mean, I don't believe men should be allowed to have firearms. Men are much more dangerous than women. So I don't think men should have firearms. I definitely don't think males with schizophrenia should have firearms. I don't think women with schizophrenia should have firearms. And further to that, I don't think you should be able to get a pegging knife unless you're a hunter. So I'm all in favour of regulation of means of dangerous means. That was the message from Port Arthur. I think that Port Arthur really worked. So I've got a very straightforward opinion about that, that if you have schizophrenia, you shouldn't own a firearm.
Professor Harris?
I think that's reasonable.
Dr Heffernan?
Well, there are guidelines around the assessment of firearm risk assessments, and they're really fairly comprehensive. Perhaps they could be easier to follow, and so I think it's a complex question, because as we've talked earlier, there are some people who have schizophrenia who have recovery and do very well, and there are others at the other end of the spectrum who don't do very well. But as a general rule, I would have a high degree of suspicion and concern that a firearms licence wasn't appropriate and required, an assessment, thorough assessment in terms of the appropriateness of that individual having a firearms licence.
Do you think it's ever appropriate for someone who has had treatment-resistant schizophrenia to have access to a firearm? Will there be circumstances?
Apologies, I didn't hear the treatment-resistant
No, that was my mistake.
question. No, I don't think so.
Dr Nelson?
Yeah, treatment-resistant, no. I mean, and again, we've recently updated, I just saw the final version of our risk assessment document, and all people who've had, mental, involuntary psychiatric treatment should perhaps have ongoing monitoring if they're going to be, have these sort of licences.
And I'll come back to you about guidelines. Just two other topics. The first is in relation to the discharge issue. I raised with you, I won't go to the individual documents, but if you can take it from me, I raised with you the issue of the letter that went back to Dr Grundy. When Joel saw the 2 psychiatrists, the 2 psychiatrists receive some information, and in fact when he saw a GP, neither the GP, Dr Rouge, who he saw most frequently, or the 2 psychiatrists who he saw for the gun licence wanted one-off, understood the lengthy history that Joel had of mental health issues, which included over a decade on Clozapine and the extent of the psychosis. Does that underscore the need for a summary, a discharge summary, if you're referring somebody out of your care who's had treatment-resistant schizophrenia? Professor Large.
Look, I think there is an issue with information sharing about serious mental illness that is not fully solved by my health record. And this sort of problem occurs within, between area health services. It happens even more so interstate, and it happens between the public and private sector. And I'm not sure exactly what the solution to that is, but where a person, there's a balance between a person's right to privacy around their own medical information and other people's right to information. And look, discharge summaries, there is an acceptable practice around discharge summaries. The thing I think here, as I keep thinking, is probably no one else was ever going to, or in Toowoomba at least, no one was really likely to treat Joel other than Boris Levac, but he didn't go back to her. And why was that?
But when he went to Brisbane, he did seek care, including from Dr. Rouge, and he disclosed at some point early on that he suffered from a mental illness, but he was not a reliable historian. He underplayed his mental illness, and Dr. Rouge was never given the background about a lengthy history on Clozapine, being weaned off in the way that he was, and mum's concerns raised afterwards. So it makes it difficult for a GP taking over care. Do you agree with that? Right. Well, I'll come back to you about what some solutions might be in terms of better discharge policy. The final issue is to pick up what Dr. Nelson said in his report at paragraph 149, and to repeat those statistics, Dr. Nelson. You say another area in which the availability of services has declined is the shelter accommodation and medical care available to the homeless, mentally ill. In 1991, there were about 1,150 short stay beds in the 4 main inner city hostels, where people who were homeless could also obtain meals, receive medical and psychiatric care, and access a range of welfare services. Now there are less than 300 temporary beds, and walk-up psychiatric care is only readily available at the Matthew Talbot Hostel in Woolloomooloo and the Mission Australia Centre in Surrey Hills. So in spite of the population increase, those beds have drastically reduced from 1991, from 1,150 to 300 temporary beds. Dr. Nelson, Haberless Housing is a registered charity that you have set up that attempts to address that gap. Could you tell Her Honour what that is and what support there is currently from the government and what more is needed?
Yes, well Haberless isn't unfortunately offering that kind of emergency shelter. It's really long-term housing with clinical support on site, and I think that's a correct model for care for the most severely mentally ill, and perhaps not Mr. Couchy necessarily, but he would certainly fit in quite well there, I imagine, because given the level of disability he had, and again Haven in Victoria attempts to do this, and there's other services that attempt to do it. But I think it's the model envisaged by David Richmond in his report, and unfortunately it wasn't introduced. It was introduced in Italy, where there's 30,000 similar beds, which would translate to 4,000 in New South Wales. I estimate we need about 1,000 of these kind of beds. And at the moment we've got about 1,000 people with schizophrenia in prison. That's in terms of I think it'd be very helpful to open some more shelter type beds for people, so they don't have to sleep in the open, because it's really a place that's a hopeless situation in terms of having ongoing care if you're sleeping rough,
So is there a need for more of the short-term services, those short stay beds, as well as the Haberless type accommodation?
Yes, yeah. I mean, the idea of the short stay, really, the idea of the Matthew Talbot, and it's actually, they're very effective in it. They've got a caseworker there who, from day one, where are you moving to next? What's your longer-term housing solution going to be? I mean, the housing department are terrific to us, but as mentioned, the people with mental illness don't last in public housing estates, and that's why they need Haberless with supported housing. So given the type of disability you have with chronic forms of schizophrenia, you've just got to have supports on site.
So you estimate we need about 1,000 of those beds in New South Wales. How many are there with Habilis?
Well, there's 20 of us. There's the Haven has funding to open another 50 or so, I believe. They've broken ground in the Central Coast. I mean, there's other models. I mean, most people who with schizophrenia are cared for by their families, but it's that small group of revolving between hospital, between prison, between the homeless sector and boarding houses untreated that will need these 1,000 beds.
So just to be clear,
Sorry, Your Honour.
so we've only got 70 in New South Wales.
Well, we've only got plans for 70.
Plans for 70, and we need 1,000.
Yes.
And the cost of this compared to the cost of someone going to prison or beds in emergency services, emergency departments, you've done some sums on that, I take it?
The cost, it's about a tenth. So it's, in other words, it could be $10 saved for every dollar spent. And I base that on the cost of, $1,200 for a psychiatric hospital bed, $300 for a prison bed, but you get a lot of them, $2,000 for a general hospital bed. So the first 6 people who came to us had generated costs of 1.5 million in the previous year, and the costs of caring for them would be less than a tenth of that.
I'll leave it there for my colleagues. Thank you, Anna.
Ms. Chrysanthou.
Thank you, Professors. My name's Sue Chrysanthou. I appear for the families of Ashley Good, Dawn Singleton and Jade Young. On their behalves, I'd like to thank you for your very professional and careful attention to these matters and the evidence you've given. I just want to clarify a matter that arose in the evidence of the treating psychiatrist last week, and I think you've been given a summary of that evidence. Dr. Borislavac told us last week that she initially diagnosed Mr. Cauchi with chronic treatment-resistant paranoid and disorganised schizophrenia. And she then gave evidence that she changed her diagnosis after receiving the discharge summary from the public health team, and she said she revised her diagnosis to that of first episode treatment-resistant schizophrenia, which remitted on Clozapine. And she went on to say the first episode lasted for a long period of time until 2008. You've all given evidence today that you agree that Mr. Cauchi had chronic schizophrenia. Can you please help us understand, if there is an explanation, first of all, whether there's some difference in those two diagnoses that the treating psychiatrist told us about last week, and if so, what they are?
I'm willing to address that. So when people are initially admitted to a psychiatric unit for the first time, they not uncommonly are given a diagnosis of a first episode psychosis because of some of the uncertainties about diagnosis, which require a period of time for the diagnosis to be clarified and for the full treatment to be defined. Professor Large spoke about that initially, in that sometimes there's some uncertainty about whether somebody might have a psychotic mood disorder or a psychotic disorder such as schizophrenia. That initial uncertainty is usually, and certainly in Mr. Cauchi's case, resolved over the opening 6 months of treatment, in which the absence of significant mood symptoms, such as a manic episode, I suppose, or a very severe depression in an elderly person, the range of symptoms that the person displays and the functional impairment that the person has would suggest that the diagnosis of schizophrenia is the appropriate one. Chronicity, the diagnosis of chronic schizophrenia suggests that the treatment, that the symptoms have gone on for at least 2 years without a remission of those symptoms, and the treatment resistance part of the diagnosis is really a reflection of the criteria for starting Clozapine. So has the person responded to one of two different antipsychotics initially given? If not, they're designated as having treatment resistance, and they're eligible for the initiation of Clozapine under present Australian rules. So Mr. Couchy had an unusual illness in that he didn't remit from his initial illness for the first couple of years. And so, although in theory he can be described as having a first episode schizophrenia, and that there was no real cessation of his symptoms. He didn't go into remission from the period of time when he was first arrived in Toowoomba Base Hospital to around, to about 2011, 2012. However, he had chronic schizophrenia over that period of time because of the duration of his symptoms.
Does the fact that Dr. Boroslavak told us last week that she changed her diagnosis make sense to you in those circumstances?
Not really, but I mean, I don't think it has. The treatment remains the same. He was started on Clozapine because of his lack of response to the olanzapine and the risperidone, and that was used as a treating agent throughout this period of time.
Does anyone else want to make any comment about that? Yes.
I might make a comment. And I'll probably be repeating some of what Professor Harris has said, but so one of the specifiers is about treatment, about the treatment things, and that's treatment resistant, and that's all about Clozapine. And then the other specifiers are time specifiers, so that they're kind of in the same category. So first episode and chronic are time specifiers. The DSM-5 hasn't helped us in the way it defines these things, because it's a little bit open to interpretation. But what the DSM-5 says is that the first episode, the way I interpret it and the way it's written, is that it's the first manifestation of the disorder meeting the defining diagnostic symptoms and time criteria. So in other words, one interpretation, and I think probably a commonly used interpretation, is that first presentation to hospital, Mr. Couchy was identified with the symptoms that met the diagnosis of schizophrenia, and he was identified with the time criteria. This has been going on for 6 months. That's his first episode. Whatever happens after that, we move on. And if he continues to have symptoms, there is no criteria defined in the DSM-5 for chronic. I think there was in the DSM-4, and I believe it was a 2-year specifier. And I think if you asked most clinicians and showed them the chronology of Mr. Couchy's illness, they would say that was his first episode in 2001, and he's got chronic schizophrenia.
So do you disagree with Dr. Boroslavak's subsequent varied diagnosis as she explained it last week?
I wouldn't describe it as a first episode schizophrenia.
Thank you. Does anyone else want to add anything to that?
No, it's chronic schizophrenia.
Professor Large?
It's chronic schizophrenia. Of course, you can present with chronic schizophrenia and first episode schizophrenia, and that's not even rare. So people who've been untreated for a long time in the community present with all the problems of chronicity and being treatment naive. Look, it's a tricky one because he wasn't really in a second episode, but he certainly didn't have first episode psychosis.
Thank you. I just want to ask you some questions about the transfer of care. It seems that here you had a patient who was very carefully cared for about 19 years, both in the public system and the private system, and then just completely fell off the radar, and that there was no passing of the baton, so to speak, in relation to his care. There were attempts for subsequent doctors to pick up his care, and those attempts were unsuccessful in the sense that he either didn't exhibit any psychosis or he was masking his psychosis. One of those examples was quite early on, and it was in November 2020, so only 6 months or so after he was discharged back into the care of his GP. And if I could just get up onto the screen briefly, tab 806. These are the medical records of Cornwall Street Medical Centre. And this was a request for the transfer of Mr. Couchy's medical records. And if I could just go to page 16 of that document. I'm not sure if you've seen these before. Thank you. While that's coming up, what we had was a request on the 26th November 2020 signed by Mr. Couchy, and it was called a request for medical records transfer to a new psychiatrist, Dr. Sarkar. And you'll see there's actually two versions of the document. There's one which, the first page, if we just scroll down briefly, please, which ticks all clinical records. And then there's a second version which ticks multiple boxes. If we just scroll down to the next page. And that was signed by Mr. Couchy. And the response by My Mind Centre to that request was to provide for GP letters. So the letters that were provided in response to that request for transfer of medical records was the letter to Dr. Grundy. If we go down to page 18, and you've seen these before, I'll just quickly show you which ones they were. The letter to Dr. Grundy of 12 June 2019, where Dr. Boroslavak reported that Joel had come off his medication and was about to come off his secondary antipsychotic, and how well he was doing. Then the next letter over the page was on 3 May 2018 on page 19, again reporting how well he was doing. And another one on 5 April 2018 on page 20. And then a fourth letter from 6 March 2012, which was the initial consultation letter with Dr. Boroslavak. So those were the only records provided to the new treating psychiatrist in November 2020. And you'll note, for example, it doesn't include that final discharge letter. What are your opinions on the sufficiency of that amount of information from My Mind Centre to the new treating psychiatrist who had asked for a transfer of the medical file, having regard to the history of Joel's treatment from 2001 to 2020? Whichever one of you wishes to start.
Was there a phone call as well? Or there was one.
There's no suggested evidence of a phone call between these two particular doctors.
Right. Put it this way, it's not the complete medical record, but it's as someone who often asks for medical records for reports and so forth, it's pretty typical of what one would get, especially if you're dealing with the clinic, the administrator, rather than the doctor directly.
I mean, it's not typical, but isn't it hopeless? Isn't it quite hopeless that over 19 years of medical care, a new psychiatrist is asking for medical information of a person who has had a very complicated and long-standing treatment regime, that this is all that they were given?
Yeah, it's inadequate because I'm guessing that they also had the discharge summary. Well, they would have had the discharge summary from the public sector, and that really should have been included, as well as you say, the last letter for better or worse.
Well, I think as a psychiatrist who has worked in private practice and somebody that does receive patients and the medical records that come with them, I would have found that quite confusing, because I wouldn't have been able to equate the first discharge the last letter in the sequence, which was, paranoid schizophrenia, disorganised, and Clozapine, with like, where are we now? Someone that's not on any medication, and I think probably I would have initiated a phone call to Dr. Boris Levart and said, just want to talk to you about this, just so I can piece it all together. So I guess the corollary of that is that it would be expected that you would get more information and at least a summary of how all of this information connects. Because the last thing also that you want as a private psychiatrist is to have to piece together chronologically lots of different pieces of information. So, there's a problem in receiving too much information. There's also a problem in not receiving enough. And in some ways, the best thing really is to get a summary and a phone call.
Would you consider, when you're considering recommendations in this case, some sort of recommendation when it comes to keeping and transferring medical records for people in the position of Mr. Cauchi? Is that something that you could please think about? Because here it appears to be something where this particular patient fell through the cracks of the medical system. Professor Harris, did you have anything to add to that?
It's an inadequate amount of information. There's no doubt about that. I think sometimes the most useful pieces of information are details of admission and discharge, as they reflect the symptoms at the nadir, the worst time for the individual, and give a sense of what symptoms were there and help make sense from the point of view of diagnosis, as well as that course of the person's illness with the letters that Dr. Boris Levart wrote assiduously to the GP. So that would have given quite a long, there would have been a lot of letters, but it would have given, they would have been available and would have given a good idea about the course of Mr. Cauchi's illness.
Well, in February 2020, we know that Dr. Boris Levart formed the view, and it's recorded in her notes that you have, that Joel needed to be monitored every month, once a month by her, and an additional time by a psychiatric nurse, so twice a month. Once by a psychiatric nurse, once by a psychiatrist. And we also know she did not pass that on to any person, any subsequent doctor. She did not tell Dr. Grundy that that was her view a month later, and she did not pass on that information to any subsequent medical practitioner that asked for information about Joel Cauchi. Do you consider that to be an adequate level of transfer of information from one practitioner to another?
So there seems to be a difference in that suggestion of frequency of observation and her own perhaps rose-tinted view about Mr. Cauchi's clinical state when she discharged him from her own care, in which she clearly was reasonably optimistic about him, and as she had looked after him over a period of time when his medication had been successfully reduced and ceased. So, as we've discussed, certainly I'd suggest continued review by a medical practitioner, hopefully psychiatrically trained, but a general practitioner would have been a reasonable person to do that if Mr. Cauchi had remained well.
But I think my question is the fact that Dr. Boris Levart formed the view that he needed that review. There's no doubt in her medical records in February that she considered it necessary that he continue that monthly review. And the fact is she didn't tell anyone that. She didn't tell his GP when she discharged him, and she didn't tell any subsequent medical practitioner from 2020 to 2023 who sought his records. Do you consider that acceptable from a psychiatrist in private practice to not have passed on her view, as recorded in her own records, that he needed monthly monitoring?
As we've already agreed with counsel, the discharge summary was brief and did fail to have a large amount of information that would have been reasonable to include in it.
Professor Large, do you think it was acceptable that she told no one her view?
So, look, correct me if I'm wrong, but I think is my understanding of a request for the entire medical file is that it is just that. And I think that's not well understood. And often, as someone who frequently wants information about patients that get admitted to hospital, often inquiries about previous history don't produce enough information.
But again, can you try and focus on my question?
Look, it's obviously a problem.
It's a big problem, isn't it, that she told no one that he needed monthly review, in her opinion, being his psychiatrist for 8 years?
I think he needed to be reviewed regularly.
And she needed to tell someone that, didn't she, when she was discharging him from her care?
It would have been much better had she done so.
Does anyone else have anything to add to that?
I think the other thing is that sometimes you will encounter a patient for the first time and you will have a poor amount of information, but that patient can give you a really clear and concise history, and so it becomes a moot point. You've gathered a really excellent history yourself from the patient, but looking at Dr. Sarkar's record, she noted that that he had an unclear plan, poor eye contact, used stock words, and she formed the view that he may have an autism spectrum problem. And so I guess it just highlights the point that this was a situation where someone perhaps wasn't in a position to communicate a good history, and emphasises the importance of that handover of information.
That's not unusual, is it? That a person who has schizophrenia is not capable themselves of properly communicating their history. That happens, doesn't it?
Of course. It does happen.
Thank you. No further questions.
Thank you, Mr. Fernandez.
Thanks, Honour. Other than thanking the experts, including Professor Nordentoft, for their careful evidence, this is on behalf of the family of Feroz Tahir. I have no questions.
Thanks very much, Mr. Fernandez.
No questions, Your Honour.
Dr. Freckleton.
Thank you. Not only does it happen commonly, I suggest, that people with schizophrenia have difficulty in communicating an accurate history of their mental illness, but there can be reasons why they may not wish to do so. Is that right?
Yep.
Yes. Yes.
And that may particularly be the case if their earnest wish is to be free of antipsychotic treatment that has side effects that they do not like.
Yes. Yes.
And might that very well have been a situation with Joel Cauchi in relation to a succession of medical practitioners whom he encountered from 2020 to 2023?
I think he actually wanted to have a gun, and so that he was interested in,
Yes.
in not conveying the full part of his history, primarily because of that.
Yes. But that's certainly the case in relation to two doctors whom he consulted for the purpose of trying to secure permission to be able to shoot a gun at a firing range. But it would seem that he was disinclined to communicate the full breadth of his history of mental illness to a whole series of medical practitioners during that period. Is that right?
Yes.
Dr. Nielsen, do you agree?
Yes, I do.
And one of the distinctive characteristics of Joel Cauchi, we seem to be able to divine from this sequence of interactions with persons in the period 2019 to 2023, was that he may have come over to them as a little odd, a little unusual, but no one formed the view that he had such symptomatology of mental illness that he seemed to pose a serious risk to himself or others. How do you do you explain that in terms of the pathology that you have identified? He's having chronic schizophrenia, and I think each one of you has agreed that he was in a process of relapse from 2019 onwards. Perhaps starting with you, Dr. Nielsen.
Well, all the alarming things that we've learnt about weren't available to anybody.
Yes.
Though, you don't know his internet searches until you get his phone later. And he had no criminal record.
No.
He certainly seemed odd when he was, having watched a number of interactions with the police recorded on body cam. There's certainly signs of some kind of mental disorder, and plenty of lay people that he came across were it seems, in their statements, aware that he was mentally ill. But there was no, apart from his interest in weapons, there was no other really alarming behaviour in public situations. I think there was one instance of the Toowoomba Fair where the police had become a little bit concerned, but when he was shaken out of his sleeping bag in New South Wales a couple of times, no immediate concerns of the police. They were aware of a history of mental illness on their little tablets. So
he didn't seem to act in a threatening way toward anyone in the presence of police or medical practitioners?
that's correct, yes. Well, not that we're aware of.
So was the situation that one of the reasons why coercive powers to take him for assessment or coercive powers to make him an involuntary patient didn't occur is that to this whole series of people who interacted with him during this 4-year period, he didn't appear to be posing a serious immediate threat to himself or to others.
I mean, that's correct. The one exception I feel is is when the police were called to his family home.
Yes.
But that's again in 2020 hindsight.
Well, it is, isn't it? Because the police spent time with the mother and the father and with Joel. They observed him to be calm, non-threatening, and of course the knives had been taken away from him. So they didn't feel an immediacy of threat to himself as a result of that presentation, although he was clearly unwell.
I think it was a missed opportunity, and it may have been because of the divided evidence gathering. That the policeman who seemed to be the senior officer spoke to Mr. Couchy, whereas the policewoman got quite a good history of significant alarm from the mother, but they didn't quite put it together properly, and it's just a shame. That was a missed opportunity. But in all the other interactions, there were no clear grounds for involuntary treatment under the Mental Health Act.
Would you concede that even with that episode, there was some significant ambiguity in relation to any immediacy of threat to himself?
Yes.
And Dr. Heffernan, do you agree?
I think I agree that there was a sequence of events that involved the contact with police, and on each of those occasions, each individually, he presented as somewhat odd, and he was pulled over for erratic driving, which, it might be common, but 3 times in a series of events. And so it just emphasises the importance of that information all being linked up. But I think the incident in 2023 highlights an issue with the change in the Queensland Mental Health Act from the EEO to the EEA provisions.
Now this is where the provision enabling a mandated detention and removal for assessment moved from the Mental Health to the Public Health Act. Is that right? And it continued to require an immediate and serious risk, but it was changed from immediate and serious risk to self and others to immediate and serious risk to self. Is that right?
Yes, so exactly that, and really, you know, that enabled a sort of a broader context of problems to be taken to emergency departments for involuntary assessment, but it did remove the criteria around risk of harm to others. And so it does highlight what does immediate risk of serious harm mean.
Yes.
And I think what most people think about when they think of immediate risk of harm to self, they're thinking about suicide.
And that's the example actually given in the legislation, isn't it?
That's the example given in the legislation, absolutely, in the explanatory notes.
Yes.
But in fact, we have to think about risk, I think, in a much broader sense, that risk of harm can also be risk of deterioration, mental deterioration, physical deterioration, you know, a risk of reputational damage, risk of a risk from others. For example, risk of vulnerability, risk of stigmatisation. So risk is a broad concept, and I think one of the challenges in the EEA and in this situation highlights it, is that there is perhaps an expectation upon police to be able to interpret what a immediate risk of serious harm means in order to activate an involuntary assessment. And that's a challenging process.
With no assistance from the words in the legislation.
With very limited assistance, yes, I'd agree. And having said all of that, I would say that if somebody has a collection of knives, and not just any knives, knives that are used as weapons and are sold online as weapons, and there is information suggesting that they're very unwell, as Mr. Couchy's mother communicated to police, you put those two things together and you might come up with the conclusion that this person's going to present a serious risk of harm to themselves.
If you factor into the matrix the fact that the knives had been removed, so there was no immediate risk of his accessing them and using them, is that part of an appropriate reasoning process for ambulance or police officers to utilise?
I think what it's highlighting is the importance of a collaborative approach to mental health, helping police in that immediate setting about how to interpret that situation.
I want to ask you a little bit more about that, and I apologise to the two other members of the panel to whom I'll return, but since Dr. Heffernan has raised that, there are a number of things which have been taking place in Queensland to assist police to make better informed decisions in these ambiguous and complex situations. Is that right?
Yes.
The liaison service to which you made reference in answer to questions from our learned friend earlier in the day is one of those, and an important component, is it not?
Yes.
That this enables police to make contact with a clinician to get advice and assistance to understand how they might best respond.
Yes, so it enables the real-time exchange of information. Unfortunately, at that time, the service was relatively small.
Yes.
And perhaps there wasn't the understanding across the breadth of the service that it even existed. And so there's an opportunity to increase that knowledge and awareness, and alongside with that, I guess, training around what
What it can
immediate
offer.
risk, self-harm might be
Right.
beyond the explanatory notes.
Yes. Let's go back to the risk issue and then go back to what you've just raised in relation to a service. The issue of risk can be multifaceted, as you've said. It can be risk as is identified in legislation that the person is going to harm themselves, potentially lethally. But it could be that they're going to engage in other forms of disinhibited behaviour, which might harm their reputation or their finances or other aspects of their lives, correct?
Yes.
Or it might be that they may engage in provocative or dangerous behaviour, putting themselves at risk by reason of speeding in a manic way on the roads, or by being provocative toward others and thereby harming them and themselves.
Yes.
So risk on its own is a complex concept, but if anything, the clarification in the legislation as it is right now, the example in the legislation confuses the situation by focusing paramedics and police minds upon risk of suicide rather than other relevant aspects of risk.
I think that's fair.
Okay. In those circumstances, are you aware that Queensland is the only jurisdiction in Australia, so far as we know, which has changed its criteria for detention and transport for assessment from serious and immediate risk, slightly different words are used in different places, to self and others, to only to self? So Queensland's now on its own in this regard.
I was aware of the change and significant change. I wasn't aware that Queensland was the only jurisdiction.
The position of the Queensland Police Force, Police Service, is that it would be advantageous in terms of assisting police members and also ambulance officers to revert to the previous situation and clarify immediacy, risk, and extend it to risk to others. Would you be supportive of a legislative change along those lines?
The balance is that it, and the, for want of a better word, risk of such an expansion is that the provisions of the Public Health Act that have enabled broader spectrum of problems, so illness, disability, injury, intoxication,
yes,
to be involuntarily transported, when combined with risk of harm to others, may actually cast the net
too wide a net.
too wide.
Okay.
So that's the balance.
So, well, there's an obvious answer, isn't there? That is that you walk this provision that back into the Mental Health Act and make this aspect of it mental health specific, so that the message is clear to paramedics and to police officers that if there is the requisite risk to self and others as a result of mental illness, it should be exercised so that the person is taken and assessed by a qualified mental health practitioner.
That might be a good question for the Executive Director of Mental Health, Alcohol and Other Drugs, who I believe is now a party to the proceedings.
Without making things difficult for you, can you see some merit in there being a mental health specific provision in relation to the exercise of coercive powers for assessment for police and ambulance officers?
Yeah,
To avoid the net widening that you referred to.
So that might be a solution to the net widening. It was what was in the previous
Yes.
Mental Health Act.
Yes.
And I understand that there was a lot of consideration by police that actually put them in a challenging position with respect to having to make decisions that were, somewhat approximating clinical decisions. So that was, I think that was some of the feedback which perhaps was influential in the change.
Right. At any rate, the discussion that you and I are having highlights the complexity of the evaluative process. I'm deliberately staying away from diagnostic, but the evaluative process required of both ambulance officers and police faced with a complex situation of a person on a particular occasion in determining whether the requisite risk is made out to exercise coercive powers?
It's a very difficult evaluative process, and it's a very important and significant power to take someone involuntarily to a hospital. And it's, you know, this is why I think it's so important that if we can have all the relevant thinking and information available in that particular interaction in real time, that will really assist those decisions. And that's why I think there's a responsibility for the mental health services, where it's feasibly possible, to actually contribute, either through information sharing or the provision of advice in relation to those decisions.
Okay. You've made reference to the significance of the power to exercise force to take someone for an assessment they may not want. First of all, it takes clinical and police time, and quite a bit of it, on any given occasion to take someone to a hospital for them to be assessed, correct? And secondly, it does constitute the use of force against someone who may well have a mental illness, and that itself can have some counter-therapeutic consequences in terms of their response to police and ambulance officers in the future, correct? And it may also lay a problematic basis for the construction of a positive therapeutic relationship between the individual and clinicians if they've been taken to clinicians through the use of force.
Yes, that's true. It does happen not infrequently, but yes, that's true.
But what it highlights is that it shouldn't be done more often than is absolutely necessary.
Absolutely.
Right. Now, going back to the points that you've made about the liaison service, what you've identified is that it has the potential to enhance decision-making by police in particular, by getting input from experts in the area about questions to ask and issues to identify, people to speak to, things to think through, correct?
Well, perhaps a little bit narrower, more through the provision of information.
Provision of information. Right. And that's going to enable them perhaps to ask some questions of family members or the individual concerned in a better way?
The next iteration is going to enable some assessment in real time by a clinician,
right,
through digital technology.
Yes, that's the future in short.
Yes, the near future.
Right. So again, you would be supportive of both that technological development and implementation, and also sufficient funding to allow it to be utilised at whatever times it's necessary, including in the middle of the night.
Yes, so, well, there is funding that has been allocated to this through the Better Care Together funding, which is the Queensland Mental Health Services Plan, and it does enable, I'm just thinking about the middle of the night, it does enable that to occur to close to midnight.
Trouble is, things happen also at 1 and 2 in the morning, don't they?
They do indeed.
So would you be supportive in principle of an extension of funding to enable that kind of assessment to be undertaken at all hours as necessary?
I would.
Now, we've spoken so far about this Queensland initiative that you're very positive about. Has that been replicated elsewhere in Australia, to your knowledge?
Not in the exact form, and some of it is yet to be rolled out, although it has funding to be rolled out, so not in the exact form. Some of the limitations are funding in other jurisdictions.
Yes.
The database being a statewide database in jurisdictions, the relationship between police and mental health. But my very preliminary and superficial assessment of this is that it is possible to roll this out on a national scale.
And would you, just thinking in terms of recommendations, given that Her Honour is focusing on some issues in Queensland and others in New South Wales, but would you commend to her consideration of the advantages of such a system for New South Wales as well?
I absolutely would, Your Honour, yes.
Thank you. Now, you've made reference also, Doctor, to the co-responder model in Queensland, which is also quite a Queensland-specific initiative that doesn't have direct parallels elsewhere. Is that right?
Similar things in Victoria. And I'm possibly even in New South Wales, but what we're talking about there is different. So it's got clinicians embedded in a call centre. A co-responder model is generally thought of as a clinician, and we'll use police as the example, a clinician and a police officer in a car together going to a particular incident.
Yes. Yeah. There are two models currently operating in Queensland, as I understand it, and please correct me to Her Honour if I get it wrong. But the first model is to have a clinician attending through the ambulance to join police who are already at the scene, and the other model is which is smaller but being introduced in some parts of Queensland, is to have a clinician with a police officer attending first up at a scene. Is that right?
Yeah. So the two models, an ambulance co-responder and a police
co-responder. And they're both comparatively recent, but is it right that that initial evaluations of them have identified real advantages in this health incorporated response by police or others?
So their advantages are that they're a high quality service. So you've got
high quality in terms of the involvement of clinicians.
You've got a clinician there on site. So that's high quality. The disadvantages are that they're a low volume service and geographically limited because you just physically can't get to many jobs in a shift. So that's the big limitation. And so where I would argue that these that these systems work best is when you've got acute care teams working with co-responder teams, working with the collaboration of police and mental health embedded in general services throughout mental health services and a police communications mental health liaison service. So each has its own component and works together synergistically.
And is that the aspiration for Queensland, further development of each one of these three components?
Oh, well, it's my aspiration for Queensland. I'm not sure I could...
I'm not asking you to speak on behalf of others, but do you think it would be constructive for there to be further development and evaluation of each one of these three components of the semi-pilot response being trialled in Queensland at the moment?
Yeah, I think it would. I mean, all these things are expensive. They have, some risks associated with them. But they look like they have the opportunities to bring that collaboration between mental health and police into or mental health and ambulance into a real-time situation, which has always been the sort of rate-limiting step in the past. And what we know is that police in any jurisdiction, no matter which one you go to, we heard in the Royal Commission in Victoria, and we heard similar things in Queensland from the police in Queensland, that the volume of mental health related calls and mental health related incidents has increased dramatically.
And the big advantage of each one of these three components is that it intrudes a clinician response into what might otherwise be a policing-dominated first response.
Yeah, digitally, verbally, or in person,
Yeah.
depending on what's required and how things should be deployed at particular times. And obviously that's an enhancement to the existing acute care systems,
Yes.
which are under a lot of stress.
And have you encountered instances yourself in respect of each one of these components, the three that are in operation already, which have been constructive in terms of enabling an informed and effective intervention?
Very much so. I work in this service most days. I do the clinical reviews every Tuesday, and we see a lot of ability to bridge that gap of communication between what's happening on the street and what the mental health service needs to know.
Yes.
So that's one really important.
So it facilitates information sharing,
Yes.
apart from other things. Yes. And so once again, focusing on the reality that Her Honour is sitting in New South Wales, and I'm going to ask your colleagues if they have any comments on what we've discussed, is consideration of introduction of comparable processes something that you would commend for New South Wales and other jurisdictions for that matter?
Well, yes, it is. And further to that, we've actually had New South Wales Police and New South Wales mental health clinicians come and visit, their service to, take back some ideas about the feasibility of that.
Thank you, Dr. Heffernan. Could I just give your colleagues on the panel an opportunity to make any comments in respect of various matters discussed between myself and Dr. Heffernan? Starting with you, Dr. Nielsen.
I think they were Queensland matters.
Yes.
I didn't follow the details of what's being proposed, so...
But a clinician-led co-response, do you see merit in that in terms of situations of crisis which require attendance of police?
well, generally, sounds like a good idea.
Dr. Arch?
Look, I've forgotten the initial question, to be the truth be known, but in New York, if you ring 911, there's a triage right at the very beginning.
Yes.
And if there's no firearm involved, then the New York Fire Brigade, which is the most trusted organisation rather than the police, go out with mental health workers, because whenever you send police into a situation of there being someone who's mentally ill, there's a possibility that the poor patient will be shot. So I am in favour of there being actually kind of less involvement of police in acute mental health situations in the community.
Or at least more of a clinician involvement.
At least more of a clinician involvement, yeah.
Thank you. And
This has been looked at in a number of different ways over the last few decades, and initially community mental health teams would visit with police on home visits when issues were arising. That fell away with the loss of cover by community mental health teams overall in the communities, just with the defunding and with the loss of services.
Roughly when, Doctor?
Through the past 2 decades.
Right.
Steadily that has occurred. The police, by them, after a number of very public issues in New South Wales, adopted a US model of mental health intervention teams and instituted quite significant efforts to retrain, to train police staff. That was with the assistance. That program is set up with the Schizophrenia Fellowship of New South Wales at the time. And that was a reasonable program, but suffered from a redeployment of priorities and services within the police force. And so, although there is regular training for all police officers, and I'd have to say, in a lot of cases, the police do a very reasonable job, that has not got the same. I'm not sure about the priority of that within the New South Wales Police at the moment, but it would not be as good as a joint response as is suggested by Professor Heffernan. I am aware in New South Wales there has been a number of pilots looking at combined police, ambulance and other service coming together to go out and intervene together. However, that has had the problems of being a pilot and not being rolled into a service. And so these pilots do exist in New South Wales, but they haven't eventuated in a proper service as far as I'm aware.
Worth being looked at further?
Yes.
And what do you make of the proposal in Queensland, which sounds imminent, of the introduction of a virtual clinician into these scenarios through digital technology?
I think it's a pragmatic solution to what is a difficult problem of trying to provide mental health expertise across the whole breadth of New South Wales, and even within metropolitan areas, given the volume of calls that are coming in for the police to handle. So I think it's a reasonable thing. I have another comment in regards to some of your original questions, which centred on the 2023
Yes.
Response by police. Of course, those police did channel their concerns through to a liaison officer.
They did.
And unfortunately, that liaison officer wasn't able
There was an administrative error.
to follow through, and that's a great pity.
But a positive thing for them to have attempted to identify a mental health issue which required follow-up.
Indeed. So even the existence of that regular contact between police and mental health services is a good thing, and needs to be more. Those channels need to be built up, and the capacity issues, which I understand was one of the issues
Yes.
at that particular time, need to be addressed. So I think that would have been that. Although I don't think within New South Wales, I'm certainly not an expert on Queensland law, Mr. Cudgel would have been detainable under the Mental Health Act at that time. It would easily have been a point in time in which contact between mental health services and Mr. Cudgel could have been initiated, and that
Yes.
may have been helpful at that time. The other period of time in which there possibly some interventions could have arisen was when he requested to look at the girls' sporting carnivals, which he did on 2 occasions, a training session and a swimming carnival, which was certainly an unusual request by a member of the general public, and something which did raise concerns, and they were communicated, and that dissipated into nothing at that stage. Again, not something which would have come under the Mental Health Act, but something which may have initiated a query by back to Mr. Council.
Thank you very much. That's helpful. Thank you, Your Honour.
Thank you, Dr. Franklin. Ms. Roth.
Thank you, Honour. Thank you, everyone. For the purposes of these questions, I'm acting for the Chief Psychiatrist of Queensland. Dr. Heffernan, to start with, you were asked some questions about emergency examination authorities and the criteria that apply. And I note that you've set out some information about EEAs in your report.
Yes.
You've helpfully, at point 7, divided up the different options that might have been available to different parties who had contact with Mr. Couchy in the years prior, including police and family. So I'll note that to start with. There are an emergency examination authority, as I understand it, is a pathway to an examination.
Yes.
Which is then a pathway to potentially obtaining a recommendation for assessment.
Yes, so the Emergency Examination Authority is all about assessment.
Yes.
Yes, and then that assessment might occur in the emergency department, usually occurs in the emergency department. It might make its way to mental health, and it might lead to a recommendation and an involuntary treatment.
And to be clear, when you say it's all about assessment, really isn't an emergency examination authority. What it authorises is the transport of a person to a place where they may be assessed.
Yes, yes.
The question of whether or not they're assessed falls to the health practitioner at the other end. not to the person transporting them.
Yes.
So the making of an emergency examination authority does not mean that a person gets assessed,
Yes, of course. Yeah, that's an important point. Yeah.
and it certainly doesn't mean that a recommendation is made that they are placed on involuntary treatment, for instance. It doesn't flow.
It doesn't necessarily follow.
You gave some evidence about the move of the provision that enables first responders to make emergency examination orders to the Public Health Act, and that included removing the focus solely on mental illness to including a mental disturbance, regardless of the provenance of that disturbance.
Yes. So, yeah, I believe the wording is the result of a major disturbance in the person's mental capacity.
Which is then, just to read the rest of that sentence,
Whether caused by illness, disability, injury, intoxication or another reason.
thank you, that's what I was looking for. Thank you very much, Dr. Heffernan. So in those circumstances, what that empowers is someone who isn't a clinician to go, this person doesn't seem very well, I'm not really sure why, but my index of suspicion is sufficiently raised. I'm very concerned they're going to calm themselves, perhaps because they're literally just about to. There might be obvious indicia of that. And I can intervene. I have power to intervene, whereas otherwise I would have no power to intervene.
Yes.
So it enables in effect, a first responder to do something that would otherwise be an assault.
Yes. I think that makes sense.
And that's to prevent, we would understand, one would infer, an emergency, a terrible thing happening then and there.
Yes, so the wording is immediate risk of serious harm. Yep.
And I think Professor Harris has given some evidence that it may have been unlikely that at that particular point in time, so one of the points of time we're talking about is January 2023, that on examination, and I'll use some local terminology here that will get fleshed out elsewhere, and I mean Queensland in that sense, he may not have met the treatment criteria as at January 2023.
Yes, so that's I think that's the part that's sort of open to interpretation, really depending on what you think the risk is and what the serious harm is.
Sure, but just to be clear here, we're now talking about the treatment criteria under the Mental Health Act, which is quite separate to the criterion for being able to exercise the powers under an emergency examination authority under the Public Health Act.
Oh, okay. Sorry, I thought you were talking about the Emergency Examination Authority. No, the treatment criteria of the Mental Health Act are imminent risk to self and others.
And is there another harm criterion in the treatment criteria in addition to risk of harm, as in physical harm to self or others?
Serious deterioration. Physical and mental deterioration.
Right. So it still is needs to be serious and proximate, but it includes a deterioration in mental or physical health, not just the risk of harm to another person, and not just the risk of harm to self.
And of course, there's capacity criteria and mental illness criteria, but.
Of course, but if we're just focusing on the so-called harm criterion, the fact is under the treatment criteria there are two pathways to satisfying that. One is that the person in front of you poses an immediate risk to themselves or others, either of self-harm or of physical injury. And the other that is that without imminent treatment or treatment of their illness, their condition will deteriorate either physically or mentally.
Yes.
And is the latter of those easier to satisfy in most cases where you have someone who you think is frankly psychotic in front of you?
It depends where you practice. In my practice, I see a lot of risk of harm to self and others, but yes, in general terms, that would be, if you've got someone that's psychotic and you think they're on a pathway to evolving further and further and deeper psychosis, then you're able to satisfy that criteria.
And now I'm jumping back a few steps again, but you talked again about some changes in the legislation in Queensland that happened with the introduction of the Mental Health Act 2016. Mm-hmm. Is it fair to say, whilst we're talking now about the ability to force someone into a position where they're examined, there is a focus under the Act, of course, in encouraging people to attend voluntarily?
Well, I think that was one of the principles of the new Mental Health Act, that it really focused on, the rights of the individual, engagement with families, alternatives to using involuntary treatment.
And would you understand that that would be consistent with another piece of legislation in Queensland, which is the Human Rights Act 2019?
Yes.
Now, to come back to point 7 and the sub-points in your statement, one of the options that you highlight as being available to family is the ability to apply for an examination authority.
Yes.
We heard from Inspector Quinlan the other day that that's an option that's also available to Queensland Police. In fact, it's available to anyone. It's available obviously to clinicians, but to persons who have relevant information that would enable that such an application to be brought.
Yes.
You haven't, given Mr Couchy's presentation in January 2023, what do you say about the pathway towards trying to obtain an examination of Mr Couchy that may be obtained by way of an examination authority as opposed to an emergency examination authority, and the assessments or circumstances that they're likely to lead to? Bearing in mind that the emergency examination authority would have been exercised in the early evening in Toowoomba, when I assume would have resulted in Mr Couchy being taken to the emergency department of the Toowoomba Base Hospital. My assumption is that's the option that were available. I'm sure we may hear more from Dr Riley about that later. But do you see there being any particular efficacy either way? Are you likely to get more traction under an examination authority than an emergency examination authority, presenting as Mr Couchy did at that time?
So an examination authority, in my experience, firstly, it enables an involuntary assessment. It needs to be made by the Mental Health Review Tribunal. All efforts to undertake voluntary treatment need to precede it, of course, but it does enable, for example, a concerned family or a concerned significant other to apply after trying to voluntarily access services, to have an individual, if it's supported by the Mental Health Review Tribunal, to have an involuntary assessment. That could have been used in this circumstance. We have to consider the issues of that have come up earlier today about preservation of relationships, and
Yes.
particularly
Yes.
Critical and important relationships, and how that might impact on that decision making, and also that somebody's had 19 years of or at least 18 years of voluntary treatment. These things I think should be weighed into the equation. So it's not a simple equation to justify an examination authority. But if a person appears to be psychotic, and the descriptions of Mrs Couchy were really quite significant and quite concerning, then that would seem to be reasonable grounds to at least make an application.
And do you understand, I think you made the point that an examination authority is something that's made by the Mental Health Review Tribunal. An emergency examination authority, by contrast, is something that's made in effect by a first responder in an emergency.
Yes.
Is it your understanding, or Section 504 of the Mental Health Act 2016 specifies that the risk or harm criteria that apply to an examination authority are both, and this is at 5042D, is or may be an imminent risk because of the person's mental illness of serious harm to the person or someone else, or the person suffering serious mental or physical deterioration. So you note that so the second criteria is picked up there?
Yes.
Do you think it's appropriate that that criterion with respect to the risk of the suffering of a serious mental or physical deterioration is limited to in its application to the MHRT as opposed to first responders? That was very poorly put, and I'll try again. I'll withdraw the question. Something is being made of the distinction. The fact that an EEA cannot be made in circumstances where it can only be made in the circumstances where there's a perception of a serious harm to the person, to the subject, to the person, self-harm. Do you think this criterion in relation to the suffering of serious mental or physical deterioration is something that's best placed in this clinical framework rather than in a first responder framework?
Well, when we talk about first responders, we're talking about quite different things. So ambulance are health trained and police are not health trained. And so I think that's an important distinction. I think what you're talking about is having an ability to understand what might lead to a physical or mental deterioration, and that's not necessarily a simple thing, and it's particularly not simple when it comes to issues of psychosis. So, for example, I've seen on many occasions police being called somewhere because someone believes a person's in the roof or is moving objects around the house, and it would seem evidently apparent to a clinician that that person's psychotic, but because they don't say, I'm wanting to harm myself or I'm wanting to harm others, then it's difficult for the police to enact an EEA. With appropriate training and with a collaboration between, and I'm using police here specifically because ambulance have health training,
yes.
With a collaboration between health and mental health, then that criteria would be of more benefit.
Yes.
Sorry.
No, please.
I was just raising to find out timings. I think Mr Lynch has about 10 minutes and Ms Martwa has about 10 minutes. So,
No, not bad.
Are you nearly...
I am.
Thanks very much, Ms Robb. Now, would you like a short break?
Oh, could I just finish? Your
Yes.
Honour? I'm very nearly finished. Really, just the short point is then to establish that there's more than one pathway to obtaining an assessment for an unwell person who's otherwise not connected with the mental health system in Queensland.
Yes, I agree with that.
Thank you.
5-minute break?
I'm okay, thanks, Your Honour.
Oh, okay.
I'm okay.
We'll continue then. Mr Wilson.
I've got no questions. Thank you.
Mr Lynch.
Thank you, Your Honour. Professors, based on the My Mind assessments that were conducted by the several psychiatrists at the My Mind Centre, including Dr Boris Levac and the credentialed mental health nurses, Mr Couchy, in their assessments, never reached the threshold for involuntary treatment under the legislation then applicable. You agree with that?
Yes.
Yes.
In as much as I understand the Queensland.
Yes. Professor Large, do you agree?
I don't think he got near it.
And in those circumstances, there was no option open to those treating Joel Couchy between 2012 and 2020 when the treatment ceased, but to accept his decisions as to whether or not he would take or not take any recommended antipsychotic medication. Do you agree with that, Professor Nielsen?
Yes, I do. Yeah, whether or not greater attempts could have been made to persuade him, based on long association, is another matter. But in answer to your question, the answer is yes.
Professor Heffernan?
The answer is yes. I think that he hadn't reached the threshold for an involuntary assessment. However, I do note that the examination authority, which can be taken out by a psychiatrist, part of the Mental Health Act in Queensland, which we were just talking about, does have a criteria about concerns about further mental deterioration. So that would be in the spectrum of options, but I think that really the principles of the Mental Health Act are voluntary assessment is what we're shooting for every time, And so I don't think there was a time in the care with Dr. Boris Levach that the involuntary criteria had been met.
Thank you. Professor Harris?
I agree that Dr. Boris Levach would have had to have gone along with Mr. Couch's wish to continue to decrease and stop the medication. However, it would have been reasonable to have demonstrated a greater effort to try and institute subsequent aripiprazole or brexpiprazole when she thought that that may have been warranted. However, I don't think that could have been enforced in any sort of involuntary way.
Professor Large?
He was a voluntary patient.
Sorry, what was?
He was a voluntary patient.
Thanks.
Couldn't have been made involuntary.
In those circumstances, his autonomy had to be respected.
Yes.
You agree?
Yes.
Is it reasonable to expect that mental health experts, experienced psychiatrists and credentialed mental health nurses should substitute their own direct assessments of a patient with the feelings or observations of a patient's mother? And I'm referring in this case to Mrs. Couchy and her observations in November 2019. Is it let me put it this way, you would expect competent psychiatrists and clinicians to take into account seriously the feelings and observations of a close relative like Mrs. Couchy. Agreed?
Yes.
Yes.
Would you expect clinicians of experience and competence to replace their own clinical assessments as to whether there's been a relapse of psychosis or not with the feelings and observations of a close relative, such as Mrs. Couchy?
No.
I think it's reasonable that that the clinicians should have taken on board the observations of the mother and have been more suspicious and to have looked at the evidence that she was presenting at that time.
Yeah, and similarly, I think that in any assessment you have to triangulate your data, which means you have a piece of information, which is your own assessment, and then you have other pieces of information, and that will include a past history, and it will also include the collateral information you obtain from other sources. I don't think we should underestimate how important that collateral information was, and so I think it would be reasonable to combine that information with your assessment and inquire along along the lines with an element of suspicion about relapse.
Thank you. Professor Nielsen?
Yeah, I agree with both with all my colleagues there. I mean, you want to have a look at a person's longitudinal care rather than a snapshot assessment, and have a higher index of suspicion with that kind of collateral information, that's for sure.
Looking at the longitudinal care that the My Mind Centre provided to Mr. Couchy over the period 2012 to 2020, would you expect the clinicians who saw him, including Dr. Boris Levach, I think at least 2 other psychiatrists and several experienced mental health nurses, to form a capacity to well understand if their patient who they'd seen jointly over several, I think at least 24 times on average a year over the 8 years, so more than 100 consultations between them, do you think they would have the capacity to identify whether Mr. Couchy was masking his symptoms, if he was suffering symptoms of relapse into psychosis?
Yes, I would imagine so. I imagine they'd be quite tuned to change, especially having made the change of stopping medication. They'd be pretty suspicious and looking closely for
Professor
signs of
Hepburn, do you agree?
I'd agree that they're in a very good position to make those determinations. One variable that does impact is the quality of that assessment. So the time you get with a person, their willingness to engage with you, and their willingness to share information. And that's why it's so important to triangulate your data to see whether what you're seeing in front of you is the whole picture.
Professor Harris?
They were in a very good position and they had a great deal of experience. They also were very keen for Mr. Couchy to get on with his life, which may have been made more problematic by a relapse. But they were certainly in the best position.
Professor Large?
So just one back to the former question, you said replace, whether clinical judgment should be replaced by corroborative history, and I just think the answer to that is straightforwardly no, it shouldn't be replaced. It should be supplemented perhaps, but not replaced. I think they were in a very good position to assess his mental state, and I don't think there's any evidence that actually that it was assessed incorrectly.
Do you consider that the treatment provided by Dr. Boris Levac and the My Mind Centre staff met the accepted standards of applicable to private psychiatrists throughout the period of 2012 to 2020? Professor Nielsen?
I believe so. I mean, it was exemplary. It was above and beyond, really, up until the end. It was just the handover of care was there were some shortcomings there.
Professor Heffernan?
No, I agree. I mean, I think there was really good care for 7, 8 years. Of maths is poor at the moment, but I think that the majority of the care was really well managed. The one area that I think could have been improved was that discharge handover.
Professor Harris?
I agree.
Professor Large?
I think it was well within the acceptable standard of care.
Thank you. Professors?
Ms Matua.
Yes, I'll be brief. Can I ask that Dr. Hester Wilson's report be drawn up? Doctors and professors, I'm drawing your attention to a peer review expert, Dr. Hester Wilson, who has provided a report in this inquest for the state coroner's benefit, and it's at page 22 of the brief or 21 of her report. We've heard there's been a number of discussions in relation to persuading a patient to engage and/or missed opportunities, and I wanted to draw your attention to lines 515 through to 522, where Dr. Hester Wilson gives this opinion. It is important to allow people autonomy to manage their own lives, medical conditions and medications. At the same time, we need a system that can respond appropriately when a person becomes unwell and potentially a risk to themselves or others. The intersection between autonomy, his human right to self-determination and compulsory treatment is controversial. While Mr. Couchy was noted to be very odd to deal with by staff from the fertility clinic, his mother expressed concerns regarding his stability in late 2019, and he was noted to have poor eye contact with poverty of thought or guarded with restricted affect by Dr. Sarkar. He was not unwell enough to be detained under a jurisdictional mental health act. I understand your collective unanimous opinions to be in agreement, firstly with the last statement, that prior to the unfortunate tragedies in April of last year, there was not an indication for him to be detained under a jurisdictional mental health act. Is that correct?
Yes.
Yes.
And is
Well,
that...
apart from the January 23 consultations, the other ones weren't of sufficient detail to identify grounds, but on that occasion, I believe he could well have been taken for an assessment.
Taken for assessment, but not necessarily detention as an involuntary patient.
Again, that would have been for the person performing the assessment to adjudicate with all the information available to that doctor.
And you're referring to a point in time where he's seen by 2 police officers on the 8th of January 2023 outside of his home?
Correct. When sufficient information emerged that would have met criteria for involuntary treatment.
But is it correct, is there a unanimous view amongst you that one of the principles of caring for a man who has schizophrenia or any patient with schizophrenia, including general practitioners, is to always be mindful of that person's autonomy and their human rights.
Yes.
Yes.
Can I now move from that and draw up Dr. Nielsen's report? And I'm commencing with you, Dr. Nielsen, because it's a matter you in fact raised in your report, and it's in the final 2 paragraphs of your report, tab 10. And it's where you give an opinion, which you have also in your sworn evidence, with respect to a personal opinion held by you that a person with a mental illness such as Mr. Couchy's should not be permitted to have access to firearms.
Yes.
Now, I note that your signature has the initials FRANZCP, namely that is short for a Fellow of the Royal Australian and New Zealand College of Psychiatrists.
Yes.
And I did note that the other panel members are also all Fellows of the College, correct?
Yep.
Dr. Nielsen, I'll start with you. When you gave that, and I'm just going to call it a personal opinion at the moment, when you gave that personal professional opinion, were you aware of the fact that the college, namely, is it correct to define them as the peak body for psychiatrists in Australia?
The union? No, it's not the union. it's actually it's the body that approves the people's qualifications.
Yes.
Their training. That's the main function of it.
Peak body, reputable body.
Yes.
When you wrote your report and gave that opinion both in paragraph 156 and then in paragraph 157, where you say again that in your opinion people with that condition, namely schizophrenia, should not have access to firearms, were you aware of the existence of a professional practice guideline 23 titled Firearm Risk Assessments, published by the college?
No, I just saw that for the very first time in Dr. Heffernan's papers. I was shown an earlier draft, which I sent a very strong dissenting opinion. The whole idea that psychiatrists could do snapshot assessments and say that you're fit forever for a firearm just seemed very troubling. And what's come out looks very different. I haven't read it in detail yet. Looks very different to the draft I was shown, but it still doesn't, it still doesn't meet my. It still suggests that psychiatrists are the guys to do it, which is troubling.
Yeah, so I mean, implicit in the guideline is the fact that on a case-by-case basis, a psychiatrist is permitted to make an assessment with respect to not lifelong access to firearms, but individual case scenarios with respect to firearms. Do you agree? That's implicit in the existence of the guideline.
Yes.
I noted that each of the other members of the panel have also expressed an opinion against access to firearms for people with schizophrenia in your oral evidence today. Professor Large is desperate to say something.
I don't think my opinion should be taken very seriously, because I don't believe there are any culinary reasons why a person should own a long pointed knife of any sort, and I don't believe there are any reasons why an Australian citizen should have access to a firearm, and I also don't believe that there should be specific legislation singling out people with mental illness. I think that puts us in conflict with the United Nations Convention on the Rights of People with Disabilities. So I think I'm sort of out of this a little bit.
Well, only in that the college does provide for members with your opinion, namely that the guideline itself states that if you have a strong ethical biases, you should refer the person to another suitably trained psychiatrist for the assessment.
I have done that.
So can I ask this, given that the peak body, your college, puts out a guideline, would it be fair to say that the state coroner should approach her task with respect to this issue by complete deference to the college's guideline as compared to each of your individual views with respect to the appropriateness of a person with schizophrenia having access to firearms in whatever circumstances, be that supervised or unsupervised?
Well, not at all, because if firearms had been acquired, this could be so much worse. And the purpose for getting it, he was already searching for, you know, serial killer kind of situations, or mass killing kind of situations in 2022. You can perhaps infer that these ideas were present before that, and it would have been so much worse. And that college position was written by, you know, like a handful of our colleagues, not by us, and people who make a living from doing these assessments as well, you know, which again is a conflict of interest. So I really don't. I think it's quite well within the ambit of this inquiry to consider the public safety that might be affected by people with unstable mental illness owning guns.
So your position, do the other members of the panel, do you share the same position as Dr. Nielsen, that there shouldn't be a deference to the current guideline, and it should be, if the state coroner chooses to do so, there should be a questioning or re-examination of the appropriateness of firearms in the possession of a person with schizophrenia?
Can I just clarify?
Can I object at this stage, Your Honour? It's common for this court to make suggestions as to amendments of the guidelines, including that are put out by various colleges. So there's nothing unusual with an expert expressing a view that a guideline should be amended.
That's true.
With respect.
And I'm inviting them to put their position clearly so Your Honour is best informed. Professor Heffernan.
Oh, no, I was just going to say, I think you missed an important term, which was the term treatment refractory. Schizophrenia, or treatment resistant, schizophrenia. So that's an important qualifier, and you know, by definition, you know, that's going to be a person that's got symptoms and that's unwell. But that it's not a dichotomous question, because it doesn't exclude that person from having an assessment, and the assessment should consider: does this person have treatment resistant schizophrenia? That's part of the assessment. As you heard today, there can be actually differences of opinion about whether somebody has treatment-resistant schizophrenia or not. And what this guideline actually requires is that all available information, history, is taken into account. And so I don't think they're mutually exclusive issues.
Only that your opinions as expressed were more global, in the sense that you held a belief, in just looking at your opinion, Professor Heffernan, that a person with treatment-resistant schizophrenia should not.
Yeah, so if a person's got treatment-resistant schizophrenia, they're going to have symptoms, and those symptoms are going to include at times positive symptoms. They're going to include negative symptoms, and they're going to include cognitive deficits. And as we discussed earlier in the day, that also includes impacts on organisation, abstraction, planning, and these are all things that can impact on decision making. And when it comes to firearms, the risk with weapons and firearms in particular is really significant.
And they also have relapse, correct? So remission, there'll also be periods of remission, which this guideline provides for, correct?
Yeah, that's why I think, you know, really it's very important to be clear about what we're talking about, and that does require a thorough assessment.
And it's fair to say, in relation to the psychiatrist who assessed Mr. Cauchi in January of 2021 in relation to his request for access to a firearm only within a pistol club under supervision, it's correct to say at that point in time the college had no guidance or guideline in place to assist a practitioner in those circumstances? Assume this is the first, it came out in September 2023.
I'm actually not sure about that.
I can't remember any previous one.
Dr. Large, do you recall, Professor Large?
I'm not aware of any guideline.
Sorry?
I'm not aware of any guidelines, but the general expectation that a psychiatrist can, tell what a person's going to do with a firearm is overplaying the extent of psychiatric knowledge. So I know that's not what the current guideline or the task that's set to us is, but I think I've expressed my view that it's actually psychiatry is better off out of this.
Well, the guideline does in fact say that there's an issue with psychiatrists making assessments on whether a person is a fit and proper person. Dr. Harris, was there anything else?
No, I haven't read this guideline, so I don't think I'm in position to comment.
Thank you. Nothing further, Your Honour.
Thank you. Court 2, does anyone have any questions for our experts?
Yes, Your Honour, just briefly, thank you. And I do seek to keep it as brief as I can. I appreciate the late hour. My name is Sophie Callan. I appear on behalf of the New South Wales Commissioner of Police. Professors and Doctor, to the extent that in your evidence you've offered a view about how first responders might benefit from mental health practitioners, such as a co-responder model, can I firstly ask, have any of you personally been involved in the delivery of assistance to first responders, for instance, through a co-responder model?
No.
Yes.
In the past with in a community mental health setting, yes.
So I'm a former director of psychiatry in the eastern suburbs of Sydney, and we, in some of the police districts, have had a PACER model, which stands for, I'm not sure, police and ambulance. I can't remember exactly what it stands for.
Clinical early response.
Clinical early response. So we've had it in
Yes.
some of our police areas, but not others.
So is it correct to say that having regard to your instances of personal experience or not with those models, you're otherwise offering these views drawn from your experience with respect to the treatment of mental health in the community?
Yes.
Okay. It seems, if I can draw it together, that you've collectively offered a compelling series of points which certainly favour the involvement of mental health practitioners as early as possible in relation to a person in mental health crisis. Would that be correct?
Yes.
Yes, yes.
And it also seems, and I don't want to put words into your mouth, that you seem to favour a response to a person in mental health crisis which would not necessarily involve a police officer unless that was warranted. For instance, there was an investigation of a crime at play, or in respect of the protection of people where there was a real or immediate risk to life. Is that right?
That's my position.
Well, I do think we have to be careful about that because, there is a model in the UK, I think it's the right care, right person.
Right person, yes.
Yeah. Which has been really, taken on that model of expecting health and social services to respond to acute mental health crisis situations that don't have imminent risk involved in them, which has saved many, many, many police hours, which of course that's a good thing. But some of the emerging evidence from this model also suggests that it is very tricky to get the boundaries, and there have been a number of coronials that have identified that the absence of having a police response led to a risk situation that contributed to a bad outcome. So I think the principle, and also I think we have to be clear about what you mean by co-responder. So a co-response is essentially anything that involves a mental health and police, and I'm just using the police models here for ease of discussion, but mental health and police working together. And that can be electronically, that can be through call centres, and that can also be on the ground in cars. And so they're all co-response models. They're just different types of co-response model. Sorry, I just wanted to to clarify that point.
Not at all, but it sounds as though your point is that there must be care taken with respect to what the model is seeking to achieve, and then its practical application as to where to draw those boundaries.
Absolute caution about those boundaries, because any implementation of new situations often tests the boundaries, and we learn by mistakes. And so if we've got an opportunity to review evidence and look at other countries' experiences of different models, that's worth doing so that we can try and get the balance right here in Australia.
And does it follow then that those instances you've referred to that you're aware of where the right person, right care model may have been at play in a situation which ended up with a bad outcome, it doesn't follow that the model is necessarily to be put to one side, but rather may warrant finessing or appropriate training delivered so that those risk assessments can be calibrated appropriately.
Well, that's right, and we have to be careful about, and I'm sorry to use this phrase, but I think it captures it clearly, is that we have to be careful about throwing the baby out with the bathwater, in terms of losing the gold that we have in that police mental health collaboration.
Yes. Thank you very much. Those are my questions.
Dr. Dwyer, anything arising?
At this late stage, thank you.
I would like to say a very big thank you to Professors Nilsson, Heffernan, Harris and Large. You've been sitting there for over 8 hours now, answering questions and putting your mind to these incredibly important issues. And this is after writing the reports, as I've said, in a very short turnaround time. I'm immensely grateful to all of you. It's been so important to have your input into this inquest. Thank you.
Thank you very much.
Your Honour, might I note that they are not off the hook yet because they have each of them agreed to assist in relation to draft recommendations that will be circulated.
Thank you. Yes, all free to go. I'm not going to keep you here any longer.
Detain you on the way.
It could be a part of it, yeah.
Your Honour, might I just clarify any confusion in relation to the non-publication order issue? With the completion of that panel, so that evidence can be put in context, there is that now will result in an expiry of the interim non-publication order in relation to the name of Dr. Boros-Levark, Dr. Parker, and the My Mind nurses. After we rise, we start again tomorrow, again with 2 panels, but we commence at 10 a.m. tomorrow. Those are the most matters.
Thanks very much for your patience, everyone. 10 o'clock tomorrow.
Silence, please all stand. Court is now adjourned.